Rocket is sending data to LinkedIn, TikTok. Good morning. Happy World Sickle Cell Day. If you are already tuned in, and I'm gonna go ahead and go live on Instagram, which is our biggest platform. So, all right. It looks like
All right.
somebody's joined. Okay, it looks like there's a few people joining. Good morning. Good morning, everybody. It's World Sickle Cell Day. It's our second birthday, what I like to call our second birthday. I am so happy to be here today, and I have some very, very special guests that I cannot wait to introduce you to. But first, feel free to go ahead and drop in your questions. All the experts I have on for today, they are like top notch. So give us your hardest questions and let's see if we can stump them today. And first of all, I'd like to introduce our medical director. You guys know him. This is Dr. Keith Carrillo. He is here to, I guess, provide us moral support for World Sickle Cell Day and then also answer some of your questions. I also have another expert that I'm so excited to introduce you all to. This is Dr. Vivian Sheehan. I've known Dr. Sheehan for a couple years now, and she is one of the smartest people that I know, and that says a lot, just with this whole panel of experts, right? And um, Dr. Sheehan, you took the time to break down such complex topics surrounding research and sickle cell mouse models and all of that. And so I can't wait to see what questions we get for today. So I'm going to go ahead and read Dr. Sheehan's bio and then we will get started. Please feel free to submit any questions you have. I see here already our first question, so that is perfect. So, a little bit about Dr. Sheehan. She is a professor of pediatrics. And let me know, Dr. Sheehan, please, if any of this information is incorrect, you'll correct me. She is a professor of pediatrics at Emory University School of Medicine and the director of Translational Sickle Cell Disease Research. Her lab uses omics, mouse models, and red cell function assays to develop novel therapies for individuals living with sickle cell disease, with a research focus spanning fetal hemoglobin regulation, gene therapy, and red cell rheology. Very, very interesting. She cares for patients across the lifespan and is dedicated to advancing both disease modifying and curative or um, transformative therapies for sickle cell disease. Did I get that right, Dr.
Perfect.
Sheehan?
Thank you.
Yeah. Okay. Wonderful. Wonderful. All right. So we have a couple questions here. Our very first question, Dr. Sheehan, now that there's a cure, where do you see research going?
Yeah, so I would say that a successful allogeneic bone marrow transplant from a brother or sister is a cure, and that gene therapy is a transformative therapy.
Mm,
My lab is the reference lab for some of the gene therapy trials, and I've looked at the blood of folks who've had the FDA approved gene therapies, Casgevy and Lyfgenia. And they still have some residual abnormalities that you would see in somebody with sickle cell. Their red cells can sickle under very low oxygen. They still are somewhat stiff. They're much better than they started out, and they're better than we can get people with hydroxyurea, typically, even the youngest best responders. So I don't mean to say it's not a wonderful thing, but I do also want to caution that it is not quite a cure, but it's durable, it's transformative, and most patients really have an amazing change to their lives, and Jimmy will talk more about that. And there really isn't a where do we go now because sadly gene therapy has been provided to so few people, about 100 in the US of one strategy and about 100 of the other, talking about the FDA approved ones. And
Yeah.
there are ongoing clinical trials of strategies that may be better, but still not completely correcting the red cell. And I know this because I'm sent the blood of the subjects before they get their edited cells and then after. Um, so here in Atlanta, we've got the largest sickle cell population in the US, and we're just starting to provide this for patients. There have been delays with getting Medicaid approval, getting your site approved, and so we have a long list of families interested. I'm talking about on the pediatric side, we're even further away on the adult side, and we can maybe do 10 or 12 a year maximum. And so I just need to explain that we will never be able to scale up this ex vivo gene therapy to meet the need.
Mm.
But we can really improve the lives of those small numbers that we can treat across the country. And I hope for it to scale up, but there are so many limitations within the healthcare system. There's so many doctors and nurses and just um, places to do this that are needed and need to grow for this to happen. And a lot of hospitals are sort of landlocked and can't give more space to this. So it's unfortunately going to be a niche treatment for the foreseeable future.
Mm. So what I'm hearing is, the question specifically used the word cure, and um, a lot of times when people are thinking cure, they're thinking gene therapy, but you're saying the true cure would be stem cell transplant, and then we would bucket gene therapy within another bucket, which is called transformative therapies.
Yes. And the limitations to the cure, a allogeneic transplant, cells from somebody else, usually a brother or sister, but could be a haploidentical transplant from a parent as well. The limitations are similar in that you just don't have big enough transplant centers and enough transplant doctors, but also a limitation of having the appropriate donor. So brother sister is ideal with amazing outcomes, but only about 1 in 10 people have a matched sibling. I like to tell families it's like flipping a coin 10 times and getting heads every time to the likelihood of your brother or sister matching you because they have to match you at 10 different places. Um,
Oh, wow.
and the results of haploidentical transplants where you're only a half match, but it's still a related person like a mother or father are getting much better, but there's still the risk of rejection and graft versus host disease where the cells look at you as foreign and attack you, and that can be quite devastating. So understandably, some people are not willing to risk that. And that does make gene therapy more appealing because your own cells edited cannot attack you.
Yeah. So taking a step back and looking at research, I feel like it's a very interesting time for research. And there's a lot of different ways researchers are looking at tackling sickle cell. And some of them are, through one-time options, and some of them are through disease-modifying therapies or, something, a therapy that's reoccurring. Could you talk about, I guess, in a patient-friendly way, because this gets very, very technical, what some of those approaches are? I know first, right off the bat, fetal hemoglobin is huge within research right now, but are there any other approaches that we're looking at to
Yeah.
lessen the disease burden for sickle cell?
Yeah. Well, even within fetal hemoglobin, it's not just hydroxyurea. So
Mm.
there is a drug in clinical trials from Novo Nordisk called NDEC, which I would classify as a little bit of an older strategy. Again, it's using a kind of a chemotherapy drug, decitabine, to turn fetal hemoglobin on. I was just at a what I call the European ASH, EHA, in Stockholm, and they presented data on that. But I'm more excited about some of the newer strategies for turning on fetal hemoglobin, like Novartis and Bristol Myers Squibb both have a protein degrader. And that may sound weird and scary, but it's targeted to proteins that repress fetal hemoglobin, that turn it off. fetal hemoglobin is being made in all of us right now. We sometimes don't think about it. Even me, I don't have sickle cell, but I am making fetal hemoglobin right now. It's just that as my cells mature in my bone marrow, a protein called BCL11A shuts it down because it doesn't want it to come out, my cells to come out with fetal hemoglobin still turned on. That would only be wanted if I was a baby, a fetus. So this drug strategy degrades that repressor, and it's kind of a lot like gene therapy, actually, the Casgevy approach, which reduces your ability to produce that same repressor, BCL11A. So it's a drug and it's not permanent, but it's attacking the same thing, the thing that turns off fetal hemoglobin, so that when a red cell emerges from your bone marrow, it's going to have a lot of fetal hemoglobin turned on, like 60% is what has been estimated from some early trials of the Bristol Myers Squibb or BMS drug. So I'm excited about that, but of course we have to look for safety, and it's a little bit of a finding that sweet spot, that Goldilocks of not too much fetal hemoglobin and not too little. And I like that a drug can better be titrated versus a gene therapy where once it's done, it's done. You know, Casgevy gets 40% fetal hemoglobin, and there really isn't a way to change that after you've given the person the cells. And it's consistent across all the patients. Whereas I think with BMS and Novartis's drug, you can find that sweet spot, which some folks think is 50%. Sometimes there's concerns about punching up fetal hemoglobin too high because it does hold on to oxygen more tightly than normal hemoglobin and certainly more than sickle hemoglobin. And we want to make sure that we don't just, hold on to oxygen really well, but can offload it where it's needed in the brain, throughout the body. So everything's a little more complicated than it sounds at first. At first it's like, yeah, more fetal hemoglobin, good, good, but then there may be a tipping point, and so we have to be watching for that.
Is there a sweet spot for fetal hemoglobin?
I think it's 50% personally, but Beam's gene therapy strategy is getting 60%, and the patients seem to be doing wonderfully, not having pain. The cell quality looks really good. I measure that in my lab. But the hemoglobins are higher than one would expect. And so that leads to, the question of um, is the fetal hemoglobin holding on so tightly to oxygen that the kidneys start to think, ooh, we're not getting enough oxygen. We need to make more hemoglobin, kind of a polycythemia, secondary polycythemia, like what smokers get, for example. And the adult hematologists, are nodding at this, because we
Wait,
see
what
it.
is polycythemia?
Polycythemia, too many red cells, too high of a hemoglobin.
Okay,
Yeah,
okay.
poly like many, and yeah, the cythemia part I guess isn't super clear, but yeah. So when your hemoglobin starts to rise above like 16, 17, even 18, that can happen as a result of genetic mutations and with nothing to do with sickle cell, or it can happen in people who smoke so much that their kidneys are getting that hypoxia signal. And the solution of the body is like, oh, I'll just make more red cells. But that's not like a great solution, because then your blood can get too thick and viscous and actually start moving more slowly. And that becomes a problem because then you're not getting the oxygen moving, which the red cells are supposed to be carrying. So
Got it.
there's such a thing as too much of a good thing. Too much fetal, too much total hemoglobin, so we have to be sure that we're not overdoing it.
Everything in moderation, right?
Like it, yes. Well, the old saying, like the difference between a drug and a poison is the dose. Yeah.
Is the dose?
Is the dose.
Okay, I
Yeah.
haven't heard that one. Okay, I love
Well,
that.
Keith and I are old enough, we know these.
I have a question actually. What does this mean during pregnancy if people
Yeah, well,
are
that's the whole reason why fetal hemoglobin has such good oxygen affinity. It was so the fetus could outcompete the mother. It had a purpose, and not every organism makes fetal hemoglobin. Mice don't, which is kind of annoying to us with our sickle mouse model. We're like, darn it, you can put a gamma globin gene in there, but it doesn't really work the way it would in an animal that's supposed to make fetal hemoglobin. So sheep and up in complexity make fetal hemoglobin. And it's probably because as an animal gets bigger and more complex, it starts to become an issue. How does the fetus get enough oxygen? And so the solution, the evolutionary solution, was to make this other hemoglobin, fetal hemoglobin, and make it be able to hold on to oxygen just a little bit better. And so the fetus gets what it needs.
So if the mother's fetal hemoglobin is like you say 50%, how does that
Yeah.
translate? Would you have to lower that
This
during
has been a
pregnancy?
debate. Like, can a woman with very high hemoglobin, whether it's from gene therapy or from natural mutations, have a successful pregnancy? And I personally have not seen the data saying that, but at meetings, other people have said, "Oh yes, it happens." Because there's some beta thalassemia patients with extremely high fetal hemoglobin just because their bodies can't make anything else because their beta globin genes have been knocked out. So I think it's possible, but I don't think we know enough fully about the ramifications. Maybe, the fetal hemoglobin strategy is helpful, but not essential, not necessary. But yeah, that's another area to get more information on.
I do have a question, and y'all are shy, so please put your questions in the chat. A lot of times the audience likes to just listen and learn as well, and that's kind of where I'm coming from at this point. But can you can you get too many blood transfusions? Because for a while I have been getting them every 2 weeks. Now I get them every 4 weeks.
Wow. So I would be curious to know a little bit more about why they were every 2 weeks, because that's kind of unusual. Sometimes
Is that
some
frequent?
that frequent and good. It sounds like it was a planned thing. And my guess would be some people still keep making their own sickle red cells despite transfusion. It's not the most common thing, but it happens. And so we're trying to get the sickle percentage down to 30%, but the person keeps making their own cells. And so we're like having to transfuse more frequently to try to maintain that percentage, suppress the sickle. Um, and I would also be curious about whether this was a simple transfusion, just like blood on top of your blood, or whether it was an exchange transfusion where you're kind of on that dialysis circuit and your cells are taken off and the new cells are given, the healthy donor cells are given, because that kind of changes the answer. Um, there are risks to frequent transfusions. Your body is a iron storing machine because most people need more iron. And so when you're given blood, every time you're given blood, that's a ton of iron right there. And it's a very absorbable kind of iron. So your body's like, oh yeah, I got to keep this iron. And there is no way for you to get rid of iron naturally. So it starts to build up first in your liver, then around your heart, and even sometimes going to your pancreas. And so in some severe cases, you get both liver damage. You may develop diabetes because you've poisoned your pancreas with the iron. This is more often seen in like diamond blackfan anemia, where people are transfused from a very young age. And the cardiac buildup is more common in thalassemia than in sickle. But these are all possible things, and it has long-reaching effects because as the iron builds up in the liver, it can definitely damage your liver. It can make getting a gene therapy or transplant harder down the road. And also every time you're transfused, there is a chance that you might react against that donor blood, develop antibodies against that donor blood called alloimmunization, and then it becomes really hard to find a unit for you. Doesn't sound like that's happened, and that's a good thing. If you've had about 10 transfusions and that hasn't happened, it's unlikely it is going to happen. But that's an area of research in my lab, trying to understand why some people develop antibodies against donor blood, even though we do our very best to match, even more than we do for most people. So I would mostly worry about iron overload. And
Yeah.
I would hope that if you've had more than 10 transfusions, folks are checking your iron levels, your ferritin levels, maybe your liver iron levels through a ferroscan, which is a special MRI. And if it's found to be high, giving you an iron chelator. It's a drug that binds up iron and allows you to remove it from your body. There's no other way to get iron off your body than that.
This person did follow up and say my doctor said my blood count was too low and it was a regular transfusion. I've
Yeah.
been getting them more now, the past year off and on.
Yeah, so I would definitely worry because that means it's not a giving and taking off that helps
Yeah.
take away some of the extra iron, although it's not perfect. Um, So I would definitely make sure you're on a chelator, like X-Jade is a common one that's oral, and that folks are watching your iron levels, your ferritin levels, and your liver function. And there I have a lot of other questions about why is the blood level low, and I worry sometimes that people get transfused for a number, and you should never be transfused for a number. You should be transfused for how you feel, what your vital signs are showing. So
Yeah.
some people may walk around at 6.5 and they're not tachycardic and they're not fatigued, and so continually giving them blood with the complication risks I talked about to get them to a number you feel comfortable with is concerning to me.
That's interesting because I never thought of it in that way. I definitely thought of it as like, you want to increase your hemoglobin as opposed to, and of course, how you feel as well, which I feel
Yeah,
like was a natural correlation, but it sounds like it is not necessarily a natural correlation.
yeah.
So it's you're saying some people are walking around with a 6.5
Yeah,
hemoglobin and feel fine.
I remember being at ASH and seeing this poster from a group in Jamaica, and the hemoglobins were all in that range. I was like, why? What
Mm,
is going on here? And they're like, that's
interesting.
what our patients live at, and they are functional there. So nobody was artificially saying, well, I think you should be 8, and I'm going to make you 8 no matter what it takes. They were looking at it more holistically as, are you functional? Is your heart rate having to be so high because, you can't tolerate that level of hemoglobin, or does that seem fine to you and your system and your body?
Yeah.
And that's something hematologists say a lot, don't transfuse a number, look at the patient, look at the vital signs, look at the retic count, but I would be curious to know, like, is this a production problem? Like some people with sickle cell, as they get older, their bone marrow stops working as well. And even though they're very anemic, they don't have a high retic count. Or is this a high hemolysis, high retic count situation? And there are some drugs in clinical trials that could potentially be helpful there.
Okay. So this person says I have always their hemoglobin is always around 7 all their life, so that's their
Mhm.
baseline. But the doctor I have now wants it to be up, so that's why lately I've been at a 9 or a 10. So to
That's too
what doctors,
much. Yeah, I have
yeah,
concerns. I don't mean to, get into other folks' business, but if you've been 7 your whole life, you should not arbitrarily have someone decide you're supposed to be 9 or 10. And 9 and 10 is really high for somebody with sickle cell. And if you need to be transfused every 2 weeks to achieve that, that's clearly excessive. And so I would encourage a discussion about that. Um, and, I'd be curious to know the level of sickle cell expertise of the physician versus more general hematology, because that's maybe a goal for somebody who does not have sickle cell, or there may be other parts of your history that I'm not aware of, like some
yeah,
cardiovascular issues that make it such that they think you should be higher. But from what I'm hearing, that seems like a very hard goal to achieve and may come with a high cost of iron overload. And so I really hope you're on a chelator if that is the plan.
yeah. Um, yeah, that's very interesting. Just kind of coming from my experience, I have been probably baseline around 8. And I feel every bit of the 8 or every bit of um but then some days I feel good at my 8 and some days I don't. And so I always thought, oh, I need to have a higher hemoglobin. And I used to be on therapy that a lot of these therapies the endpoints are to raise hemoglobin by a gram or yeah, a gram.
Usually it's a gram, yeah.
Yeah. But it sounds like that's
Yeah.
how you're feeling outside of clinic or how you're feeling outside of those particular labs is obviously more important. And so can you maybe discuss the limitations of having an endpoint like that in research?
Well, that's been a big debate with Oxbryta, now with mitapivat, etavopivat. These are all medications that were intended to raise hemoglobin by allowing the red cell to live longer. And that's a positive thing because that doesn't add to your iron overload. That's not blood coming in from outside. That's you keeping your own red cells. And you keep those red cells for longer because they're better quality. And that's really important too. You don't want just more of the same. You want more of better red cells, whether it's better because you've turned fetal hemoglobin on or because you have a molecule keeping the hemoglobin from sickling in the case of Oxbryta and Osavelator, which Oxbryta has been taken off the global market, but Osavelator was given the go-ahead by the FDA to continue clinical trials. And I've fed Osavelator to the sickle mice, and they do amazing. They're getting hemoglobins of like 14, 15. And when I look at the quality of the red cells, in some cases, they're better quality than gene therapy. They're even
Wow.
less likely to sickle. So, we have to proceed with caution, but it looks like the issue with Oxbryta was that in malaria endemic areas, um, like sub-Saharan Africa, it made the red cell better and therefore more infectable by the parasite, which I guess should have
Oh,
been
interesting.
something that could have been foreseen, but wasn't. And so now Osavelator is only allowed in places without malaria, Europe and the US and Canada. And so I'm really sad that it's not going to be developed where it's needed the most, but I could see it being really impactful for someone like the person providing this question because it could raise hemoglobin in a less, aggressive and risky way than such frequent transfusions.
I
Um,
hadn't heard it,
that it
I
came
guess,
back, yeah.
framed in that way that, it improved the red blood cells so well that it was able to become infected. And yeah, walk us through a little bit about how malaria affects the red blood cell, because a lot of times people think, oh, I have a sickle cell disease, so uh,
Yeah,
I won't
or
be
I have
impacted by
trade.
malaria, but I
I can't
have
get
had
malaria.
malaria firsthand. I've
Yeah,
had malaria in Nigeria. I'm
yes,
SS.
yes.
So yeah, could you give us a little bit
Yeah.
about
Yeah, so the
what that
malaria
interaction is?
parasite has lots of different stages, and one of them is infecting the red cell, and it does cause the red cell to break open and be destroyed. Um, but it has its own preferences. So the reason we have sickle cell is because the carrier status, the trait status, gave a little bit of protection against malaria. I don't mean to say that it's a lot. I know plenty of trait people who have had malaria multiple times, but it was just enough to have a survival advantage. And so the sickle mutation flourished anywhere where there was malaria, which isn't just sub-Saharan Africa, but India, the Middle East. Um, and so that's why we have sickle cell. And beta thalassemia also made the red cell a little less good. The parasite was like, oh, this is kind of a hard cell to get into. There's a lot of oxidative stress. I can't replicate and flourish in this cell. So the person was less likely to get infected, but it's by no means absolute. And people with sickle cell, if they get malaria, are even more at risk for bad outcomes because they're not starting at a hemoglobin of 12, 13, 14. They're starting at a hemoglobin of 8 or 7. And so when that parasite gets into your red cell, if it decides, well, it's not the greatest red cell, but I'll still infect it, then it's still going to break open your cells and you're going to drop even lower. So
Interesting.
the relationship between malaria and sickle cell is really intertwined. And I remember like 15 years ago, while I was still a fellow, I think, in Houston, talking about hydroxyurea use in Africa and oh, would we improve the red cell and make it more infectable? I had that concern about hydroxyurea, but fortunately, hydroxyurea actually has some anti-malarial properties to it. And so that has not been the case. And you can see we've had
Wow.
some really successful trials of low dose hydroxyurea in India, in sub-Saharan Africa. And so that's the answer there, but you don't get any anti-malaria effects from something like Oxbryta, a small molecule that just binds to part of the hemoglobin and keeps it, um, it increases its grasp of oxygen, almost like fetal hemoglobin, so it just is less likely to sickle. But that has long range effects, especially as you take it for longer, of improving the red cell and making it more normal. And that's something I saw in the lab when I fed these drugs to the sickle mice. I saw the red cells becoming more normal. Um, but yeah, I wasn't aware at the time that Pfizer was bringing trials to Nigeria, um, and so that didn't kind of come together. And it was unfortunate that then there was higher death rates in the treatment arm. So despite a pretty good safety record in the US.
Yeah.
Not everybody, but many people really benefited from Oxbryta. It was just entirely pulled. It may come back, or it may just be osavallator, or maybe we'll find a problem there too. But that does make it challenging to have another drug for sub-Saharan Africa. So I guess it's hydroxyurea for now, and then we have to work on in vivo gene therapy, a gene therapy that isn't transfusion, mobilization, take the product to the company, the product edits it, you give it back to the patient after they get busulfan. That's a very expensive process, and we can never scale that up like we were talking about. But what about packaging the editor into something that you can then put inject into the vein, and it goes to the bone marrow and it edits there? That we could scale up and do everywhere in the world.
Got it. I have a question from our audience, and it's about spleen removal. What are the things people need to do after a spleen removal? So could you kind of share why a spleen removal would happen and what are best practices?
Yeah. So we might remove somebody's spleen, especially in a young child, if they've had several episodes of splenic sequestration. And the spleen is the first organ to get damaged in babies and very young children. It's kind of a prime sickle spot because it's low oxygen, high acidity. And so blood flows in, it sickles, it gets trapped, it can't come out. And you can trap a lot of blood in the spleen, like go down down to a hemoglobin of 3 or 5. And you could even, in really serious cases, have the spleen rupture or, die of just not having enough blood circulating because it's all trapped in the spleen. So it's really a medical emergency. And that's why we tell parents to feel this for the spleen every morning and just make it a game, get the child used to it and know what it should feel like and be sensitive to it feeling larger or more tender or the child looking pale or irritable, because the solution to the situation is a small, cautious transfusion to have the healthy blood flush out the trapped blood from the spleen. But you don't want to give a really big transfusion. You can't be like, oh, they're 3, I got to give them a lot of blood, because there might be so much blood in there that you then end up too high. And your blood can be then too thick and viscous. So you got to be cautious. You give a little like half transfusion, see what happens. Half transfusion, see what happens. But if a child keeps trapping blood in their spleen, I mean, it's really risky. And so when they get to 2 and we feel like, okay, their immune system's stronger, we may recommend a splenectomy. And and so you have to be concerned about, what is the spleen supposed to do? The spleen's supposed to pull out encapsulated bacteria that has that thick wall. And it's going to probably stop working anyway, but there does seem to be a difference between having a spleen that doesn't work well because you've sickled in it a lot and it's become kind of small and shriveled versus no spleen at all. So we do have to treat infection differently. We may have to re-immunize because we think we've lost a lot of information and have to retrain the body against those organisms that we've vaccinated against. And so you also have to be more concerned about fevers. And most practices are to give a more broad antibiotic if you come in with a fever, if you have no spleen versus you have sickle cell and I think your spleen probably doesn't work. It's a different level of concern and different level of risk of sepsis, because people with no spleens can die of sepsis in hours because a bacteria gets into you somehow, whether it's getting in through a gap in your gut or some other breach, and it can just replicate and take over your body, leading to sepsis and death. so fast. That's why we tell parents, 101 fever, come in, let's cover you with antibiotics, draw blood cultures, because we just don't know how functional someone with sickle cell spleen is. But once it's surgically removed, then we're like, okay, really there's nothing that's going to help us against those types of bacteria. So we've got to be extra careful.
Okay, fair enough. I have another, it's a comment, or a question comment, and a lot of the community really gravitate towards managing sickle cell through nutrition and health and nutrition and diet rather. And a person stated that they use beetroot. It says they kept their son's count up by beetroot. Is there any research surrounding uh, beetroot, or what research is out there
Yeah.
surrounding nutrition and diet and I guess whole foods and sickle cell?
Yeah. I think that's a really under discussed and studied area, unfortunately, because there's no money in it. Um, but it was actually the topic of the NHLBI Sickle Cell Advisory Council that I'm on and that Dr. Fasipe chairs. And yes, and that you were a part of. And so I really like that they discussed um, both what we call macronutrients and micronutrients. So, and then they got into the gut microbiome too. And so that was really good. I've heard beetroot mentioned before. I'm not I'm not aware of any significant research on it. A lot of things have been looked at, and unfortunately, usually in kind of small studies. There was a study of lime juice in Nigeria. There have been a lot of things like that, but some things that have a little more data attached to them are omega-3 fatty acids, vitamin D, which deficiency of vitamin D is just widespread in sickle cell, and it's really distressing to see because my lab has data showing that it actually the insufficient vitamin D can impact how much fetal hemoglobin you make. There was also a presentation at ASH, and I saw it in one of my own patients, that being iron deficient impairs your ability to make the maximum amount of fetal hemoglobin that you could otherwise make. I know it sounds weird, like weren't we just talking about iron overload? But if you're not transfused,
No,
you can
that's
be iron
interesting.
deficient.
Yeah.
Had a baby in my clinic, an 8-month-old, who her hemoglobin was rather low for such a young child. It was like 7. And we were actually talking about hydroxyurea, but then I was looking at her blood counts and I saw that her cells had been getting smaller and smaller over time, and the variability of size in her red cells were getting greater. And this is all very classic for iron deficiency. You start to make smaller cells, but then they're all like varying sizes because some get more iron than others, but iron's really scarce. And she was a breastfed baby and she wasn't on extra iron. And so we're like, well, let's replace the iron first and then talk about hydroxyurea again. I did not expect her fetal hemoglobin to change. It was just mom wanted to do it stepwise, and I respected that. Well, her fetal hemoglobin went from 12 to 24%, and her total hemoglobin went up. And then this is all happening like in the fall. And then at ASH in December, there was a French group that reported similar data on a large cohort of patients. And so, and then that came up at I may have brought it up actually, the advisory council. So nutrition is so important. And we have to remember that, the iron overload issue is only from transfusion. It's not like naturally people with sickle cell get iron overloaded. So we have to also be wary of iron deficiency, and that can be masked by hydroxyurea because hydroxyurea is making your cells look big. So, and also variable of size. So, but missing that iron deficiency can cause you to get less fetal hemoglobin than you would normally, which is tragic, right? Not taking up your vitamin D. And when we're working on this and publishing on this, can affect your fetal hemoglobin, your total hemoglobin. Also impacts your immune system, your bone health, and there's some data that our patients are at risk for what's called clonal hematopoiesis. It's small mutations, not in in every cell, but just in some cells, not having vitamin D can increase that, and that can increase your risk of a blood cancer over time with age or with the stress of gene therapy. You might have heard that there were 2 cases of AML in one of the gene therapies. And it wasn't that the gene therapy gave them cancer. It was that they had some small changes in their DNA that could become cancer. And then the stress of having a smaller number of cells having to fill the bone marrow that was cleared to make space for the edited cells made that cancer bloom. Might have never happened otherwise, but it's just like this perfect storm. So vitamin D has far-reaching effects. So I definitely would encourage folks to check their vitamin D levels and aggressively replace. And if your doctor doesn't know this already, it's important to say, I'm going to be harder to replace than you think. Because people with sickle cell often lose the vitamin D binding protein. They pee it out, and then they can't hold on to vitamin D as well. So you have to give somebody with sickle cell what seems like a mega dose of vitamin D. And that's scary to doctors who don't know this because vitamin D is a fat soluble vitamin that can build up in the body. But, putting somebody on, 5,000 a week is not going to do anything. It's got to be, 50,000 a week or even better, giving it daily, 10,000 daily. And then don't just say, oh, I got you to the normal level, let's stop. You need to keep going maybe at a lower dose because that person will drop again because of these, sickle cell specific things. And so I'm so concerned that vitamins and nutrition does not get the respect it deserves because everybody is kind of dazzled by, drugs that cost millions and, and actually just these humble things can do so much for you.
Sorry, I was mute. It's nice to hear that message being, I guess, reaffirmed within the community. A lot of times, people see it as this or that, right?
Should be an
Drug
and, I agree with
therapies
you.
or
Yeah.
nutrition or, whatever else, or, hydroxyurea. But my philosophy has always been, and it's, living a healthy lifestyle, living, getting in those macro and micronutrients and taking my hydroxyurea. Um, any thoughts on that?
Yeah, that is ideal. It doesn't have to be an or, and again, hydroxyurea is our best drug tool currently, but I also don't think that we should keep insisting people take it if they are not comfortable with it. And I know we've lost the trust of some patients and their families by being too aggressive or too dogmatic about it. It's our job to provide the information and then respect families' decisions.
That's our philosophy. So you're preaching to the choir, have at least that information. And it's actually the theme for World Sickle Cell Day for us is the importance of being able to access health information. And I shared a story about, and this will come out. So this is like a little sneak peek, or if you will. But I shared a story about a meeting of a 42-year-old. This was years back, and she'd never heard about hydroxyurea. And it's one thing not hearing about it and never having the choice to take it. And it's another thing where you've been offered and you've been educated about it and you choose not to take it. And so the goal for Sickle Cell 101, this World Sickle Cell Day, is to make sure that everybody has access to the information and can make an informed decision based off of that access to information. And so that's huge for us. And you hit the nail right on the head when you said that. I do have some follow-up questions about vitamin D.
Mhm.
Is vitamin D from the sun enough?
No, no, no.
No?
And
Is it not?
actually,
You can't stay outside all day.
so here I am living in Atlanta. I actually walk to work, so I am out in the sun a fair amount.
Yeah.
And when I went to my doctor, and I'm pale, I went to my doctor and I was slightly deficient. I drink milk in
Okay.
my coffee every morning. I eat cheese,
Yeah.
yogurt, everything. And so it's definitely not enough for anybody, but particularly people with sickle cell disease, because they have some aspects of their body working against them, some aspects of their kidney and of their liver that impair absorption and then retention of vitamin D. It's not even about darker skin or being indoors more, or any of the kind of myths that have kind of been used to excuse vitamin D deficiency, or even kind of distressing to me. Well, their bone density seems fine, so maybe they don't need as much D as white people. No, no, let's
I'm
not,
glad you're debunking all of that because
but it's in papers, it's in like
yeah,
peer-reviewed articles, and it just makes me mad. Um, because just because something is common doesn't mean it's okay.
yeah. And then I have, is there a connection between vitamin D and conditions like AVN that you're aware of?
So that is a really interesting question. My way of thinking about AVN is, I would say no. AVN to me is more about, the ball of the femur or the
Yeah,
humerus is got kind of a tenuous blood supply. This was one vessel, and so if you have a lot of blockage or sickling in that, then there's a lack of oxygen going to that ball, and you see actual ischemia and damage. But something about AVN I do want to emphasize, and I published on this in American Journal some years ago, but I don't feel like the message really got out. American Journal of Hematology. It's not
yeah,
a one-way street to just hip replacement or damage. Just like a broken bone can heal, the ball of the femur or the humerus, especially with physical therapy or improved sickle cell disease control, can heal and come back. I published a series of MRIs showing that you know, the damage can repair itself. So I do want to mention that and give hope about that. And another question is like after gene therapy or transplant, does your AVN heal? And again, there's so much that we don't know and we haven't looked at. In
yeah.
part because after people get their transformative or curative therapy, they sometimes stop coming to see us. It's probably a little bit of PTSD around the
Why do
healthcare
I need to
environment. They're
see you
like,
guys anymore?
I can't wait to
I'm
never see a hematologist again. But then there are these unanswered questions and these assumptions. The transplanters are like, I cured you. And the hematologists are like, well, but what about the damage that was already there? Does that heal? And
Yeah,
so there are programs like STAR and Coalesce that are looking to answer those questions, but it's really late in the day. I mean, we've been doing transplants for decades and we're only now, trying to answer the question of what gets fixed and what doesn't. So yeah, osteopenia is a thing in people with sickle cell. That's sort of like osteoporosis, but in a younger person. DEXA scans do show low bone density, and that I think is definitely from low vitamin D. But the AVN, I think, is more of a sickling, ischemia, um, death of the bone problem. But have hope
okay.
that it can come back as well.
Yeah. I have a question that a lot of people ask, and happy World Sickle Cell Day, everyone. And hi, Stanley. Stanley joins us from the Dominican Republic. Um, so this person says, I have gallstones and struggle daily with fatigue. How do I know if gallbladder removal is the right choice and what can I do to improve my energy levels? And this is a question we get often is, and even for myself, energy is always super, super low. So
Yeah.
what do we do about that?
Like, so to me, there are two separate problems from the same root. So I would guess that Stanley has what I would call a high hemolysis type of sickle cell, meaning his cells live less long and they break open more easily, and his blood levels, his hemoglobin levels tend on the low side. Some patients are different. They have a higher hemoglobin, and then they have more of a high viscosity problem, maybe more pain, less fatigue, less organ damage. So you can vary kind of crudely separate into two groups. And so the reason I think he probably has his red cells breaking open more rapidly than some is that the gallstones are from the bilirubin that is released every time a red cell breaks open and dies, and
Mm,
it builds up in the gallbladder. And so
yeah.
the gallstones can, cause some pain, some colicky pain. They're at risk of getting inflamed, getting cholecystitis, inflammation of the gallbladder. And so taking out the gallbladder would help with that. I don't know that it would change the fatigue because the fatigue is coming from that same root of your red cells die rather quickly. You can't keep up with this rate of destruction. And
Right.
so your hemoglobin is lower and you're getting less oxygen throughout your body, no matter how hard your heart pumps. And so you feel fatigue. And so to me, the answer is a drug therapy that will slow that process of red cell destruction, let your hemoglobin go up higher or if there's no other way, transfusion, but I would definitely try not to go that route given the risks of chronic transfusion.
Yeah. So I know we're coming out up to time and I have our next guest, but I do want to get in one more question uh, to Dr. Sheehan. So if you have a question, please feel free to type it in quickly. In the meanwhile, Dr. Sheehan, I know a lot of your research is within lab, and I guess this is a shameless plug. We are putting out a global sickle cell survey. The last date is this Sunday. How do you use data from surveys or how does data from surveys translate into lab, if that makes sense?
I
Or if it does, do you ever use data from any of these types of surveys to kind of create any hypothesis or to
Yeah, that's
inform
an
your
interesting
research within
question.
lab?
I guess I would ask kind of what do the surveys tell you? Are they asking kind of like what are the priorities of the people taking the surveys or
Yeah.
can you
Yeah. So this particular survey, we've kind of cast a wide net to see what we can find. But a lot of it talks about, what medications patients are taking, how they're feeling on a daily basis, what fatigue levels look like. What else is in the survey? Um, what are priorities like daily life struggles and symptoms for people living with sickle cell? Does that
yeah,
help?
I definitely I don't know if that necessarily comes from surveys, and maybe it should because that would give me a bigger view. But one of the things I really like about being a physician scientist is that I see patients too, as well as running a lab. And so I hear their stories and their problems, and it helps me focus on what is most important. But I actually would love to hear the results of your survey so I can see if I am aligning my research with the most broad information on what is it important
Yeah.
and needing to be addressed in people with sickle cell. And fatigue is understudied, and I know this in my head, but it's difficult to fully, translate that to research because it's still not clear like what is causing the fatigue. Is it all hemoglobin? And can I address that by developing therapies to increase hemoglobin, which, I do, or is it more complex than that? I think it's more complex than that, but how
Mm,
to drill down on it is a big question.
yeah.
And I want to keep that dialogue going.
Thank you. And the last question I got, can you shed more light on why we need to take hydroxyurea and is hydroxyurea recommended for hemoglobin SC levels greater than 10 on average?
Yeah, those are great questions. And, I like to tell people in my clinic how hydroxyurea really works. And I tell this sometimes to teenagers, and like it's clear like the teenagers never heard it, the moms never heard it. And one time I realized the nurse practitioner that had been working for 10 years with us had never heard it. So So why hydroxyurea? Why fetal hemoglobin?
Yeah.
So something maybe we don't get into the details of is that the mutation that causes sickle cell puts a water-hating amino acid, a protein building block, right on the surface of the hemoglobin molecule, this glob of protein that's supposed to be carrying oxygen all around you. So what is a red cell full of? It's full of water and hemoglobin. So everything in nature wants to be low energy, comfortable, and so here's this water-hating amino acid right there on the surface. It's super uncomfortable. So what is the body's solution? I'm going to put another hemoglobin right over it to cover it, right? Oh, but wait, that one has that same problem. So you got to add another one and another one and another one. I have some beads that show this, but we'll have to imagine that. Okay,
Mhm.
so now we've got this rod of sickle hemoglobins. It's supposed to be a jelly donut with the hemoglobins all floating free, carrying oxygen, but it's not anymore. It's this rod making the red cells stiff and fragile and sticky. And so, what's the solution? What can we add to cover that water-hating amino acid that won't just continue the problem? A fetal hemoglobin. It's a different gene. It doesn't have the sickle mutation. It is fine in being in water. Cover it with fetal hemoglobin. The more fetal hemoglobin you have, the shorter those rods are. So maybe it's just two or three molecules stuck together. That's not so bad. That's
Yeah.
not going to make the red cells super sickle shaped and rigid, you know? So that's why hydroxyurea. We want to trick the body into leaving that fetal hemoglobin on. All hydroxyurea does is shoot out a kind of more immature red cell from the bone marrow. It hasn't shut off the fetal hemoglobin all the way yet. And
Yeah.
so every time you got that fetal hemoglobin there in the mix, it's going to give you a shorter rod, maybe only a couple molecules. And then the red cell is more like the jelly donut of somebody without sickle cell. So that's why hydroxyurea.
Yeah. Oh, I love that explanation. Thank you so very much. And thank you for being here today.
Yeah,
It's always a pleasure to talk with you, and I'm always learning so much.
I'm happy if someone
You
comes up
say
with a
things that I've
question,
never
email
heard
me.
before.
Yeah, yeah. I'm always happy to answer. So, just because the hour is up doesn't mean, I'm not there to answer questions. If you want to connect me with anybody, they're welcome. Welcome to
Thank
share my
you so
email.
much. Yes, I will do. And you are with Emory
Mhm.
University currently in Atlanta, Georgia. So
Yeah.
if anybody's wondering where she is from, phenomenal provider and researcher. And thank you so much for the work that you're doing.
Thank you. I really enjoyed this time together.
Wonderful. Well, we have actually Dr. Mara Faruqi next, and she is going to be discussing menopause and reproductive health. So I have a lot of questions. You guys get your questions ready. And thank you so much, Dr. Sheehan, for being here today.
Happy Juneteenth.
Happy Juneteenth. Take care. All right. I am going to go ahead and let Dr. Faruqi in next. That was so interesting, wasn't it, Dr. Q?
It's 8 hours.
Oh, you're on mute. You're on mute. I don't know if you're saying something.
Yeah, I really like her. She knows her stuff. She's
Yeah,
really very, very good at explaining things.
I
So
agree. All right,
yeah,
I'm gonna
she's
go ahead.
great.
I have Dr. Faruqi here. You guys get your reproductive questions, your menopause questions. I know I certainly have them. Hello. Let's see. Hi, Dr. Faruqi.
Hi.
Hello, how
Good
are you?
morning. I'm good. How are you?
I'm great. Thank you so much for being here today. Want to let you know you are on live and we have some questions geared up for you. And I'm really looking forward to a great discussion today. I came across your work probably a year or two ago, and Dr. Faruqi was discussing perimenopause and sickle cell. And I just had never heard anything about any type of correlation between the two. And so I have been wanting to work with Dr. Faruqi and we get a lot of questions from the community surrounding reproductive health and sickle cell. So now's your chance. We have an amazing expert, Dr. Mara Faruqi here today to answer your questions. Happy World Sickle Cell Day, Dr. Faruqi.
Happy World Sickle Cell Day. I've been doing sickle cell this whole week in honor of World Sickle Cell Day. Some
Yes.
institutions did it a little bit earlier. We did ours on Tuesday, and then I was at Howard yesterday talking about menopause and sickle cell disease, and here today, excited.
So if this session sounds like a personal session, please don't mind me. I just have lots of questions. But before we get started, I want to read a little bit about you and your work to orient our audience here. Dr. Mara Faruqi is a hematologist oncologist at UI Health in the Division of Hematology and Oncology, where her clinical focus includes sickle cell disease with expertise in pain management and supportive care. Dr. Faruqi, please correct me if any of this is wrong or, feel free to expand on any of this stuff. Her research focuses on expanding treatment options for sickle cell disease and increasing access to clinical trials, with particular attention to an often overlooked area, menopause and reproductive aging in women with sickle cell disease who may experience premature or early menopause compared to the general population. So, lots and lots to discuss. Anything to add to that, Dr. Furky?
No, I think you were pretty thorough. I'm
Okay.
one new development is we're working on a neurocognitive in menopause in women with sickle cell disease project. We're
What
hoping
does that
to start
mean?
enrolling in July.
And what is
Looking at the
neuro?
neurocognitive impacts, so memory, brain fog, early
Oh,
onset dementia potentially, and things of that nature.
okay. So, could you provide just a little bit of background on, you know, um, maybe perimenopause and sickle cell?
Yeah, sure. So to be completely honest with you, my work actually started because of a patient. About 4 to 5 years ago, I was a new attending at that time, recently graduated from fellowship, and at that time, I was establishing my practice, and she was in her mid 40s or so, and she came up to me and she told me that she was having hot flashes and she didn't know what to expect with menopause and sickle cell disease. Is there some stuff that she should be looking out for? And I was very honest. I was like, I don't know. I actually don't even. We didn't formally train for menopause. We don't really think about it in sickle cell disease because up until a couple decades ago, women didn't make it to the menopause age range, which is usually in the early 50s. So, yay, we have made progress,
Yeah.
but that leaves a vacuum of missing information around perimenopause. So, when I started doing my own PubMed research, I saw that there was just one article based out of a Brazilian study in about 20 to 22 women, and they followed this cohort longitudinally to look at, all the menopausal symptoms that women have. They tried to decipher the age at menopause and linking the symptoms to disease modifying therapy and things of that nature. So that was it. There was nothing in the United States. There was nothing globally at the time. So that's when I decided, hey, we need to start looking at this because we do have a good sizable population at UIC itself, and half of them are women, and all of them are going to go through menopause. So why not start some exploratory work and start answering some of those questions? So perimenopause is actually the time period before your final period. So menopause itself is a decline in estrogen levels. So those are the female
Mm.
hormones. And as your estrogen goes down, there's other things that can happen. But the final period is the mark of menopause. Now, as women, we won't know if it's our final period. The way we define menopause is naturally not having a period for 12 months. So if
Yeah.
you're not on birth control, if you don't have, if you haven't had your uterus removed, if you haven't had your ovaries removed, if you don't have a pituitary disorder or other endocrine dysfunction, and if you're not having a period for 12 months, that's considered menopause. Now, the question is, there are other conditions that can interfere with your period, so we have to make sure we're not missing some of those conditions. But specifically with menopause, we started noticing as we did our study is women with sickle cell disease were reporting missed periods and missed periods for several months. And really, because sickle cell care is generally fractured, especially in the United States, and
Yeah.
most hematologists are not even thinking about menopause because, again, our training is lacking in that sense. We need to start looking at why is this that women are missing their periods despite not being on birth control or being pregnant. So we started noticing that there was a trend towards earlier menopause, and it's important to capture these symptoms that will happen before menopause. And some of the common symptoms are hot flashes, joint aches, vaginal dryness, sexual dysfunction, sleep disturbances, mood changes, all of which can happen in sickle cell disease itself, but it's quite heightened in menopause for some women. So there's quite a lot of overlap, and we have to tease out what belongs to what bucket so that we're not missing the diagnosis or mistreating or overutilizing certain medications for not the correct condition. So that's
Yeah.
my little spiel about starting to look at menopause transition and this perimenopause. Those are terms I do use interchangeably, but menopause transition can happen almost a decade to 15 years before your final period. So it could be that women may be experiencing some of these symptoms even 10 years prior to their final period. So it's important to start recognizing these symptoms and not attributing everything to sickle cell disease, because yes, sickle
Yeah.
cell disease is, it can wreak havoc on your entire body, but there are other conditions that every woman goes through, that can also cause some of these symptoms.
Yeah. So how does one, I guess, get diagnosed, or how do you know if you're going through perimenopause? Asking for myself.
So the biggest thing for perimenopause is symptoms.
Okay.
Whenever you talk to menopause experts, they'll tell you, there are certain symptoms that are more linked to menopause than they are to anything else. So the hot flashes get worse, especially for some women. The hot flashes can be a huge thing. When you start seeing irregular periods, that could also mean that you're going through the menopause transition. But that's what makes it really hard in sickle cell disease, because sometimes at baseline, some of our patients have that, right? So,
Yeah.
how do we delineate between, is this menopause transition or is this part of the disease itself? So, we did come up with an adapted questionnaire. It's called MQ6, and it looks at the key menopausal symptoms. And the nice thing about this questionnaire, it was Dr. Goldstein out of the University of Toronto that actually developed this questionnaire that can be utilized in a busy primary care setting. So we adapted it to sickle cell. And the specific thing this questionnaire actually emphasizes it, are any of these symptoms new in the last year or so? So if you start seeing new hot flashes, new sleep disturbances, new genitourinary dysfunction, then that is an inclination that this could potentially be linked to menopause. Now, there are blood-based biomarkers that you can do, biomarker studies as well. And definitively, to know whether or not your fertility has ended, there's validated measures, specifically anti-Müllerian hormone. Dr. Lydia Pecker's team has done quite a lot of work on this, to look at the end of fertility, and that's been validated in sickle cell cohorts. So you can use that as surrogate marker to see if the fertility period is ended. But you could also use other hormonal markers such as FSH, estradiol, inhibin. But this is more in the exploratory phase, and that's kind of what we're doing right now. We're doing some biomarker testing to see if there's, biomarkers that will be able to pick up this perimenopause versus sickle cell disease differentiation a little bit better.
So is that clearly defined for the general population, but not necessarily defined for sickle cell community, or are we talking about this generally speaking?
So generally speaking, the biomarkers
Okay.
are well defined.
Okay.
However, they vary with the cycle of the woman, even in the general population. So you really have to look at when the last menstrual period is and what phase of menstruation the woman is to understand and interpret the biomarkers accurately. And that really takes someone who's trained in the menopause pathophysiology to be able to understand and interpret these biomarkers. Now you mix in sickle cell disease into this, where you're having ovarian ischemia intermittently. I don't know what these biomarkers are going to show for the sickle cell warriors. So,
Yeah.
that is the unanswered question that remains. How much variability is there? Even with anti-Müllerian hormone, I've seen dips and then I see improvement in anti-Müllerian hormone in some of my female patients. And I don't think we have answers to why that happens. We guess it happens because the ovaries also are an end organ, right? And there is some interruption of blood flow to the ovaries, and perhaps that's why some of these fertility markers that we're looking at, they can fluctuate over time, but I would assume it's the same case for some of these hormonal markers as well.
Hmm. So I have a question here within our audience. Is hormone replacement therapy recommended for menopausal sickle cell women?
That's a really good question. So, hormone replacement therapy, biggest thing for us to watch out for, and we have a lot of data from birth control for this. Estrogen-based hormone replacement therapy specifically can cause a lot of issues in terms of blood clots. And this is not just women with sickle cell disease, this is across the board. We do have to worry about blood clots, and specifically in women with sickle cell disease, there's a heightened risk of getting blood clots. So, and when we're talking about hormone replacement therapy, primarily we're talking about estrogen replacement, and that's the driving factor for venous thromboembolism, both blood clots in your lungs and your legs. So, in terms of the safety of hormone replacement therapy, it has not been studied in the context of sickle cell disease, but we can extrapolate from data. And, generally we put a pause on oral hormone replacement therapy. However, that's not to say we can't use other forms of hormone replacement therapy. There are transdermal patches that we can use that actually don't significantly interfere with blood clotting, and that can actually help improve the symptoms of menopause, specifically the vasomotor symptoms such as hot flashes, and still give you the benefit without increasing your risk for blood clots. So that has been studied in the general population and is generally safer. Has there been a study done in sickle cell disease? No, but many menopause experts that you go to clinically will be willing to try the transdermal estrogen patches. And now I know a good chunk of my female patients have also utilized vaginal estrogen creams to help decrease some of the genitourinary symptoms of menopause, especially the vaginal dryness and things like that. And that has been safe in many of these patients. Now, hormone replacement therapy isn't the only thing that we can utilize in menopause. For menopausal symptoms. There are other modalities of treatment that we can utilize, and specifically, there's neuropathic medications that can be used to help with to help with the vasomotor symptoms such as hot flashes. And then there's some of the other newer medications that have come out for menopause symptom management as well. And the new medications have not been utilized in women with sickle cell disease just because we don't have enough data. Do I have a handful of patients here and there that have been on it and it has helped? Yes, but it's all anecdotal. We don't have studies done
Yeah.
on it yet. The neuropathic medications are what I'm talking about is like gabapentin, duloxetine, clonidine, and some of these medications have successfully been used in sickle cell patients regardless of menopausal status. So those medications we're pretty comfortable using for menopausal related symptoms as well.
Yeah. And then there's a lot of, I feel, controversy surrounding hormone replacement therapy. Can you kind of speak to why some people may not see that as a good option for individuals in
So
general?
hormone replacement therapy is the spectrum of birth control, right? There's a lot of hesitancy around birth control as well.
Yeah.
However, the stigma around birth control has significantly improved over the past couple decades, right? And with hormone replacement therapy, I think it's going to take time. Hormone replacement therapy doses are much lesser than your traditional contraceptive hormone levels as well. So I think a lot of hesitancy comes from just, not knowing and the unknowns. And also the data has swung one way or another. Initially, there was a lot of concern about unopposed hormone replacement therapy and being linked to adverse long-term effects. And now we have looked at, large cohorts where we've proven that those theoretical risks actually are not significant when it comes to treating women with hormone replacement therapy. Now, is hormone replacement therapy for everyone? No. The International Menopause Society actually came up with recent guidelines looking at who would be the ideal candidate to start oral hormone replacement therapy. And this is specifically women who go through premature menopause, which is defined as under the age of 40. And that for long term can decrease your cardiovascular risk when you do start these women early on hormone replacement therapy. There's not significant data after the age of 40, so there's still mixed results when it comes to that.
Hmm. A question we get a lot is it safe? And I think you spoke to this a little bit. Is it safe to be on a contraceptive with sickle cell? And it sounds like with an increase in estrogen comes an increase in blood clots. Did I get that right?
Yes,
Is it specifically estrogen?
it is specifically estrogen.
Okay. So are a lot of the, birth control therapies, um, I guess, promoting an increase in estrogen? And is that why it would be problematic for individuals with sickle cell?
So with birth control, we specifically try to avoid estrogen only contraceptive methods.
Okay.
And we are comfortable using combined both estrogen and progesterone. And ideally, we would like to use progesterone only based birth control um, options. And there have been several studies that have been done on things such as Depo-Provera to look at, well, what is the risk in terms of sickle cell disease? And it's shown that there is no significantly increased risk in terms of venous thromboembolism. And specifically the progesterone-based
Okay.
birth control options, and including the combined hormonal contraceptives, which have both a little bit of estrogen as well as some progesterone. Now, when we're talking about replacing estrogen in the hormone replacement therapy space for menopause, we never like to give unopposed estrogen, so we would give a little bit of progesterone with it as well.
Okay. So another question that we get often within the sickle cell community is just asking about if there's a correlation between sickle cell pain and being on your cycle or being on your menstrual cycle. Could you speak to that a little bit more, if there is that correlation?
So there has been good papers by Dr. Davis Sharma, and she has actually specifically looked at this in the younger female population, and has we have data showing that uh, in younger women with sickle cell disease, there is significantly increased number of pain crises with menstruation. So there is definitely some impact of hormonal fluctuations and the disease itself. And we know some of these hormones, specifically estrogen, can drive a little bit of inflammation as well that can cause and trigger the pain crises.
So it's not in our head. That correlation definitely exists.
It does exist, and there's good papers on it. Specifically, I would refer to Dr. Sharma's paper on it.
And then, oh, I guess what is the solution? How do we get in front of that, to make sure that, it's not too disruptive to our lives?
So, in my female patients who have noticed menstrual related vaso-occlusive episodes, to the point that they're being hospitalized every time that they go into their menstrual cycle, I will recommend hormonal contraceptives to regulate their periods. So that way, they can have a good quality of life without it interfering with their day to day intervention. Now, some women already know and when to predict their crisis. Sometimes it could be linked to the time of ovulation and not necessarily the time of periods. So,
Mm.
I think women are really in tune to their body. It's just us as providers, we haven't really for a long time bother to ask them about these questions. So I'm glad there's work being done by others. And it's not just hormonal contraceptives. You could also utilize NSAIDs to help with the menstrual related pain specifically. And you're kind of, addressing two issues with one medication, both menstrual related pain issues and as well as um, it causing the trigger in VOEs. Now we have to be careful with the amount of NSAIDs we use because of all of the side effects that can happen with things such as Motrin, ibuprofen, Midol, I'm sure you've heard of in the
Mhm.
period space, because over long term, it can cause unwanted side effects of renal dysfunction as well as
Oh, I didn't know that.
GI issues. So you do have to be careful about how much of these non-steroidal anti-inflammatories you're using.
Okay.
If it's being used over a course of 2 to 3 days, it's not an issue. But if you're using it for the entire 7 days that you're getting your period, or longer or shorter, that can become an issue over time, especially if you're using it month after month. That's why regulating your periods and getting on some kind of um, hormonal contraception to help regulate these periods is a good option for one.
Would you start on hormonal contraception if you know you are on perimenopause?
You could, because perimenopause is the time of the time for women where you could have a lot of fluctuations in your period. Some women end up getting no period for a couple months. Some women end up getting periods twice during their monthly cycle. So,
Mm.
and then some women end up bleeding quite a lot. There could be symptoms of menorrhagia, which is heavy bleeding. So that is actually not a horrible time to start birth control. And just because you're having menopausal symptoms, it doesn't mean you're not fertile, right? You still have those oops babies of their 40s. When people talk about it, you do see that quite a lot as well. So,
Mm.
um, you know, any time is a good time to start if it's interfering with your life as well as your quality of life.
Mm. Yeah, I
Of
always
course,
feel.
you should talk to your hematologist before starting anything and make sure the person that's prescribing the hormonal contraceptive is, communicating with your hematologist so they can talk about the risks and benefits. There are over the counter birth control options as well now. And then Of course, there's Plan B in terms of the emergency contraception. And those things are over the counter for a reason, but I would still highly suggest that women go back and let their hematologist or their sickle cell provider know if they are using those, because those don't come without side effects, and you want to make sure that your provider is aware of what you're using. Similar space in terms of menopausal therapy that I've noticed that women do use quite a lot is herbal supplementation. So there's soy-based products that women do use to help with some of the hot flashes and things like that. And there's a lot of things that you can find at the health store. Please always let your provider know, because they'll be able to let is it safe to use? Is it not? Does it increase your risk of blood clots and things like that? Now, remember, keep in mind these over-the-counter nutritional supplements, specifically the herbal supplements, have not been FDA tested. So can they give you a final yay or nay? No, but generally they'll be able to decipher if there's increased risk of blood clots, liver dysfunction, renal dysfunction, because you want to make sure you're not mixing it with some of your other sickle cell medications that you're taking as well.
Yeah. A question from the community. Is there, I think you touched on this a little bit, but is there a difference between the use of birth control, contraception, and hormone replacement therapy? And it sounds like hormone replacement therapy has less estrogen, uh, from what I gathered. Is that correct? And what's the difference? What are the key differences between the two?
So oral contraception is more being utilized for um, birth control purposes. So the amount of these hormones varies in hormone replacement therapy versus your traditional oral contraceptives. The oral contraceptives will have a higher dose of the synthetic hormones that's supposed to prevent ovulation and eventually prevent pregnancy. Majority of these contraceptive pills work that way. Whereas hormone replacement therapy is used to give lower doses of hormones to help with the declining estrogen levels during menopause itself. So the dose is significantly different. And the route could be different as well.
Okay,
So
okay.
there's vaginal estrogens for menopausal symptoms. There's the transdermal patches. There's the oral hormone replacement, traditional oral hormone replacement therapy as well.
And does a decrease of estrogen increase pain crisis during perimenopause and menopause?
We don't know the answer to that. We
No.
don't know the answer
Okay.
to that. Anecdotally, there are some women that will tell me, hey, menopause was not a big deal for me. I'm glad you're doing this research, but it didn't really bother me as much. Then I have some women that will come to me and say, that transition time when I was going through menopause, those hot flashes were so bad that I went into a sickle cell crisis every time I had these bad hot flashes, and I ended up in the hospital. And then there's some women that will tell me my sickle cell crises got better after my periods ended. So um, I don't think there's a one size fits all answer for it, but it's really important. That's why to study cohorts of these women and see who is the one that menopause will affect the most in terms of quality of life, as well as sickle cell disease related outcomes and comorbidities. Now, let's say there is a female that went through menopause at age 37, all right? That has huge implications. That means you're declining estrogen levels early on. You have worsened bone health. You have muscle wasting, sarcopenia early on. With the decrease in bone health, it means higher risk of fractures at an earlier age, increased risk of cardiovascular side effects, and brain fog is also something that we're starting to look at. But all these side effects that are related to early menopause and premature menopause, we do have to monitor these women closely. And unfortunately, with the DEXA scans, the bone density testing, it's not approved in women unless they have hit menopause or if they're of a certain age. I have to file for prior authorization and give an explanation of why I'm doing DEXA scans in my young 40-year-olds. But if they've gone through menopause already and have been in declining estrogen, they don't have the estrogen levels, they are at a high risk for fractures if they have osteopenia and severe osteoporosis. And we do find that some of these women who've gone through early menopause do have declining bone health. There is a researcher out of California, I forget her last name, Adesina, I think, Dr. Adesina is the one who's looking at osteoporosis in patients with sickle cell disease. She doesn't necessarily focus on females, but females are a huge population that make up for the osteoporosis because of the declining estrogen levels. And it's important to do bone densities in this woman, especially if they've been through menopause for several years.
Okay. Does hydroxyurea affect fertility? And if so, is there anything we can do about it? That's a question from the community.
That's a hard question to answer. There's sickle cell disease itself is a red cell disorder that can cause significant organ damage and vaso-occlusive episodes can cause restricted blood flow to certain organs. And we've seen this in the kidneys. We've seen this in cardiac dysfunction. We've seen it with pulmonary hypertension. Remember, ovaries are an end organ as well. And over the years, fertility, typically when you're born with a certain number of follicles, and that helps determine what your fertility will be over the span. But that's not the only picture. The other things are, as you're aging, what other insults are you adding to that? And how easy is it to get pregnant? And it's not just the female. A lot of times people don't look at male infertility. So that's another factor. And is hydroxyurea specifically linked to decreased fertility? In some studies, it has been. But can we figure out, is it the disease itself? And was there fertility issues to begin with? Or was it the introduction of hydroxyurea that caused decrease in fertility? Or is it that patients who had the severe disease were started on hydroxyurea and therefore we're confounding it based on that? There is quite a lot of unanswered questions. In my practice, when my patients are talking about, hey, I want to start thinking about pregnancy, or if a patient comes to me and says, I've gotten pregnant several times, but I haven't been able to carry my pregnancy to term. I've had patients who've had 3, 4 miscarriages on or not on hydroxyurea, regardless. And, it's heartbreaking. So if women come to me early on with a planned pregnancy, my traditional way of approaching this is, let's not initiate anything new that already has some linkage to fertility issues. And if you are on hydroxyurea, I will start scaling it back slowly, depending on how symptomatic you can be without it. And then we start putting some of these women in who are planning pregnancies or early pregnancy on chronic exchange transfusions throughout the duration of their pregnancy and then right after, especially if they're breastfeeding, to help with the pain crises and the disease component of it. There's no definitive data on the outcomes, but Dr. Oting Natim from England actually is working on this study to look at chronic transfusion therapy in pregnancies. And there's a lot of data coming out of Hopkins, and and talking to some of my colleagues at Hopkins, that's what they use, and that's the approach that I've adapted. And many of the women that we've put on exchanges during the pregnancy and withdrawn the hydroxyurea tend to do really well. Not a lot of folks will challenge people with hydroxyurea during their pregnancy because there were initial animal studies. Now, there's not been any human studies, animal studies that did show that did show embryo defects while the mom was on hydroxyurea. Now, are there some women that are getting pregnant while on hydroxyurea and continue hydroxyurea until they found out they were pregnant? Yes. And have their pregnancies had issues? Not really. So some of my OB colleagues who are a lot braver than I am will continue the hydroxyurea throughout the duration of their pregnancy. And actually, the World Health Organization has also started encouraging utilizing hydroxyurea at least in the latter half of the pregnancy, in the later trimesters. So, there's a lot of controversy around hydroxyurea in terms of fertility. It is a really good medication in terms of sickle cell disease. We have data on it reducing vaso-occlusive episodes. We have data on it reducing end organ damage. We have data on hydroxyurea decreasing hospitalizations and pain crises. Well, it was and it is a blockbuster drug, but I think the answer directly about fertility, we don't have a definitive answer yet. And this is why we need more studies and we need more data on it before we can say one way or another.
Yeah. So if somebody was thinking about family planning, what do they need to know? And I guess pregnancy, what do they need to know right off the bat? Oftentimes, we have people within the community asking, can they get pregnant? Can they kind of understand what their pregnancy will look like with sickle cell? It's kind of a big question mark within the community. So, what guidance can you provide to people who are looking to get pregnant with sickle cell?
So I'm always of the opinion of the more knowledge you have, the better you're equipped to make the decisions, right? Um, Generally, we're starting the puberty talks in fifth grade, right? Across
Yeah.
the United States. Now, every parent is different, every community is different, but if you're starting the puberty talk, I would start the reproductive health lifespan talk in both men and women. Because oftentimes I will have during our qualitative menopause interviews, I will have patients that have told me, had I known that my fertility window was this short, or had I known I was going to go through menopause early, I would have planned my pregnancy earlier, or I would have planned to have more kids. I would not have just waited after my first one and, waited a couple of years. And that's when my fertility kind of just, declined completely. And now I have an only child, or I was never able to conceive because my periods stopped before I knew they were going to stop. So that's heartbreaking. I do think both men and women should be aware that sickle cell affects fertility, and as early as you can make them aware, in terms of health literacy, I think that is key. Now, with sickle cell disease, it's not just hydroxyurea. There's other treatments that can affect fertility as well. Specifically, the curative treatments that we're talking about, gene
Yeah.
therapy that's lately been on everyone's minds, as well as hematopoietic stem cell transplant. Both of these, the conditioning regimens that we use for these treatments, do have an effect on fertility and can cause permanent irreversible infertility in individuals. So this conversation needs to happen early on, especially in these curative therapies. We're using it for younger individuals. So whether it's fertility preservation with sperm banking or egg preservation, all these conversations need to happen early, not when you're coming to me as a 25-year-old. I hope my AYA physicians, is my transition clinic doctors, my pediatricians are having this conversation with the families of warriors as well as the warrior themselves. So they are aware. So it's on their radar that, you may have issues with pregnancy. Not just that, I have individuals with sickle cell disease, they say, had I known that this could be passed on, or, I needed to do more partner testing, and had I known that I would have a child with sickle cell disease, I would have planned my life differently. So, meeting with a genetic counselor early on is important. Understanding the disease. How many teenagers are sitting there, talking to genetic counselors, but you have an inherited genetic condition and you will pass it on to your child. You will pass on the trait, but you can pass on the disease if your partner has sickle cell trait or sickle cell disease. So all of these are important conversations that the warriors should be exposed to periodically, because it can have a long-term impact on
Yeah.
their quality of life as well as family planning. And
Mhm.
then also, pregnancy is not something easy to deal with. As as a mom of two, I can tell you raising a child is not easy. So understanding the implications that come, especially if you have a chronic blood condition.
Yeah.
Some patients will get very, very sick during pregnancy. There is significantly increased mortality for women during pregnancy with sickle cell disease. So understanding the risks that are going with your plans for pregnancy are important, and making an informed decision. And then, then after that comes breastfeeding, childcare. As
Yeah.
the kids age, there's a lot of, mental health issues, not just, the moms are the ones that are doing a lot. It's not easy caring for a child. So I want my warriors to understand that and be as literate as possible in terms of their reproductive health and make informed choices.
That's a really good overview. I think a lot of us, maybe it's a millennial thing. A lot of us um thought we had to have kids also. Like, I heard, and it could be generations before us as well, where it's just kind of like standard to have kids. And now I'm kind of seeing this movement where, generations after millennials are like choosing not to have kids, and it's okay, like I think it's becoming okay within society to not have kids. But additionally, when you hear this, especially with sickle cell, and especially with the history, with, just doctors historically telling people with sickle cell that they shouldn't have kids, or, you shouldn't pass on that gene, it can get really um, sticky. So it's a really
I think
interesting
I
conversation.
personally think it's unacceptable to tell
Yeah.
any human being that they should not have kids,
Yeah.
or should have kids, right? I think that should be the individual's choice. They should be given all the information. You would not believe how many times I've had women who've had 3 or 4 miscarriages who come to me devastated and then tell me, my OB said, hey, don't even bother because you're putting yourself at risk. And, I start them on chronic exchange transfusions. Their disease gets better. They carry the pregnancy, and now they're a mother of 2 kids, and they find it so rewarding.
Yeah.
Are they having issues with childcare? Did they have some issues through the pregnancy? Yes, but, that's why it's important. Sickle cell disease is a multidisciplinary care uh, condition, right? So it's important to talk to to a team of doctors, not just, be in the silos and have tunneled vision. So even if you're choosing to have kids, if you're choosing not to have kids, each individual needs to make informed choices based on what works well for them.
So I'm getting a lot of comments that are talking about the link between hydroxyurea and fertility, and a lot of people are saying my daughter has been on hydroxyurea since she was 2 years old. I wasn't told anything about it impacting um, fertility. And then somebody else said, I never knew hydroxyurea can cause fertility issues. I wish these side effects were talked about more. So can you kind of level set the conversation around hydroxyurea and fertility, and what it is and what it isn't, I
So
guess?
I will give the disclaimer. I'm not a fertility expert. I'm not a hydroxyurea and fertility expert. There is data on both sides of the camp that If you look at the papers that Dr. Lydia Pecker's group has published, there is data showing that there is increased decline in fertility in individuals who've been on hydroxyurea for long periods of time. However, there is the other camp that talks about because people have been on hydroxyurea for long periods of time, their disease overall may be under better control, and therefore fertility may not be an issue. I
Mm,
always remind every patient sickle cell is not a one size fits all.
yeah.
If you have any friends with sickle cell disease, you know yourself that, your pain is going to be a lot different than somebody else's pain. And that goes for fertility, that goes for your kidney health, that goes for your eye health. Every person is different. And I think the conversation should not be a general blanket statement.
Okay.
Instead, it should be a conversation between yourself and your provider or your child's provider. Hey, what do you think the long-term effects of this medication are going to be on my child or on myself? And, before panicking about, hey, there's these studies about this, I think it's very important to weigh out the risks and benefits, and then also understanding that sickle cell disease itself is a disease, regardless of whether or not you're on hydroxyurea or any other treatment, that does have decreased fertility to begin with. And, on the point about no one's ever discussed with me about this medication affecting my fertility, that goes back to show that as providers, we need to be mindful. We need to provide comprehensive care. And honestly, fertility, even menopause, right? It was not on my radar 5 years ago. So having these conversations, realizing that, you don't know. We don't know when we need to be able to accept that we're not going to know everything. And, each patient, each encounter is teaching you something, and learning from each other's experiences as well as learning from the general sickle cell expert community is important. That's my thing on and
Yeah.
when it comes to that.
I appreciate that. I don't think a lot of people know that sickle cell impacts the fertility on its own without, hydroxyurea. And so I think that's also worth, kind of just stating again that sickle
Which is
cell,
why the puberty talks that happen in fifth grade,
yeah,
I think the fertility talks need to happen early.
yeah,
And maybe with parents, the fertility talks need to happen when the child is born. I know no one's thinking about grandchildren, when you just have a baby, but if you've had a baby with sickle cell disease, parents need to be aware. And, parents sometimes are the best teachers for children. So that way, maybe your doctor has talked to you about it once, but who's going to remember what your doctor told you at the age of 13 when you're, 30 and planning on having kids? So
yeah,
it's a conversation that needs to be revisited. And I
yeah,
think now it is on the radar because of the work of some of our great sickle cell experts across the country. But I don't think it's enough. I think it will get better as perhaps for the millennials, it's probably already better than it was for Gen X and the older generation. But if you talk to the boomers, if you talk to, people who are older than where you and I are, they'll tell you, hey, like we were told we would not even make it to 20. So,
right.
hey, forget about fertility. Who was counseling them on fertility? But these
Yeah,
are some things that we need to start looking into. We want to age gracefully. We want to have a full, complete life. We're not going to let sickle cell disease stop who we are or stop us from living our best lives.
yeah. So I kind of want to flag something. I learned about experiencing early menopause from you. And this was a couple years ago. I think it was a talk that you gave at VCU, that I think you might have mentioned that Black people may experience menopause early, and then also people with sickle cell may experience menopause early. What other, can you speak to that, and what other lesser known facts about sickle cell and, reproductive health deserve spotlight?
Yeah. So, definitions of menopause when we're talking about early versus premature versus regular menopause. So, regular menopause in general, Black women in the United States experience menopause around the age of 51 to 52, compared to the average population where it's ranging from 52 to 54. Okay. Now, when we're talking about early menopause, we're talking about, two phases. It's early when it's between 40 to 50 years of age. The closer you are to 40, the more concerning it is. And then there's something called premature menopause or early ovarian insufficiency, premature ovarian insufficiency. And that's when it happens before the age of 40. You know, the general population, it's not as common to have premature ovarian insufficiency, but there is a subset of the population that will have premature ovarian insufficiency. In individuals with sickle cell disease, early menopause, which means stopping your periods in your early 40s, and in a handful of cases, premature ovarian insufficiency is more common than not. The problem is we don't have numbers. We're collecting all these registries across the nation and, looking at pregnancy now. We're looking at medications. We're looking at pain crises. We're looking at all these other endpoint markers of sickle cell disease. But no one's really collecting data on last menstrual period and how, are you in menopause? No one's looking at that. So there might be a missed group of individuals who actually stopped having periods, perhaps in their mid 30s, and we don't know. And we don't know, and the eyes don't see what the mind doesn't know. And your hematology provider, who is not at all knowledgeable about menopause, which is where I was 5 years ago, is not going to be asking about it, right?
Yeah.
And you may think it's normal not to have a period without being on birth control. And you may actually even like it because it doesn't trigger pain crises. But that is something long term, it can cause problems, especially if it happened before the age of 40. So um, I think it's important for women to talk about their menstrual cycles without hesitancy, and without shame, and ask providers if they don't know. Maybe they'll start looking into it more, and it might trigger what it did in me. It's really my warriors that this is what we talk about, translational research, or bringing the bench to bedside. We want to make sure that we're addressing problems that are actually having in real time and not in silos. So just being open and conversational about fertility, about your periods and things like that
I
is
appreciate
going to
that.
be important going forward. And nationally and globally, we need to start incorporating these into the guidelines. I'm very happy that the WHO started incorporating some of the pregnancy guidelines into their sickle cell work, and NASAC, the National Alliance of Sickle Cell Centers, has done great work um, in terms of producing guidelines of what centers across the United States can follow. But I'm hoping as our warriors are aging gracefully, we start incorporating some of these healthy aging measures as well. And it's not just in sickle cell disease, unfortunately. Um, in the space of women's health, the research and the implementation of the research is lagging. So I think across women's health, we need to start implementing this.
Yeah.
And we're working with some rare disease researchers at the University of Illinois who have started to look into cystic fibrosis and menopause and some of these rare diseases. And it's not just the rare diseases, it's people with chronic conditions can also probably have some of the similar impacts on their health. So, I always think of sickle cell disease as being the new wave of discoveries, and I hope the treatments follow. Sickle cell disease was one of the first known genetically inherited disorders that we learned about as, as scientists. So Let's use it as a model to improve women's health across disease and non-disease women in general.
I agree. You are preaching to the choir. I know we only have a couple minutes left, and I do have one more question from the community. But before I let you sign off, there's a question that asks, what test should GYNs do to determine if you are perimenopausal or menopausal? And you kind of touched on that a little bit. Is there like just a list of tests that we should, uh, if we're getting labs, try and request to understand where we are within this?
So specifically for gynecologists, they know this better than I do.
Okay.
And whenever I talk to my gynecology mentors, they are like, we don't like doing lab tests. If you're symptomatic with menopausal symptoms, we treat the menopause symptoms. And then if they get better, we know it was menopause. If it doesn't get better, we know it's something else that's causing it. So if you go to my gynecology colleagues, that's what they'll say. But if you really push them, they'll do some of the biomarkers with the understanding that it does fluctuate quite a lot. And then, especially in sickle cell disease, we don't know what to expect. We don't know what the normals are in that. So, comparing that to the baseline population's normal might be risky territory. So that's kind of where my next phase is. We're looking at biomarker testing and hopefully establishing some rules to the craziness of hormonal um, in the hormonal world.
Yeah. Well, thank you so much, Dr. Faruqi, for taking the time to walk us through perimenopause and menopause and reproductive health with sickle cell. It's always so eye-opening just hearing you speak because we realize how much we don't know about this and how understudied this is, and just very grateful for the work that you're doing and shedding light because these are issues and these are topics that we get that come up a lot within sickle cell where we just don't have that data. And you're doing the work to make sure that we have more clarity surrounding this. So I appreciate all the work that you're doing and you taking the time to talk with us today.
Yeah, no, thank you for inviting me. And those were all wonderful questions. And those questions are something for me to think about as well. So, yeah, it's not just you guys. I learn something from these talks always. So I appreciate it. And happy World Sickle Cell Day.
Happy World Sickle Cell Day. Enjoy the rest of your day and thank you so much for being here.
Okay, bye bye.
Bye. All right, so you all, we have our next speaker. Um, this is a Dr. Martha Kenny, and she specializes in pain and sickle cell. So get your questions ready for pain and sickle cell. I know you guys have them because you ask us a lot about pain with sickle cell. So this is the expert right here. Ask away, and I will let Dr. Kenny in. Any parting thoughts, Dr. Q, before I let Dr. Kenny in? Oh, you're on mute.
That was very interesting talk. That was really good.
Yeah. I clutched my pearls when I heard, when I learned that I could be experiencing uh, menopause early. I was like, I don't have time anymore. This is, of course, is after I had my daughter, but I was like, oh my gosh. So it's yeah, very interesting. All right, I'll go ahead and let Dr. Kenny in here. Hello. Hi, Dr. Kenny.
Hello.
Hi, how are
Hi
you? Good to
guys, it's good
see
to see you
you.
again. Let me increase my volume.
Nice to
Can y'all
see
hear
you
me?
too. Yes, I can. Can you hear us?
Yes.
Oh, wonderful. We're so happy to have you. Thank you so much for being here. You know, the last time you were here, you kind of know the spiel, right? But so many good questions surrounding pain and sickle cell. So I can't wait to see what the community has in store. As somebody just asked, you have a child? Yes, I have a 11-year-old going on 23. No, I'm playing. But I do have an 11-year-old child. We just finished talking with a Dr. Mara Faruqi, who specializes in menopause and reproductive health. So very, very interesting conversation. And I know we'll have interesting conversations surrounding pain. But welcome, welcome, welcome. Thank you so much for being
Oh,
here
it's a
today.
pleasure to be here. Yeah.
And happy
Yeah.
World Sickle Cell Day.
Yeah. Happy World Sickle Cell Day. Happy Juneteenth. Happy,
Yes.
great hopeful future. That's what I'll say. Yeah.
Yeah. So I'm gonna give a brief bio on you, Dr. Kenny, to let our audience know a little bit more about you and your work, and feel free to um, correct anything that is incorrect, and we'll dive deep in uh, a little bit more of your work. So,
Sure.
Dr. Martha Kenny is an assistant professor in the Department of Anesthesiology and Pediatrics at Duke University School of Medicine, and she is an interdisciplinary pain researcher whose work focuses on identifying modifiable risk factors for adverse pain outcomes in adolescents and young adults with sickle cell disease. And you're going to have to break that down for us, Dr. Kenny. A lot of big words there. Um, and on increasing community research engagement among underrepresented communities. She leads the Pain Equity and Disparities Lab at Duke, supported by the NHLBI Career Development Award and a patient-centered outcomes PCORI engagement grant. Long story short, there's acronyms for everything. So welcome, 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 Dr. Kenny. I want to start you off with a question surrounding, or if you could just provide an overview of what sickle cell pain looks like and what research looks like right now for sickle cell pain.
Oh, that's a great question. Well, first of all, thank you for having me. It's a pleasure to be here again. And so when we talk about sickle cell pain, I think that those who are living with the disease have much more of a better descriptor and understanding of pain and sickle cell disease than I do. But I'll just, share a little bit from the clinical and the research perspective. And so it's really important to understand that there's what we call three different kinds of pain based on uh, how long they last that can occur in sickle cell disease. So we can have acute pain, you can have chronic pain, you can have an acute on chronic pain. I think acute pain, probably everybody that is listening is very familiar with. That is what we classify as the pain that you have with crisis pain. And the pain that is incredibly severe, it lasts for a certain, a shorter period of time, the chronic pain, and is very responsive to the traditional treatments that are used, such as opioids. And also, of course, when you have a pain crisis, also making sure that your disease is under control. So whatever it is that your sickle cell specialist recommends in that setting, whether you're going to be treated at home at an infusion center or in the hospital, that is what needs to be done. And so the challenge of sickle cell disease is that for quite a long time, both clinicians and researchers thought, okay, that's it. If you have pain in sickle cell disease, it's crisis. You're having a crisis. And when you're not having a crisis, you're not in pain. And so
Mm,
when the crisis is resolved, you should be okay. But that was not the reality, and that was not the lived experience of warriors. For many people, even though a crisis may have been resolved, they were still living with daily pain that is classified as chronic pain. So daily pain that still limited their ability to live life. And that actually was not really kind of, I want to say, accepted or well described in research in clinical medicine into like the mid 2000s. And which is not, for some people listening, they might think that was such a long time ago. That's not a long time ago.
yeah.
That's still pretty recent, right? And so it's just more recently, I would say over the last decade, that there's been a lot more focus and research on also understanding chronic pain, that daily pain burden that we know more than half of adults living with sickle cell disease experience. And understanding that daily pain burden, quantifying it, describing the characteristics, and also understanding the people that develop chronic pain, because not everybody who has sickle cell disease has chronic pain. Now, although I would say the majority of adults do, not everybody does. And not everyone that has sickle cell disease has disabling chronic pain as well, meaning that chronic pain that limits their ability to work, to go to school, to just perform their daily, actions. And the reason why it's important to understand this chronic pain is that we believe that the cause of it is different from the cause of the pain crisis, and the treatment, therefore, is also different as well. And from the research that has been done, we believe that the cause of chronic pain, it starts off as from cause, repeated pain experiences that you have from your sickle cell disease can change how your brain and your spinal cord, so your central nervous system, sees and processes pain. And so these changes, we believe what ends up happening is that as you have these, if you start off, let's say we're following somebody, a warrior who was, 4 years old all the way to the age of 21, right? When they're, let's say, between the age of 4 and 16, their pain experience is primarily pain crisis, right?
Yeah.
But when they're having a pain crisis, if we were to rate their pain goes up here. Usually when I'm giving talks, I have a visual graph of this to explain this. But your
Is it the
pain
one that's Samir Balas in the
is
bell
similar.
curve?
This one is
Oh,
rating pain,
okay.
and it kind of just follows over a 2-year period. So when you're having a pain crisis, let's say your pain, is 10 out of 10. And then when the crisis resolves, when they're younger age, it kind of goes closer to 0. But then if you follow the patient, the warrior, all the way to the adolescent age, you will see that in between crisis, that baseline is not reset into 0. It might go to like 5. They might say that at baseline their pain is 5. It might go to 6. And that is where you're seeing that development of chronic pain in that person. And so when that chronic pain has developed, it means that in between crisis, they're still in pain. And we believe that part of the development of that chronic pain is because people have had repeated experiences of pain. The brain is now resetting how it sees pain, and it sees pain at a much lower threshold. And so if we don't treat it before it develops, it's something that can be persistent. And it's something that even if we do give disease modifying treatment that, helps with the sickle cell disease, or even potentially cure sickle cell, like a bone marrow transplant or gene therapy, people can still have chronic pain. So it's important to understand who develops it, and also important to really start thinking about how we can prevent it from developing. But that's my long-winded answer to that question.
And it means not all pain is equal at the end of
No.
the day. And I think we might have talked about this in the past, but I think a lot of times pain is pain for people with sickle cell, and it's really important to be able to distinguish because you don't want to take an opioid for a headache, for example,
Mm-hmm.
or and so I appreciate you differentiating, that one, not all pain is equal, and two, because not all pain is equal, treatment shouldn't look similar for between those types of pains. So I have a question here from the community. What causes pain on the left side of the ribs or the lungs? Any insight in that?
Well, I mean, that's an interesting question. First of all, I would want to make sure that it's not anything that is like that could be potentially life-threatening if you're having pain on the left side of your ribs or your lungs. It's not something that's caused by your lungs. It's not like you have a blood clot that's gone there. So if it's really severe, if it's just came on, a severe onset, please communicate with your primary physician and make sure you get, evaluated for that. But if we're thinking of more like pain that's been there for a while, that's chronic, you're not having any other symptoms, then it could potentially be underlying musculoskeletal pain. It could be chronic pain from your sickle cell, it could be chronic pain from something else. And so I think it's worth kind of figuring out when the pain comes on, what makes it worse or better, and also just having a discussion with your provider in terms of what that pain could be. And I think what the other thing that's important is that people living with sickle cell disease, you understand your pain experiences more than anybody. And so really understanding, is this similar to crisis pain? Is it different? Is it in a different location? Is it triggered by anything? And really kind of getting a better sense of that pain experience you're having there. But
Yeah.
first, let's make sure that it's not anything that
Yeah.
is related to your lungs or anything
Follow up
like that, please.
your provider. Yeah. 100%. So I'm wondering, what does pain medicine look like right now for sickle cell? And is there anything new? I think the last time that we talked, we were talking about ketamine and
Mm.
sickle cell, or using ketamine for sickle cell pain. Is there any updates on that, or any updates on
That's
like
a great
what sickle
question.
cell pain medicine look like?
I wish I could give you a wonderful update that says that we have done, there's been this major clinical trial that has looked at the use of ketamine in sickle cell disease, and we can give you an answer as to whether it works well or doesn't work well. Unfortunately, there has not been one. There have been a lot of what we called case studies, which is basically
Mhm.
when clinicians and researchers kind of describe the experience of using ketamine for people who have been in the hospital setting. And the things that a couple of things that we do know. So right now, let's talk about what the ASH guidelines are for ketamine use, and then we'll dive into a little bit that we do know. So first of all, what is ketamine? So ketamine is a medication that is often used, usually in the anesthesia setting. And at high doses, it is an anesthetic that we use in the operating room. But what we do know about ketamine is that you can give it at very much lower doses. We call that sub-anesthetic. You can give it at much lower doses, and it helps with pain. And so it actually attacks a receptor or a molecule that's different from an opioid. And so it attacks a receptor called an NMDA receptor. And what it does is that it helps with pain. It can also, is believed to also help to reduce some of the side effects related to opioids, especially if you are on high dose opioids repeatedly. That can cause a different kind of pain response. It can heighten your pain response, and ketamine is believed to reduce that. And so right now, the ASH guidelines for the use of ketamine in sickle cell disease is really for refractory pain. So pain that has been, if you've been admitted to the hospital for a crisis and they've tried basically everything and it has not worked, ketamine could be considered as a potential. And if you were to receive it in the hospital setting, in most hospitals, usually a pain doctor will be involved at that point in helping to manage it, and it will be given as an infusion at low doses. I do like to mention some of the side effects, because I've had experiences from talking to some warriors and also caregivers who their kids or themselves are given ketamine and no one warned them about the hallucinations that can kind of happen, the out of body experience that could potentially happen. And for one person, it was very traumatic for their child. Because nobody said anything. He was given a dose of ketamine in the emergency department, and she thought something was happening with her kid because of the out of body experience that he was having. And to somebody explain this is an effect from the medication. So that is an important part. So what we do know is that the people whom ketamine may work for, it tends to work better in the setting where you're given it as an infusion in sickle cell disease. And it's just basically based on the case studies and the case reports. I've seen there are a lot of community hospitals, ED settings that love, in the ED, they love ketamine. And when we were doing one of our studies where we kind of looked at a large group of sickle cell warriors who received ketamine, a lot of them got like a single dose of it in these community hospitals before they got transferred to our bigger sickle cell centers. And I'm not sure if it's really beneficial in like that single dose. There's been one clinical trial that was conducted, I believe, in Uganda, and they didn't really show, dramatic results with that single dose, and that single big dose can cause more hallucinations. But the setting in which it could be potentially used according to the guidelines is really more of a slow infusion. And for people who have chronic pain and have sickle cell disease, it might be potentially beneficial. And the other thing that we have observed is that it's probably more beneficial if it's introduced earlier rather than later, which is a kind of a catch-22 because the guidelines are saying give it for refractory pain. But then, and so the setting in which it's being given is that after you've maxed out on the opioids, nothing's working, then you bring in the ketamine as if it's going to rescue someone. When we know that ideally it would be best to be introduced earlier on as an opioid helping agent, opioid sparing agent, meaning that it will potentially decrease the amount of opioids that's required.
Yeah.
And so, but it's for a small, right now, it's just a small group of warriors who've just had, it's been really challenging managing their pain in the hospital setting and who probably have an underlying chronic pain that ketamine can help with. Hopefully, Cass, we will have a trial. Everybody's been trying to put in grants related to a trial for ketamine in sickle
Yeah.
cell disease. Part of the challenge is that it's easily available. And so when you have a drug that's easily available and people can use, it's cheap. Sometimes you have to really justify why it needs to be tried, but it should be because if it's really beneficial, we should have some evidence for it. And it's also easily available and cheap outside of the United States. So that also would be very beneficial in understanding in more low resource countries.
Yeah. So I have a few questions about particular opioids, but I wanted to ask, so the people are asking about L-glutamine for pain, morphine for pain, and tramadol for pain. But you talked about hallucinations. How common are hallucinations with opioids in general?
Oh, for not the hallucinations I was talking about are more in the context of ketamine, which is is much
Mhm.
more common with that medication.
But are
Um,
they not, can you not get hallucinations from
You
other?
could with opioids, although that's less common. That's just really much more common and much stronger and pronounced with ketamine
With
than
ketamine.
opioids. Yeah,
Okay.
yeah.
Got it. Got it. Um,
Um,
so what are your thoughts on L-glutamine for pain?
I'm honestly don't have much experience of L-glutamine because my,
Okay.
role is more of dealing with like opioids and ketamine and more of an
Yeah.
anesthesiologist. So that would be something that would be prescribed by your sickle cell specialist. So I would not go outside of my area of expertise and comment on it since I don't have experience with that medication.
Yeah. How about so the question is, what about morphine? What does it do and what are its side effects?
That's a great question. So let's just talk about morphine is an opioid. So let's morphine, dilaudid. Those are in, you can dilaudid is given usually in the hospital setting. Morphine can be IV or oral. You might also be on oxycodone. All of these are opioids. And opioids are probably one of the largest group of pain medications that we have available and the oldest that we have experience with. And so these are medications that bind to an opioid receptor and they help with pain. We know that opioids are very helpful when you have acute pain. So pain that is caused by something that is happening in your body, right? In the case of sickle cell, you are, having getting poor blood flow to a certain area that's causing inflammation, that's causing tissue injury and so there's, that kind of pain. When that kind of pain is present, opioids are very helpful. And that kind of pain, the term that we use for it in the research setting is called nociceptive pain. So that's pain that is caused by tissue injury. And so opioids are really targeted towards that kind of pain. And so they help. Now, you asked about side effects related to opioids. There's a lot of side effects related to opioids, and that is part of why there's so much research into finding other drugs than, compared to opioids. And side effects could be there's respiratory side effects. So at high doses in certain individuals, it can affect your breathing. There's GI side effects. It can cause constipation. There is also the kind of the sedation, fogginess, slowness, kind
Yeah.
of the mind side effects related to opioids as well. And then, people often, when they're talking about opioids, also bring up the potential for abuse tolerance and dependence, which are all different things. And one of the things that whenever I give talks, and I'm going to give, because I don't know who the audience is, if
Yeah.
everyone that's listening are sickle cell warriors, that I always mention is, you know, a lot providers who are outside of the sickle cell space often get worried that, well, sickle cell patients may have more dependence on opioids or there's more risk for substance abuse. There's been several studies that have looked at this. And the prevalence of opioid abuse or substance misuse or opioid dependence among individuals living with sickle cell disease is not different from the general population. And so when I give talks, I always include a slide that says this. So if you are not going to treat, if somebody's presenting that has pain, that does not have sickle cell disease, and immediately you're not going to think about opioid abuse and substance abuse and dependence and all of that, all of those things for that individual, then you shouldn't think about that for the sickle
Exactly.
cell warrior either, because the prevalence is not any different. Now, tolerance is real and can happen with opioids. That means that, the more you're exposed to it, the higher the dose that you may require in order to get the same effects in terms of
Yeah.
pain relief as well. And then there's also a phenomenon that can be present that we called opioid-induced hyperalgesia. The extent to which it's present in sickle cell disease, we don't know, but it likely contributes in a little bit, in the sense that as you get to higher doses, the opioids themselves can actually change how sensitive you are to pain, where you develop a little bit more greater sensitivity to pain. So something that may not have been as painful in the past now becomes more painful. So that's basically a way of explaining
Yeah.
that. So there's a range of side effects related to these class of medications. Unfortunately, to this date, we don't have a medication when it comes to acute pain that provides the equivalent pain relief. But when it comes to chronic pain, we do know that opioids are probably not that helpful for chronic pain, and chronic non-cancer pain, at least. And they may actually be potentially harmful in the setting of chronic pain, which is why my research focuses a lot on that in sickle cell disease, because we need to figure out other interventions that can actually help and be beneficial for people living with chronic pain on top of their regular acute pain and sickle cell.
Mm. So we've had a lot of questions come in. This one is from TikTok. What do you feel about pain meds such as Suboxone for those who are post-transplant and sickle cell? Do you have any
Oh,
experience with that?
that's an interesting question.
Yeah.
I mean, well, first of all, getting on Suboxone should be a conversation between you and your sickle cell provider.
Yeah.
And so let's first, just to make sure we're all on the same page, try to understand what Suboxone is, right? So
Yeah.
Suboxone is what we called a mixed opioid agonist antagonist, fancy words, right? Meaning that it binds to these receptors in a way where it can provide some pain relief, but
Mhm.
also is not as intense. And it decreases some of the side effects associated with opioids. And so it can be a great bridge if somebody has been on chronic opioid therapy. So if someone's been on like high doses of MS-Contin or oxycodone for years, which is the case for some people, they've been on it for quite a long time. And maybe, after having it discussed, these discussions about going on something like Suboxone is really a shared decision-making discussion between you and your sickle cell specialist. So maybe after having that discussion with your sickle cell specialist, like you want to be weaned off of that long-term opioid that you've been on. This is a great transition to that.
Okay.
And there have been a couple papers that have looked at the use of Suboxone for sickle cell warriors who have chronic pain, who have been on chronic long-term opioids. And in fact, I'm collaborating with Dr. Sophie Langstrom and Dr. Julie Cantor on a grant that we just submitted that hopefully will get funded, because there'll be a large clinical trial that looks at the use of this in sickle cell disease in general. But that being said, and I forgot the person's original question. Can you remind me
The
so I answer
Suboxone
the question?
Suboxone post-transplant.
Post-transplant, that's what it was.
Yeah.
So if you're still on, and this can happen, we know from, some early data that individuals who have had a bone marrow transplant from sickle cell disease and have been, cured from a sickle cell perspective, they may still have chronic pain.
Yeah.
And actually, there's a paper that quotes that about 40% of those who have chronic pain may still be on long-term opioids. And goes back to the point of really understanding the chronic pain and trying to prevent it before it kind of sets in. And so if you're still, on long-term opioids, you still have chronic pain, this can be an option. And I would say discuss it with your sickle cell provider. That's the kind of like the context in which I would imagine Suboxone would be considered.
Okay. Okay. And I haven't heard of this therapy. What about pethidine? What does it do? Does it have side effects? Is
I'm
that
not
an
sure.
opioid?
It
Opiate?
might be I have to look it up. It might be an opioid,
Okay.
pethidine. I will have to defer on that question because anything I would say would not be accurate at this point. So I'll hold off on that.
Appreciate it. So does adding NSAIDs to opioids reduce your desensitization to opioids?
Oh, that's a good question. So it's not the NSAID specifically. What we do know about treating pain is that pain should be treated from a multimodal perspective, and that's a term we like to use a lot in the pain world. Multimodal means that it shouldn't just be one intervention that's attacking the same pathway. So if you are treating pain, it shouldn't just be like you're on just opioids, right? We have you on, like MS Cotton, and then we're giving you boluses of, morphine when you have breakthrough pain, and that's it. Because the reason being that you're only addressing pain through one receptor and through one pathway, and we know that that's not the most effective way to treat pain. And so it is important that you address the pain through multiple pathways. And so adding on things like NSAIDs, if it's appropriate for you, because we do have to be careful about NSAIDs because a lot of sickle cell warriors do have kidney problems. And so if your provider thinks it's appropriate, adding on, like if you're in the hospital setting, something like ketorolac might be helpful, or an oral NSAID if you're outside of the hospital setting. But you as a warrior have to be empowered to understand if that's, you have normal kidney function and whether that's appropriate or not and how much to take and for how long. And so NSAIDs work through a different pathway. They're anti-inflammatory drugs. And inflammation definitely plays a role in pain, especially in pain crisis. And so they work through that pathway and they could be potentially beneficial. Tylenol also has been studied in sickle cell disease, is adding that on. They're analgesics, but they're not as strong analgesics. But the goal is to add on things that are address things from different pathways. And then the important thing I want to add to that, an important part of the answer I want to add to that question is that when we think about pain interventions, it's not just medicines, right? When we talk about addressing
Yeah.
things via different pathways, there's also non-medicine pathways that can be addressed, right? And can be, tried. And so whether it's, non-pharmacological interventions such as, some people use like heat, some people use, yoga, some people do meditation, some people, have movement-based things that they do as well. Some people have tried cognitive behavior therapy to acquire, coping skills. We're not saying use all of these things alone, but these also are attacking different pathways that relate to pain. So it's really making sure that we're addressing different pathways and when they all are packaged together, that can help to address pain as well.
That makes sense. Not pain isn't one size fits all, so gotta tackle it from multiple modals. We had a question about withdrawal. Is withdrawal from pain meds after being discharged from the hospital normal? And I guess what should hospitals be doing when they discharge you after um a pain crisis, right? And treating crisis with heavy opioids. Should anybody be discharged and experience withdrawal after being discharged?
Um, So there's a couple of things embedded in that question. The ideal in most places for treating a pain crisis is that you have some kind of individualized pain plan for when you're admitted. And so, for instance, Dr. Paula Tanabe has done a lot of work related to individualized pain plans in the ED setting for sickle cell warriors, so that when you do get, show up to the ED in North Carolina, for instance, that you've already had a plan that you've worked out and discussed with your hematologist, and that plan is implemented. And I bring that up because when you have plans like that at discharge, it usually kind of dictates where we're gonna transition you to, from the IV opioids to what oral opioids you're going to be transitioned to. If you're experiencing withdrawal symptoms, that's usually in the context of people that have been on long-term opioids, and perhaps the dose has decreased significantly. So that shouldn't be something that should happen. And I think if you're experiencing it, at the time in which they're titrating down your opioids, you should have, a discussion with the team that's taking care of you, and then also make sure that you're plugged in for follow-up with your sickle cell specialist as well.
Okay. Next question I have from the community is there anything we can really do to prevent a crisis or pain from happening?
So that's a great question. The biggest thing is just, I wish I could say we could prevent it in all individuals, but the thing that is most beneficial is making sure your disease is well controlled.
Yeah.
Because a pain crisis, right, is a marker that something is happening from a disease perspective, from a sickle cell perspective. And so making sure that you are following whatever it is, the treatment plan that you and your sickle cell specialist have decided on, taking the medications that you've been prescribed, the disease modifying medications. Of course, there's also the outside of the medications, important things like staying hydrated. Stress also can play a role, weather can play a role, but all of these things. But basically, the big part is just really making sure, as much, we can't control everything, right? But as much as you can play your part, that your disease is well controlled, you're adhering to your treatment plan, you're plugged into your providers, et cetera. Because that is what a pain crisis is. I, often say when someone is having a pain crisis, and I do a lot of education with providers who are not sickle cell specialists, because I think it's important for those of us who are not sickle cell specialists, but maybe work within that space in a multidisciplinary perspective, to educate all providers, because you might see someone in the ED, you might see someone in the operating room. And what I often mention for providers who are not specialists is that we have to remember that a crisis is a marker for underlying disease activity.
Yeah.
So pain is the symptom, but that means that there's underlying disease activity. And so you have to make sure that other organs are not being damaged as a result of the crisis. So the best thing that you can do is really making sure that you're doing all that you can to manage your disease, understanding that not everything in life is within our control. There's only so much you can do. But the best that you can do to the best of your ability is important.
Yeah. So what I'm hearing is, managing your disease is the best way to, um, control pain. And also pain is an indicator that something is going on behind the scenes that they're not behind the scenes anymore if you're in pain. But
Something is going on in your body, right?
Yeah.
You're
Yeah.
having a crisis in your body. It's an indicator that there's vaso-occlusion that is occurring, which is the term that we're using, and it could be occurring in other parts of your body as well. And so just really, I especially to our adolescents and young adults that are listening, I know life is hard. I can't imagine going through being a teenager and being a young adult, and then having a chronic disease. That is really difficult. But to you all especially, because I do know that some of you get lost in that transition period. And it is also hard when mom and dad were helping you to manage things and take your medications and go to your appointment, to all of a sudden they're not, as involved, or you're seeing an adult provider, not a pediatrician. There's less hand holding. And so that's where I think that age period in which a lot of, unfortunately, for lack of a better word, damage to the body can occur. And so, make sure you have a good support system, that you're plugged into a good support system that can support you, to help you manage your disease during those years, because you don't want to reach 30, 35 and, have some damage to your body because we weren't able to manage during that time period.
Yeah. So you talked a little bit about this earlier, not all pain should be treated equally. What does chronic pain treatment look like? We kind of heard from acute pain, which is, heavily based, I guess, treatment is heavily based in opioids and NSAIDs. But what does chronic pain treatment look like?
That's a great question. And I wish I could tell you that chronic pain in sickle cell disease is proven to be, if you treat with X, Y, and Z, is effective. We don't really know. Because once again, we really started paying attention to chronic pain in sickle cell disease not too long ago. And so we're still trying to understand it. Is it very similar to other chronic pain disorders, or is it different? Or what are the overlapping characteristics? What are the things that make it different? Those are still questions we're asking. With that being said, there have been some things that have been shown to be potentially beneficial in the chronic pain setting. And so when it comes to medicine interventions, sometimes for medicine interventions, things like antidepressants are used to treat chronic pain. So these are the serotonin reuptake inhibitors. So things like Lexapro, for instance, especially if someone has an associated mood disorder or mood challenges, that can be beneficial. When people have pain that has chronic pain that's like neuropathic, where it's caused by injury to the nerve, where you can have like tingling, shooting, electric-like sensation, those kinds of symptoms, you might see medications like gabapentin or Lyrica that are tried in those kinds of settings as well. And then you can have chronic pain that is just primarily caused by that reset of the central nervous system, where it's like seeing pain at a lower threshold. And in those cases, we see that non-medicine interventions are much more beneficial. And so things like cognitive behavior therapy can be very beneficial. This is really, and what I want to add here is that if someone is having chronic pain because of that reset that I'm talking about, and maybe they present, their labs are normal, we can't find biologically, abnormal labs or things to explain that pain, and it's caused by that reset, it doesn't mean the pain is not real.
Yeah.
It doesn't mean that pain is not real. An example that I can give is, and I use myself as an example, where I don't have a chronic pain disorder, I don't have a pain disorder, but there was a time in my life where I was under a profound amount of stress. And I just woke up with this severe pain in my chest. I've never experienced it before. I knew I wasn't having a heart attack, because usually we have severe pain like that, that's not how usually that presents, but it was severe, but I knew something was off. It was so bad that in the middle of the night, I told my husband, like, I need to go to the ED. And so I went to the emergency department. They did a full workup. They couldn't find anything. And then so, as it happens in the ED, oftentimes when you present that way, they give you a dose of Ativan. And they gave me a dose of Ativan, which is a anti-anxiety relaxing medication. They gave me that dose and the pain went away. Now, was that pain not real? Even though they didn't find that there was an issue going on in my chest, or they did all kinds of imaging, they did labs. Was that pain not real? No, it was real. It was enough to wake me up in the middle of the night,
Yeah.
find a babysitter for my two young kids, and have my husband take me to the ED. So it's very, very real, right? But how I dealt with that experience is like, okay, I need to manage my stress, my anxiety better because my mind is connected to my body and I can feel real physical symptoms when there are things going on in the mind. And so I say that to say that that doesn't make a person's pain less real if it's from that reset. And then if that's the case, things like cognitive behavior therapy, non-medicine interventions can be really beneficial in those settings.
Thank you so much for sharing that because it really does paint the picture. Oftentimes, as you know, sickle cell patients in a clinic setting, our pain isn't believed. And I wish more providers would come from the standpoint that you just shared, that the pain is real and, you know, where it originates doesn't matter as much as the pain being real at the end of the day. So it's really good to hear that. Um, you touched a little bit on this earlier, but does your work involve better defining what a pain crisis is within sickle cell?
No, my work focuses primarily on better defining chronic pain within sickle
Okay,
cell. So not so
okay.
much focusing on pain crisis, but the chronic pain aspect.
And so within chronic pain, what subgroups do we find here? I think you mentioned the hyperalgesia. Is that considered chronic pain hyperalgesia?
Yeah, so the hyperalgesia I mentioned is more of something that can contribute to
Chronic.
the development of the chronic pain.
Got it.
And so is your question kind of more focused on subgroups of people that you see chronic pain more dominant in the sickle cell, or just trying to understand the
I
question
think
more?
what I was thinking was in the same way where you can, or I guess, categorize different types of acute pain. How
Hmm.
can you categorize chronic pain?
Oh, that's a great question. So within sickle cell, the good thing is that some of it has been categorized a little bit. And so you can have chronic pain from a complication related to sickle cell disease, right? A common one is people who have avascular necrosis and have to have a joint replacement. You can have chronic pain from that because or people who've had like recurring leg ulcers that's also a complication from sickle cell, and you can have chronic pain from that. And then you can also have, in the context of sickle cell disease, chronic pain that's not related to a complication from sickle cell disease, but is related to this repeated experience of having pain pretty much your whole life, and that
Mm,
and the central nervous system kind of resetting and changing how it processes pain. And that kind of chronic pain, we call that more centrally mediated chronic pain. Or if you really want to get fancy, the fancy word is nociplastic pain. And that kind of chronic pain is the one that's more responsive to the non-medicine interventions. Now, within sickle cell disease, do we have clues about the individuals who go on to develop that kind of chronic pain? And the reason why I'm interested in that is because that kind of chronic pain, it stays there and it's challenging to treat, and it can still be persistent even after your disease is under control because it's kind of almost a separate entity. It developed as a result of the disease, but it becomes its own separate entity, right?
yeah.
And so people who tend to, we don't have all the answers, but we do know that that adolescent, young adult period is the highest risk period for developing chronic pain, that kind of chronic pain. And so if we're going to design interventions, it needs to be really focused on our teenagers and our young adults in that time period as well. And then also, it does appear that people who have, I wish I could show, I have usually this visual that I show when it comes, that shows like different contributors of pain. So we do know there's like psychosocial aspects that also contributes to this development of that kind of pain. And so like poor social support structures, for instance, can contribute to it as well. We do know psychologically, mood disorders, anxiety, depression, poor coping skills, all of those can develop from having pain experiences and also having those challenges can also play a role in developing that chronic pain as well. And so there's different factors. And so hopefully that kind of clarifies it a little bit.
Yeah. A question came in. Can you talk about why it isn't good for those with sickle cell to use aspirin when having pain?
That's a good question. So aspirin is really not that might I don't know if the person who was asked that question is not based in the is based outside of the US,
Oh,
but
okay.
you in the US it's really not a pain medication. And it can actually cause more harm than good. It doesn't really help from a pain perspective. And so if we wanted to use an NSAID or something that kind of similar in that class that really does address pain, then you're really looking at things like ibuprofen, for instance. No, it was ibuprofen. I was going to try to think of some other names that might be more internationally friendly, but but ibuprofen, Toradol, Ketorolac, Mobic, which I'm blanking out on the generic name on. And so, but these are more the NSAIDs that actually are analgesias, meaning like medications that are intended to address pain as opposed to aspirin. And so that is not something I would recommend for taking for pain, but my guess is that question is probably from outside the US, where in different countries, particularly in Africa, it might be actually used in the pain setting. And that has more to do with challenges with access and pain medications.
Mm. So it's available, and
Yeah.
so therefore used for
Yeah.
pain for
And
sickle
yes,
cell.
and the other things that we might typically use here is not as easily available. And so therefore you might see people using it as a result of that.
Got it. Got it. Um, Somebody asked, I was once told that tramadol is for cancer patients. Is that true?
No, I'm not sure why you were told that, but tramadol is a pain medication that is definitely I've used it before for non-cancer patients. And so can be used outside of that context. I wonder if the person who was having this discussion with you was thinking more of, is if somebody has chronic cancer pain that they might be on that medication, but tramadol is definitely used outside of the context of cancer quite frequently. So
Is anybody doing work in like coming up with a pain medication specifically for sickle cell at all?
that's a great question. Not that I'm aware of, that's specifically for sickle cell. Most of the trials that are when it comes to medication development for sickle cell are really about focusing on addressing the underlying cause of the disease and not necessarily, and because if you do address the underlying cause of the disease, right, the hope is that you'll have less pain crisis
Less
because the pain
pain.
crisis is caused by the actual disease activity. And so that's where most of the focus is. When it comes to symptom management, managing the pain and just pain medications in general, I'm not aware of how most of the studies that are focused on trying a pain intervention in sickle cell are interventions that have been tried in other conditions and it's like, okay, let's see if it actually also might be beneficial in sickle cell disease. That's usually the context.
Mm, okay. Okay. And go ahead and ask your question. Someone says I have a question for the doctor. Um, Let me see what else I have here. This is outside of pain, but somebody asked, what about Pen VK? Is it advised to take for sickle cell? Is there anything you can share about that, Doc?
I don't have much experience outside
Okay.
of it, so I'll defer
Yeah.
on that. Yeah.
Pen VK is okay. Sorry, the other question coming to answer Pen VK is the penicillin used, and I do believe this person's outside of the US, and so yeah, penicillin is used in children. Um, that are young children with sickle cell to kind of fight off life-threatening antibiotics. And so it's not necessarily tied to sickle cell and pain, but advised. And Dr. Key, you probably could speak to this a little bit more about penicillin in sickle cell in kids with sickle cell.
So yeah, penicillin is given to children with sickle cell disease because they have uh, immune problems secondary to their spleen function. So it's usually given about 2 months of age up to about 5 years of age to not prevent infections, but to give the parent enough time to realize that their kid is sick and bring him into the emergency room where they get a more definitive treatment for their um, infection and worked up for that. Um, Most people would stop penicillin after about 5 years of age, but because you have no splenic function usually after that, your spleen has been damaged so severely that your infection risk goes on for the rest of your life. So that's why we have people come into the emergency room and their temp's 101 and they have any other symptoms. But initially, it's to prevent uh, death in children who are very young, under 5 years of age.
Um, all right, so another question that I saw come in, it's again about Suboxone. And this is a clarifying question, Dr. Kenny. Why is it they're using Suboxone for pain management when I thought it was for people to get off of opioids? Can you make that distinction?
So that's a good question. If somebody has been on opioids for a really long time, your body does become kind of is dependent on it. So you can't just take the person off of the opioids just like that. That will cause incredible withdrawal symptoms. And in some people, depending on the level of withdrawals, it can even cause them to land to the hospital, or even, potentially die if they've been on high dose opioids for a long time. And so there's two options. You can taper their opioids, was the term where the dose is like slowly decreased incrementally. And then for some people, they choose, in addition to kind of starting the taper, you can taper to off completely, but that takes time. And that is something that you will be, doing with your sickle cell specialist and potentially some other multidisciplinary pain person that might be helping and assisting in that process. And then the other thing is that you can start weaning your opioids, so decreasing the dose and come onto Suboxone, which still provides some of the agonist or the effects of the opioids in treating your pain, and also prevent some of the withdrawal symptoms as well. And I know Suboxone is it can be, what's the word? There can be some stigma attached to it because it is used in the context of opioid abuse. And so you might hear of Suboxone and methadone, clinics where people who are trying to come off of, uh, opioids, like heroin, for instance, might be on that, but it's also used. Methadone and Suboxone are also used in the medical setting. So, for instance, methadone is a medication I use a lot in the pain world, and because it's a long-acting opioid, right? So that's not the only context. That might be the cultural context in which we hear these drugs, but that's not the only reason to use it. And so Suboxone can be an option for people who have been on opioids for a really long time. You can't just stop it like that when you've been on it for quite a while. Um, you have to slowly wean the person off, and that can be part of that process.
Yeah. So I know we're coming up to time here, and we have our next guest, but I did want to ask one last question before signing off. And uh, that question is, what would you prioritize within pain and sickle cell? when it comes to research? What is it that you, I guess, desperately think should be answered that could change, that could be life-changing for patients when it comes to pain?
We should study pain in younger and younger ages.
Mm. And
And the reason I say that is because if our goal is prevention, as with anything else, then we really need to focus on our pediatric population. We need to, I mean, the ideal in my ideal world, and this is if I could, shape the world and
yeah.
create a research study where, because I have endless amount of money to fund it and endless amount of time to do it, I would actually do a study where I'm studying a group of warriors
Hmm.
from the ages of probably from 10 all the way to 21 when it comes to pain. And the reason is because we know something changes in that adolescent period. And hormones probably play a role in it as well. The social aspects play a role, the psychological aspects play a role. Something changes where we're no longer having pain crisis, but the crises are changing, pain is becoming more persistent, chronic pain is developing. And so if I really want to understand, even for a crisis perspective, if I really want to understand pain better, then I will really focus on the younger ages, and also start um, incorporating, I guess, more non-pharmacological interventions in the younger ages. Start teaching them about pain. Start teaching them about how the body sees and processes pain. Start equipping them with coping skills at younger and younger ages. But that will be the ideal. It will be very hard to get this day and age to get the NIH to fund a study that's 10 years long. It would have been hard even before, but not even harder. And so we are trying. So some of the things that we're trying is to try to look at different things. So for instance, I'm working with somebody to look at data that has already been collected in about 13 children's hospitals across the country, just part of PCORnet or PCORI, and to try to study that data that's already there, to try to use both. I hate to use the term AI because that's so that's a can of worms, but use that to see if we can find any patterns in the data that's already there. And then use that to give us an understanding to design a study that doesn't have to be as lengthy, and to really help understand things. The last thing I would say that's not pain related, if I had a magic wand
Yeah.
to fix this world, there's many things I would do. But one of the things that I think is really important that I would like to end on is that we need people to be more involved in research. More involved does not mean just participating in a study. We need more people to participate in studies. If you look at overall at clinical trials in sickle cell disease, less than 20% of the people who are eligible for trials actually enroll in trials. There are so many clinical trials for sickle cell disease that don't meet the enrollment goal, that close early because they weren't able to meet the enrollment goal, that aren't able to keep the patients in the study. And this is not the fault of the participants. This is not the fault of the community in any form at all. This is because there's a lot of complexity that has been created in the whole research and healthcare infrastructure. There is a lot of things that have bred mistrust. There is a lack of transparency. There's a lack of good communication. There's a lack of partnership that from researchers and healthcare systems don't seek to partner with the community and bring the community on board at the very beginning. And so what I would like to end with is that we need to figure out ways to empower the community to be involved in research, not as just as participants, but in collaborating with researchers to actually help design studies, to help address some of the logistical barriers that make it hard for people to enroll in studies, to really kind of really just work as research partners, work hand in hand. There's a proverb that I love. If you want to go quickly, go alone. If you want to go far, go together. And so we've been going it alone, and we're not making the largest impact. And if we can all come together and go in together, we are going to go much further and make a bigger impact. And so really bringing the community on board as research partners, that's my ideal world.
Oh, what a great thing to end our conversation on. And yeah, I completely agree. It's some of the work that we're trying to do with Sickle Cell 101. So
It's $10.
I appreciate so very much you coming in and, kind of sharing your expertise on um, pain and sickle cell and particularly chronic pain. I think I learned a lot within our conversation and the distinction between the two and how this is a multimodal approach. It's not a one size or one way fits all. And so thank you so much, Dr. Kenny, for coming and imparting uh, your expertise and your knowledge on us today.
Well, thank you both for having me. It's always my pleasure.
Thank you.
Take
Happy World
care.
Sickle Cell Day.
Happy World Sickle Cell Day to both of you too.
Thanks. Um, so we did get a few questions that was outside of the scope of pain. Somebody did ask about eligibility in bone marrow transplant, and we have a provider coming in a little bit later who can answer some of these questions. So, um, if you would like to, stay on either until that provider comes or that we have an adult sickle cell specialist who can answer some of these questions, especially the one around sperm count and hydroxyurea use, and then also we had, oh my gosh, the person who asked birth control and perimenopause. We had Dr. Faruqi, actually, a few people before Dr. Kenny, and she was answering questions specifically around menopause and sickle cell. So this live will be saved. We can go back to it, and hopefully you can watch some of that. But if you still really like to have the answer to that, we can also ask our adult specialist. So our next expert is an expert on sickle cell trait. So get your questions ready surrounding sickle cell trait. We have a Dr. Stephen Boateng. He is actually part of the Sickle Cell 101 team. So this will be kind of like a family reunion in a way. So let me go ahead and get Dr. Boateng here, and we will go ahead and start answering questions about. He's also a pharmacist too, so you can ask him questions about drug therapies. I'm gonna add him in. So feel free to ask questions surrounding sickle cell trait. And like I said, Dr. Boateng is a pharmacist by training, so you can ask him your drug questions as well.
Right
Your
off the
questions
bat, I just get
around
thrown in like that, huh?
medications. Give him
Hi,
some
Dr.
tough ones
Q.
because he thinks he's smart. No, I'm playing. I'm playing. So it's all banter with Dr. Boateng. He's my frenemy. And hi Stephen. Happy World Sickle Cell Day.
Happy World Sickle Cell Day. I'm glad to be here. I love how you just threw me with all the questions, but how's it going for you guys?
It's been a very, very eye-opening and an informative morning. Heard we just got off with Dr. Kenny.
Martha, yeah, I was listening to her a little bit, so I heard a couple of it with the pain talk, which was awesome.
Yeah, we had Dr. Faruqi who discussed menopause and reproductive health. And then we had Dr. Vivian Sheehan, who is just excellent in sickle cell research. And now we have you, who you'll hopefully be answering questions around sickle cell trait.
Yes.
But before we dive into that, tell us a little bit about your background, Dr. Boateng.
Holy moly. Thank you. First off, for anybody who doesn't know me, Cass is my little sister. Even though she won't admit it. But my name is Steven. I was born in Ghana. That's my home, which of course, those of you that know sickle cell, of course, ties into why this is important for our African community. But beyond that, I am a pharmacist by training. My actually full-time job is in breast cancer. That is where I spend a lot of my time as a medical scientist, medical science liaison doing that work. Um, but sickle cell is, I call it what got me started in healthcare. If it wasn't sickle cell, I probably would be doing something different. That is because I have a sister who lives with sickle cell disease. She's probably on here or not. Like to give her a hard time. But she's truly what inspired me to be a pharmacist, quite frankly. I like to tell people about how when I was little, growing up in Ghana, my dad, my stepdad, and my mom always sent us to go get her folic acid at the pharmacy. And I had no idea what all these medicines were. But what I knew was she was the one that had to go to the hospital a lot, had to take this medicine every day. And it always got me curious. So I think when I got the opportunity to just dive into healthcare, she just centered me around what I do. I will caveat and say, I tell people all the time, my job in healthcare is to be a patient advocate first. Personally, I think is the most important thing that all of us in healthcare have to do. I think both of you will agree. But oftentimes we forget. And for me, that's how I challenge myself. So whether I'm doing breast cancer, lung cancer, you name it. The only disease state that centers me to be a patient advocate first is sickle cell because I think about my sister and I'm probably going to go off a soapbox, but it's my selfish interest in healthcare. And that's what inspires me to also treat other patients as an advocate first. So that is really me. Of course, my work with Sickle Cell 101 and my foundation is very well documented. You guys know Sickle Cell 101. We are the largest global nonprofit that leads all sickle cell work from education, research, awareness, you name it, both in sickle cell disease and sickle cell trait. But this work is important. That is why we are on here. That's why we're doing this stuff because you may be on here, you may not even know anyone with sickle cell, or maybe like, oh, why am I sitting on you? Why am I learning this? It impacts all of us, regardless of whether you're blue, purple, pink, black, you name it. It impacts everybody. I'm going to explain when I get these questions, but that's me. That's why I do sickle cell, and that's why I'm excited to be here to talk about sickle cell trait. And I am open for any questions and any thoughts.
Thank you. I will start you off with a trait question. I want it to be a tough one too. Um, I guess what should people know about sickle cell trait in research right now? What are we looking at, and what's the latest that's come out about sickle cell trait?
You just came in firing hot. So I'll give you guys one. And Cass, I'm gonna tell you guys, there's data that just got presented at one of the biggest oncology conferences in the world. It's called American Society of Clinical Oncology. I was over there in Chicago. This is about 2, 3 weeks ago. One of my good friends, also based here in Houston, Dr. Pavlos Musa. We actually, Cass and I did an interview with him years ago because we would talk about sickle cell trait. And I think the biggest research came out over there. There's a drug called panitumumab. And I don't want you guys to get bogged down with the drug, but this is a first time ever a medicine has been studied in this cancer. It's called renal medullary carcinoma. And again, let me backtrack and say, I always like to caveat and say sickle cell disease, sickle cell trait, as you guys have probably learned over and over, it's not the same. People live with sickle cell trait typically experience nothing. They do just fine. But what I always say is that the fact that something is rare doesn't mean it cannot happen. So the education is just to help us stay informed, right? So we know about sickle cell trait because it impacts our family planning, but also the other things, right? So back to Cass's question, this data that was presented there was about renal medullary carcinoma. This is a type of kidney cancer, one of the most aggressive types of kidney cancer that, for some reason, almost everybody that gets this kidney cancer is of African, Black or African descent and has sickle cell trait. Most often younger, mostly actually men, but also can happen in women. And so that's what Pablo's does. That's his work. And again, most of these people, it is sad. Usually we find out these cancers in the metastatic setting. That's kind of when it's kind of, moved around the body a little bit. But they did this study. It's not officially approved. Again, it's a new option that hopefully can be done more. And the long and short of it, it showed that I think it was about 26 patients in this study. Most of these patients had their tumor shrink to over 50% with, I believe about 5 or 4 patients had a complete response, which is a big deal. Because if you guys, again, I love sports. When I'm not talking about sickle cell breast cancer, Cass knows I like talking about sports. So I'll give you guys a sports example because sometimes it helps us relate. I talk a lot about Ronnie Hillman. This guy is like this famous Super Bowl player for Denver Broncos. Um, He passed away from renal medullary carcinoma. There is so many other people who have had this condition that unfortunately passed away in a few months. So I think it's important to talk about the famous names again, not to scare people. But this data that we just saw at ASCO just showed some promise for these patients that I'm super excited about. So we can dive more into another time. But I think to answer your question, I think that's probably the biggest news when I think about sickle cell trait. There's one more, but I'll save it for later around testing.
Okay, I'm gonna remind you, testing. Let me make note. Testing and sickle cell trait.
Maybe later.
All right. Um, I have two questions. Both of them are about aging with sickle cell trait. How does trait impact older women over 60? Is there any research surrounding that that you know about? And then also, are there things individuals with sickle cell trait should be aware of, especially as they get older? My father has a trait, and I feel like he presents similar symptoms as me. I'm guessing the person does have sickle cell disease. Oh yeah, me with sickle cell, the older that he gets. So, what do you know about trait and aging?
That's a great question. So let me start where you began, specifically with women, right? So you had talked about aging, particularly for people with sickle cell trait. Again, I'm probably going to be saying this. You guys going to get tired of me saying it. Sickle cell disease, sickle cell trait are not the same, right? But what we do know is, particularly for women, the one of the biggest studies that was ever done, it's actually beyond sickle cell. Um, it's by a women's cooperative group, and they studied women across different ages, across different disease states. One of the subgroups in that study, this is a very old study, but it's still important, was looking at when you think about, so, of course, not every woman, let me caveat it and say, but some women take something like birth control, right? From a hormonal standpoint. And what we do know is not all the time, again, not all the time, but one of these studies did show that, even regardless of sickle cell disease or sickle cell trait, people with AA, when we talk about taking like birth control and some medicines, we talk about the risk of having clots because it can come with it. It is very rare, right? And so for people with sickle cell trait and also with sickle cell disease, some of these studies did show they slightly had a higher risk compared to the typical population. So that's kind of in the back of a lot of people who do this work's mind. So back to women, as we know, of course, from a hormonal standpoint, and so for women also who may be taking or have taken birth control, does this escalate that risk? We do not know. But I think it is important that we bring that awareness. And so, what I do know specifically about as people get older with sickle cell trait is just really remembering what are the things that are changing from your health standpoint that used to be normal. Um, I will also add to, again, I want to really put emphasis on the women here is that if it's someone who maybe has had never taken birth control, had never taken any type of medicines that maybe could have increased their risk of some of these things that we know in sickle cell trait, which I think Cass is going to ask me about, these rare triggers and complications, right? Some of it is medicine. And so I think as people get older, if they have sickle cell trait, it is important for them to just pay attention to their health, what's changing, what's not changing. I talked about the kidney health a lot earlier. As people get older, our kidney function gradually declines. It's just part of human nature, right? Of course, everything starts slowing down. Now, what we do know, like I said, right? If you're getting older, maybe you're seeing blood in your urine, or you start to feel these red flank pain, all these abnormal stuff. Is it sickle cell trait related? Possibly not, but I think it is worth taking a look at. So I would say if you told me a woman who has sickle cell trait, what should they be looking out for as they get older? The totality of your health, your physicals, everything. I shared something earlier about getting our physical, adding our sickle cell trait, and checking everything. Don't think about you as sickle cell trait, so something special. Just still do the stuff you typically do. But if something comes up that's abnormal, I think it's better to be proactive and also let your doctors know. Um, Even as a healthcare provider, I've had to have tough conversations with doctors because not again, I'm not seeing every doctor, but some don't even know about any of some of these things we're talking about it because this stuff is rare. So as you get older, maybe you advocate more for your health. But if you find anything that's abnormal compared to what you typically see, I think those are the times that you should be worried about. Um, and I think you had asked the second part of your question is just the general population in general. Did I get that part right?
I'm rereading this. The second part of the question was, my father has trait, and I feel like he presents similar symptoms as me with sickle cell the older he gets.
I'm gonna take a good guess. They're possibly talking about pain, right? That's my guess. Now, there is a very, very, I call it touchy topic in our sickle cell world, right? When it comes to pain, there are some people that say they have sickle cell trait and they experience pain that maybe look like sickle cell disease. Now, my thought process is it is definitely not going to be the same as people with sickle cell disease. But is it possible? Possibly. And so what I will say is if you have, or if you are someone, or like for this person's question, maybe it's a parent who typically is experiencing pain or all of these symptoms that make them feel like some of the things they get at sickle cell disease. Number one, I would say, can they double check and confirm if they truly have sickle cell trait, or have they had sickle cell disease and never known, or maybe had a milder form of sickle cell disease that we do not know? Because that's another big gap that we don't talk about. And I always like to say, I don't know where this person lives, right? If we take the US alone, only about 20% of Americans, all Americans, know their genotype. And I tell people all the time, it's not because people don't want to know their genotype. If they wanted to, they would. But if we talk about history, right? Like today's also Juneteenth, which brings back history, right? But if we talk about the history around sickle cell testing, why there's this big gap, it wasn't up until what, the early 2000s that every single state had the mandate pretty much done, where every state does these newborn screenings, right? So
Yeah.
I'm pretty sure there may be some people who still were born and their parents didn't know their genotype. And then in the past, there used to be times when if they had a child born even tested, and if let's say the child had sickle cell trait, because of how it was perceived or it is perceived, some send letters, some make one phone call. I did this, it's like my little project I did for myself where I was trying to figure out how do all these different states approach making people aware about their genotype, right? And I think I did probably like 16 or 17 states. Most of them they do their due diligence. I'll give them credit. It's a phone call, some send a letter. Sometimes I don't check all my mail. I'm being fully honest here. So a lot of people get missed, or people move and may not see it. Or one phone call, you leave a voicemail, people may not see it. So I think there's still a lot of people who do not know their genotype. And let's be honest too, some people maybe the test that was used to determine their genotype may not be the most accurate. I always say my always gold standard is of course electrophoresis, right? But some people maybe have used had to use maybe a point of care test. And again, nothing wrong, but I'm just telling the reality. So if it's someone who maybe they may have had some form of sickle cell disease, they never know. We've seen these stories too, by the way. This is not an example. I have a personal story of someone in Ghana who, for the longest time, rest in peace to him, one of my teacher's brother, and for the longest time, he thought he had sickle cell trait. And so my teacher literally called me and said, I think my brother has this thing you always post online, man. Like it was like a funny joke. He's like, can you talk to him? He's no more with us. And so I said, yeah. So him and I actually became good friends. We started talking. And I said, man, can you go check? Can you go check? Can you go check? And eventually we helped pay for it and he got tested. He had sickle cell disease. So that's also another element to this question. So I would always say just confirm if people are having symptoms that make them feel like, and maybe I have sickle cell disease. Let's confirm the test. And if it's sickle cell trait, we're not nullifying that because you have sickle cell trait, you shouldn't experience any symptoms. Maybe you have pain because of maybe another secondary illness, whatever it is. But I think knowing the true diagnosis is important. And also, too, as we get older, a lot of things change. I feel like I have an old man ankle, an old man brain, all the 9 yards too. And I think as people get older, if you have sickle cell trait, I would say that is the time when we should pay a little bit more closer to our health, particularly getting our physicals, having doctors that you can trust that will listen to you. That if you have things that you feel like is wrong and they're not listening to, you can fire them. I'll end with this, Cass. And again, I'll share this personal note. For those of you that do not know, I have sickle cell trait. So maybe that's why I have the selfish interest, right?
I didn't know if you were disclosing that or not.
because it's important. But here's the thing. I think this is important. I know not everybody can do what I did, but I had to fire, quote unquote, a doctor, right? So when I go to the hospital, like I like do my physicals, and again, I shared a post earlier. I don't like telling the doctors I'm going to see that I'm in healthcare. I don't like it because there's something magical that almost always happens, right? You walk in, maybe I'm in my like, regular outfit, I have my hat on, whatever. It shouldn't matter, but we all know these things are part of healthcare. You may get treated a little bit differently. But the thing I find interesting is sometimes like let's say a word or two slips out of my mouth. Like, oh, do you work in health? And then they find out, then the care changes. And again, I'm speaking from a lived experience. It's happened to me several times. This is recently. For the longest time, this is not related to sickle cell trait, but for me, I think Cass probably know like a lot of foods my body cannot tolerate. So I went to the one doctor. I said, I want you to do every test. I just want to figure it out. They were not listening to me. Again, she had no idea that I'm in health, and I refused to tell them. And I kept asking questions. Eventually, I pretty much was like, I'm done with you. I said, I'll find a second opinion. The second doctor I went to, I said, listen, before you even start telling me all the things you want me to do, I want every single test done, please, and I will pay for it. Again, I get it. Not everybody can do what I was able to do, but that is how I was able to find out. For the longest time, I found out a condition that I didn't even know about. So this is what brings me back to the point when it comes to people advocating for their health, including sickle cell trait, where sometimes having these conversations sound not every doctor is a Dr. Q, right? Dr. Q is an N of one. Let's be honest here. And so we have to be willing to have these uncomfortable conversations. And some people are always going to say, let me say this, so I may get in trouble, but I'll say it. Some people are always going to say, oh, maybe because the doctor doesn't look like me, that's why they don't listen. We know that is factually true. But I will tell you this, some of the patients that we have in my foundation or people that I know send me personal messages, some of their worst experience, these are people with sickle cell disease too, by the way. Some of their worst experiences come from people that look like them. It's not all the time, but I think these things we have to start talking about it. Sometimes the way that how we're educated around medicine, science, I talk about this concept of rethinking, reeval. Again, this is why I say being a patient advocate first. It's important. You guys, I'm probably gonna get too passionate talking about this because I get too fired up. So hear me out. But I think it goes beyond what people look like. I know the disparities are there, but I think ultimately doctors need to listen more, but also patients, caregivers need to be willing to sometimes take the risk and advocate a little bit more. Sometimes you may have to fire someone. Sometimes you may not be able to because you're in a desperate need of care, like someone with sickle cell disease going into like ER for pain crisis. We know the story there. So I just want to bold this up and say when it comes to sickle cell trait, all these complications, things we talk about are typically very rare, but it doesn't mean they cannot happen, right? And I think it ultimately comes down to one, making sure you accurately have the right diagnosis of you having sickle cell trait or not. But two, as we get older, I say if nothing at all, at least every year do your yearly physical, get all of it done. CBC, all of metabolic, all of just get it done, figure out what's going on. And if you feel like there's something not going well, and if you feel like maybe sickle cell trait related, talk to your doctor about it. It may be, it may not be. And we talk about RMC, and that's always the example I give. So let me end there and see if there are any follow-up questions. Hopefully, I help answer that question with my little soapbox I got into. Magic word, you're mute.
Sorry. Um, so what are some things that individuals with sickle cell trait should be aware of? You mentioned visiting your provider and asking for particular labs, but what else is not very well known about sickle cell trait?
I'm going to start with one that is actually, I love how you said it. It's not very well known, but it is so obvious. And I'm going to talk about water. So, I always say, again, this thing I have to share a cast where I wrote about this, where I talked about water and hydration is one of those things that connects sickle cell to our whole world, right? And so I'm gonna connect to the sickle cell trait. So for us at Sickle Cell 101, some of some of our work we do is supporting Donovan Peoples Jones and his football camp. So about what is it, 2 weeks ago, I was at this football camp where we support with kind of creation partners. And so best part of it for me is like whenever I'm there, literally it's because of the water conversation that makes people want to learn about sickle cell. So people are like, oh, okay, sickle cell 101, talk about sickle cell disease. Or I had a family member who had sickle cell disease. And they're like, okay, well, it's great you guys are supporting the water, but tell me more. And I'm like, one of the most important things when it comes to people with sickle cell disease is hydration and water. And I think people with sickle cell disease know that. One of the most important things when it comes to water for athletes is hydration because they know that. Now, when we talk about sickle cell trait, it is just like everybody else. It's important that if you have sickle cell trait, you always stay hydrated. But here's some of the things that we know. This is not hearsay. This is not made up. This is facts. Again, rare doesn't mean it cannot happen. And I would hate to be the rare person that I become the data. But there's people that have been the rare people. So the thing that I think it is important, but is not often talked about is people with sickle cell trait need to also stay hydrated very well. Just do it like regular people. Like me, I forget. Like I'll talk again, I'm going to use myself as the example today because I said to myself, I'm going to keep holding myself accountable. That means I have to use myself as an example. I don't do the best at hydration all the time. I have a nutritionist, and her challenge to me was I have it's called spin drip. So I have this water. I have to get these like sparkling water in my office. It makes me drink water. It's important for everybody, right? For people with sickle cell trait, why this is important is we all know heat exhaustion is something that can trigger, and dehydration triggers something called rhabdomyolysis, which is when people's muscles break down. Again, this is not exclusive to people with sickle cell trait alone. But what we've seen under certain cases, rare conditions, you guys can look this up. Examples, one of my good friends, Tamia Austin, she runs a great nonprofit. They do a lot of work for the Darling Brothers over there. That is pretty much what their work is. The Darling Brothers were these twins that played at Florida State. The story is out there. You guys can read about it. One of them unfortunately passed away while playing football during summer exercise exertion. That is what caused it. And so, not just them, there are several others. Again, not all the time. And so, when it comes to sickle cell trait, I say if someone is an athlete, they have sickle cell trait, you're fine. People with sickle cell trait have won Super Bowls, have won World Cups, have done all this stuff. You are fine. You are not exempt. But you have to stay hydrated, especially during the summertime. If you have to, and that's one thing we try to do, remind the coaches, right? And this camp, that's part of why we do this camp. So people say, what's the connection? I'm like, reminding these people it is hot, humid, stay hydrated. Maybe 99% of people there will be fine even if they're dehydrated. 1% kid who maybe has sickle cell trait, do that we want that to be our case that we write about again about Rabdo? Absolutely not. So I think my answer to you, Cass, is very atypical. I think it's water and hydration that we don't think about. People who have sickle cell traits like we're just fine. Again, me included, and I'm trying to be better. So I think if it helps, let's this is when we can learn from our sickle cell warriors, right? So we know our sickle cell warriors, they always talk about their water bottles and the things they take with them here and there. And I think that is something that for those of us that carry sickle cell trait, we can learn from them. Again, you guys can. I'm preaching to the choir because I'm trying to be better at it. So that's my answer for you.
Yeah, I feel like most people with sickle cell trait that I know love water.
Hmm.
Like y'all know how to drink water, like probably better than us.
There's something there. And again, like you
No, let me
said,
just speak for myself because I know I'm not always the best at drinking water, but um, I always, every person with sickle cell trait, I always see with the water in your hand. And you see the way you just pulled up that can of water? Like,
I don't know why. I think
there's something to it. I don't know what it is, but there's something to it. Um, so I have a question about a medication because I told them that you are also a pharmacist by training, and I wanted to cover all bases with you here. So, the question is, what medicines do you think help with sickle cell in general, and why? And can you please tell me more about the drug DF118, also known as dihydrocodeine,
Okay.
and how it helps with sickle cell pain?
Hey. All right. Of course, you have to sneak
Here
in
we
a bad
go. Here we
question.
go.
So let me start with this. Let's get to the foundation. Okay. So the thing I always say, the first question was, what's the best drug that works for sickle cell? Um, I was at this conference with this doctor. He's a breast oncologist, and he said something in the audience because he got a similar question. He said, the best drug that works for the patient is the one that the patient can take, can afford, and can benefit from it. So that's my answer right there, right? Again, as we all know, every patient is different. So this is a beautiful question, which kind of opens the curtain a little bit. Is it's the drug that the patient can take that's going to work for them, but also the one they can afford. So I'll give you guys an example, right? Those of you that don't know, like I said, my foundation is called No One Behind Foundation. Our work is primarily intentionally in very poor remote communities in Africa, in Nigeria and Ghana. If someone in our community asks me this question, my answer is different versus if Cass asked me this question. So for these people in these remote communities, sometimes I feel like it's not even fair for me to tell them to take hydroxyurea. Not because it doesn't work. Again, I know everybody has their own thoughts, right? But this is where we talk about the social determinants of health. Some of these people literally have to decide, do I get food or medicine? So again, we try to do our own little thing there. We help them with like the folic acid, vitamin B, and also providing them with food. So for someone in that community, I'm going to say, please at least take this folic acid, vitamin B we can afford to give you for now. In the future, I hope we should get hydroxyurea there for those that will work for them. But we all know someone taking hydroxyurea, they also have to get their labs done, right? For their hemoglobin F and all of this stuff. Man, some of these people, they are literally living in places you can't even reach them. So that's one group I'll talk about. And then the other group, if you we are lucky, we can afford all these medicine. That's why I always go to. I think we all know the staple is hydroxyurea. Does it work for everybody? Absolutely not. Just like every medicine, it doesn't work for everybody. I think for some people, you may have to see if it works for you. But if we're going again, I always say you can always think like a preacher, you can always think like a politician, you can always think like a prosecutor, but you can never go wrong thinking like a scientist. What do I mean by that? We go off of data and facts. And if the data is accurate, we go with it. If the data changes, we can rethink it and reassess it. That's where sometimes people miss it. That's where sometimes people like me and Dr. Q, people get mad at us. We say the data says, and like, oh, these people want to let us take these medicines. That's not what we mean. We're going off of data here. There's data that shows that hydroxyurea helps with people living with sickle cell disease. There is the side effect profile that comes with this medicine too, which we all know that. So for some people, I know some people that this medicine didn't work for them. But I also know some people that because they took hydroxyurea, their crisis per year decrease. So that is a medicine that for most people can benefit from. If you have never had a doctor or you have a doctor you consider, I think that's when you have the conversation about it. Beyond that, we also know there's a lot of drugs that have come out, whether it's through research or recent approvals that have also shown can work for certain sickle cell warriors. I will not touch on gene therapy because you guys have a session talking on gene therapy. So there's all of these evolving things, right? So I think my answer to this person is the best drug for sickle cell is the drug that one, the patient can afford and take, and also two, that is accessible. Some people cannot afford these medicines, right? And then three, the patient can benefit from it. And it ultimately comes down to the doctor, provider, patient relationship that can help with that. And then the last question was about codeine and pain. Um, I want to be careful how I put this one. So there's so many different drugs, right? That of course target the mu receptor, all of these. I don't want to nerd out and talk about how pain works, all of this. But a key takeaway is we all know the biggest complication related to sickle cell is pain and crisis. And there's different medicines that work. There's also a lot of pain medicines that over time people build tolerance to. Literally, receptors get desensitized. So I always say when it comes to codeine, right? if there is an element of coding for someone which kind of helps them, sometimes in their acute management, I've seen it work tremendous. For some people, it's like a lifesaver. And then for some people, they may have like there's also codeine tablets. It's not always liquid. For some people, I've had people tell me, when I take the tablet, it doesn't work. But when I take the liquid, it works. And I'm like, yeah, from a pharmacological standpoint, going straight versus getting it to your gut and then getting the breakdown may be a difference. So the question that they ask us about coding, I will say we have to always figure out what's the route of administration. Some people, it may be through IV that may work better. This is where doctors, ER people need to listen. Someone comes to you and say, you know what, this is what works for me. There is a method to their madness. It doesn't mean they're drug seeking. We all know that story. So if we're talking coding in general, I'll always say it works for some people with their pain. Some people, you're like, it doesn't do anything for me. Some people even talk about how they get itchy. There's another whole mechanism over there. They get itchy from taking codeine, so it doesn't work for them. They may have to take like, an antihistamine here and there. So I don't think it's a perfect answer. You just have to I think that one of the best things about people with living with sickle cell disease is they're very good at pretty much, when we do like in medicine, Dr. Kino, you do the soap notes, right? You figure out what's going on with the patient all the way up to what you give the patient. I think people with sickle cell disease are so good at it when it comes to the pain. So oftentimes they're going to figure out what works for them. And I think if it's coding that works for this person, let your doctors know, add it in your notes, tell the ER people if they have to take care of you. But also remind yourself when you talk to your providers that sometimes you may have to switch between medicines a little bit, give your body a break here and there so you can get maybe the full benefit from these medicines. There are some sickle cell warriors that I know, the only medicine they take for pain is ibuprofen. It works for them. So it depends. I guess that'll be my final answer there, Cass.
Okay. I got a question from YouTube and then a few from TikTok. Um, the question from YouTube is it possible for some people that are thought to have sickle cell trait to have chimerism and actually have sickle cell disease?
My simple answer is no. Um, Now, again, I know I said it earlier, right? We all should think like scientists, and thinking like scientists is challenging ourselves to be willing to look at new body of evidence so we can change our mind when we have new body of evidence. But as far as we know, around the body of evidence and data around sickle cell disease and sickle cell trait, what you're born with is what you're born with. It's not changing at any point in time, right? And so I think some theory, I'll say this though. A lot of the time for some people that feel like, well, I feel like I had sickle cell disease and it became sickle cell trait, or I had sickle cell trait became sickle cell disease. Oftentimes, with being honest, it was a misdiagnosis factor, right? Now, there is the other bucket of conversation around people getting gene therapy now that are saying, I feel like now maybe I'm like kind of, you can call me like I have sickle cell trait. Story for another day. That's what we're talking about here. But I think my answer to this person is I feel like what the science and the evidence tells us is the fact that what you're born with is what you're born with. And I don't think at any point in time you're going to have like some type of switch here and there that's going to make you switch from sickle cell disease to sickle cell trait. And I think some of the most interesting conversations and cases that I've seen is around this topic. And it's oftentimes someone who has sickle cell trait that feels like, I feel like it just switched up on me and it became sickle cell disease. But if you go to the roots, figure out how they were tested, you oftentimes realize that it was probably because it was a wrong test that was done. I will keep it PC in saying that, but again, to each their own. Some people may agree or disagree, but I'm going off of the body of evidence. I'm thinking like a scientist today, people, and that's what I would say.
All right, I got two questions about vitamins, and this is a conversation we've had in the past, something we talk about a lot, Stephen. What is a good vitamin in adults with sickle cell? Um, what vitamins would you recommend?
We're talking sickle cell disease. I will always say, it never hurts to
And sickle
supplement.
cell trait. You can,
Both? Okay.
if there's anything for sickle cell trait, let's cover both.
I I think I'll merge both of them, which is also going to bring me back to my soapbox from earlier This is why I think we also do our yearly physicals, right? Because sometimes that can help you figure out which vitamins you're deficient in. Sometimes someone may only be deficient in vitamin D, and that could make you feel tired and exhausted. And then here you are with this person who maybe ends up taking a bunch of different vitamins that they're probably already getting from their food, but they haven't done the test to know that maybe it's they're deficient in vitamin D, and that's maybe what they should be focusing on to help them. So again, my first answer to this question is I highly encourage when possible, do your physical. Don't do it every time. Just a yearly physical can tell you how your even your vitamins are doing and all the other stuff. So sometimes that may be all you need to do to figure out the best vitamin for you to take. Some people, it's only vitamin D is what you need. But if we think about overall, right? A lot of vitamins are water soluble. So how do I simplify this? So um there's an acronym called ADEK, ADEK. So these are the vitamins that are insoluble, right? Vitamin A, vitamin D, vitamin E, vitamin K. These are the vitamins that if you're taking them, not that it's not going to clear out of your body. It's going to take a long time. Now, if you take like a vitamin C, it is water soluble. I'm not saying go and overdose on vitamin C, but the reality of vitamin C is when your body takes what it needs, the rest that's left, you're just going to pee it out, right? So it's important to understand all these different dynamics around vitamins. Now, we know a lot of vitamins are multivitamins, have a bunch of stuff in it here and there. But if we're being honest, most of our vitamins, we're getting it from our food. So my first question is, how is your eating habit? I'm talking to myself too, by the way, right? Where, like, again, I'm telling, like, for me, I I had to switch how I eat now. Where, we always say, oh, have a portion of your protein, your carbs, and a bunch of vegetables. I'm learning this, by the way. Again, nobody's perfect. Keep learning where it's like even what you're eating first can actually impact the absorption of your vitamins. So maybe you start with the vegetables first. I was joking with my nutritionist and I said, when I moved to America, I never understood why you go to a restaurant and they always bring you like a salad first. It just never made sense to me. Like back home, you're like, man, give me my main course, let me go my way. But there's a thing in America where you go to a restaurant, they always come, hey, you want a salad or appetizer, then you get your main course and of course your dessert. But if we think about back to this question, what I've learned is that, sometimes even starting with, let's say, your vegetables first with your food, I'm not saying or like only sweet vegetables, no, like your literally maybe your salad, whatever, first, that can actually help with the absorption of the food and vitamins too. After you go your protein, of course, your carbs. Again, I am learning this stuff, so I'm sharing this stuff too. So I think the question is asking, do we understand the difference between the vitamins? What's soluble, what's not? Do we understand what we are lacking from a lab standpoint? I will go with the data. And then three, how is our eating habit? Now, I know life happens, people life be life in where maybe you're busy, your work, you can't do it all the time, and sometimes you may need a supplement, right? So I think if nothing at all, if you need to supplement, um, and you have to buy a vitamin, you have to really buy a vitamin that is from a trusted source. That is a touchy topic, but as a pharmacist, I'm going to tell you guys, right? There is a thing called USP, and vitamins, I'm talking about US alone, right? They're not regulated as prescription medicine. So someone can literally make up their own vitamin, slap a label on it, go through a few hoops in there and put it on the shelf. Let's be honest about that. But I think right now there's a lot of people trying to be better at people that write vitamins. So I always say if you have to get a vitamin you have to supplement with, there's nothing wrong with it, in my opinion. What kind of vitamin are you getting? Is it from a trusted source? Some companies will pay extra money to have additional bodies look at their vitamins. So, people love Nature Valley, right? It's one of those groups that pay the extra money to get this stuff tested. Nature Valley is not paying me, people, so I'm not saying anything like that.
I was
But
gonna say, not an endorsement.
I know. But what I'm saying is, just make sure whichever one you're getting is from a trusted source. And um, my sister will kill me for that. I'm going to tell you guys a funny story where for some people, the vitamin is maybe some type of plant or herb that they, maybe where they live or whatever, that may be the herb. Again, you guys know us Africans, some of those things work wonders. I always say, I wish, man, I wish there was like money to pay for all African scientists because we have a lot of stuff there. So I think again, I have to always kind of center myself, take myself out of America and think about us also community globally, like how people for Knob, right? And for some of those people, people will say, hey, I don't want our vitamin B and folic acid because I have this herb that we've been doing and it helps them. Who am I to say no? If it works, great. What I wish is that maybe whatever that's being done, it was maybe studied in a perfect world. It's not, so we can know the right proportions that comes with it. So, I think, Kaz, your question is a very interesting one. I think it even requires further conversation. But I always say you have to figure out what you're deficient in before you try to take vitamins. And if you don't know it and you're trying to just go, hey, I want to supplement with vitamins, just remember there are some vitamins that are water soluble and some vitamins that are water insoluble. And I gave you guys the acronym to help you answer. That's what I'll say.
That's fair. Um, I'm looking at time here. I do want you to tell us about the testing and sickle cell trait, but somebody did ask, what are the side effects that come with hydroxyurea?
I'll give you guys one, and the other ones we can have it for debate. The biggest one, especially for the women, is the discoloration of the fingers. It's a big one. Um, and I always say this, right? Even my breast cancer, what I say, you can never diminish a side effect of a drug. For some, if it's a man taking hydroxyurea and their fingers are gonna get dark, discolored, who cares? But for some women, that may be the reason why they don't take it. And again, that is a valid concern. So I always like to start with that because I feel like that's the easy, most obvious one that maybe like, it's not a big deal, but it's a big deal for someone. It's like, um, again, I don't want to get a soapbox with that, but that's the one I think it's important that we need to talk about because it impacts people, and that may be a reason people don't take it. The other thing about hydroxy, I think most of us know, it is technically a cancer medication. That is how this drug got discovered, right? And so even the fact that here's the medicine that you have to get your labs done. I remember when I worked at St. Jude where we had a very family case where the fact that to start hydroxyurea, you're gonna have to titrate it a little bit, right, and figure out where your best value is for the medicine. And for some people, having to come in all the time, maybe, hey, this time we did it, we may have to increase your dose, decrease your dose. It may not even be a side effect management thing for them. It may just be a reason why they just feel uncomfortable, they don't want to do it. So I will say, I think the biggest thing I always say is that there are different side effects that can come with the drug. I don't want to go through all the different details, but I think if there's anything that if you have to take hydroxyurea, please make sure you're working with a doctor or provider who is invested in you, that especially in the beginning, they're going to be willing to do your labs, check your labs, because they have to check your counts too, right? White counts, red counts, all of it, making sure everything is good, because that's another side effect of the drug to keep in mind. It's a cancer drug. So the labs are very important. The white counts, the red counts are important because they can decrease some of those. And then the aesthetic, the less side effects, like I said, I always tell people that's why I start with the discoloration of the fingers is one that may be not a big deal for some. For some people, it can be. I've had people that told me that even after they stopped taking it, it never went away. And for some people, it goes away, right? Again, the data says both ways. So that's what I would say. And if you're thinking about it, just have a conversation with your doctor or your trusted healthcare provider, is what I'll say.
All right. So how about you tell us about the sickle cell trait and testing?
Yes, let's talk about it. I think it is the most important yet underestimated topic around sickle cell in general when it comes to testing. And so I think that it is important that I think I had mentioned earlier the gaps around testing why people don't know their genotype. And I also told you guys about the other reasons, right? Because of all these potential complications that can happen that we're still studying about and why people should know their genotype. So the question there is, okay, so I want to get tested. How do I do it? My gold standard recommendation is the electrophoresis we talked about earlier. But there's also a ton of different point of care testing devices that people can use. Um, there is one particularly in Africa, it's approved in Africa and India. It's called a Hemex. They have this, it's a Gazelle device that can actually, it's the coolest part about that device is the fact that it's not only for sickle cell trait. For people with sickle cell disease, they can actually also measure your hemoglobin F on it. It's not approved here in the US yet. I know they're going through some testing and stuff like that. But I think in a perfect world, a testing, if it has to be a point of care testing, if it's a point of care testing device that has been studied, every test can have false positive, false negative. We know that. But I would rather lean on the ones that have gone through extreme testing, extreme regulation to make sure it's accurate. Because man, misdiagnosis of sickle cell trait can be costly. I haven't even talked about diabetes misdiagnosis from sickle cell trait. Story for another day. That is also rare. For some people with hemoglobin disorders, if you guys look at the National Kidney Organization's website, they actually listed a lot of tests that help us determine people's A1C is actually accurate. So every test that you typically do for A1C, which tells you if you have diabetes or not, is fine. But there's a few of those tests that if you have some type of blood disorder, it can give you a false positive because you have sickle cell trait or sickle cell disease. And so I always say if that's the case, have a conversation with your doctor, make sure they're using the right test. Again, most of the ones that are being used these days are perfectly fine. There's no issues with it. But I think that's why I want to talk about the testing because most people do, they go to community screening, they do maybe a point of care testing. If yours came back maybe positive and you're not sure, it doesn't hurt to confirm using an electrophoresis. If I was a billionaire, what I would do is I would probably like invest money in confirmatory testing for all sickle cell for everybody. But I'm not a billionaire. So if you have to use the point of care testing, who am I to tell you no? But what I really want to reinforce is if your testing was a point of care testing that helped you determine you had sickle cell disease or sickle cell trait, if you're able to please at least confirm with the electrophoresis because some of these things here ultimately comes down to did you get an accurate diagnosis or not. And again, it doesn't matter what you look like. Everybody, I saw, because I'll end with this. There is a group that's specifically for sickle cell trait. We have our own groups too, by the way. And there's a woman who just shared that. I won't take as a group, just out of respect for her. It's a white woman who just had a baby. Husband is also white, and the baby has sickle cell trait, and she's like blown away. So I think she started going online looking for places like, what do I do? I have no idea what this is about. And again, of course, sickle cell disproportionately affect people of Black or African origin, but it can impact everybody. So for me, my theme is at least the testing is important. Everybody should know their genotype, but I think every day is a good day to advocate for sickle cell disease too.
The question I will leave you with is, what do you hope for the future of sickle cell trade? And I guess if looking at research, we have our voice survey study out, and it's primarily for people living with sickle cell disease, but caregivers can take it, and a lot of those caregivers have sickle cell trait. What is the answer that you would have wanted to find out about sickle cell trait?
Hmm. I'll tell you two, because you started like, well, kind of my wish, right? I think one of my biggest wishes is that people with sickle cell trait will be a little bit more invested in the work that needs to be done for sickle cell disease. And I'm going to explain why, and I'll tell my second answer quickly. So, we all like the cool stories, right? And I cast those. I say like, there's always the story about sickle cell disease. Oh, someone has sickle cell. Of course, we all feel sad. We want to make sure they're okay. But the reality of this world is not fair. We're going to be honest. This world is not fair to everybody, regardless of what you have. And I tell my team, my foundation all the time, you cannot force people to care about what you care about. But you can actually do things about what you care about to inspire people to hopefully care about what you care about. And I think to do that, sometimes you just need to have something that I call trusted messengers. And what that means is that if we have people that maybe have sickle cell trait, that are more invested in what needs to be done for sickle cell disease, I think that message can go a little bit further, right? Oftentimes we have our sickle cell warriors, man, pounding the table. A lot of advocacy work you're going to see is the CASs and other people with sickle cell disease doing it. Is it perfect? Absolutely not. So in my wish, I would say if someone has sickle cell trait, I feel like that should inspire enough to want to do a little bit for sickle cell disease. Most of us with sickle cell trait are fine. We don't need to worry about anything. But I think that's one thing I wish we could do more because we can pound the table and say, oh, why don't all these people who have so and so disease come also help us with sickle cell disease? But we have a big group that we're not tapped into that can help with sickle cell disease. So that's one of my, it feels like my dying wish. People with sickle cell trait invested in it, which means that there has to be something that needs to be done so more people know their genotype because most people don't know. That's why I think they're not invested. And so the second part of your question, specifically around your the survey and the questions you ask over there, is that I just wish when it comes to sickle cell research, there can always be at least a 5% or even a 3% of the research that includes specifically people with sickle cell trait to also share their thoughts, their sentiments, their learnings. Because often, the caregivers are always invited, right? But I think when even the caregiver comes into these surveys or these research, even if they have sickle cell trait, they're not thinking to participate as a person with sickle cell trait. They're thinking as a person caring for someone with sickle cell disease. That's the reality of it. So I would say a lot of this research, I think we have to find a way to, again, not because sickle cell trait needs all this bunch of research. I'm not saying that, just us helping us learn because we probably wouldn't have known about this cancer, this rare cancer that impact people with sickle cell trait had it not been people with sickle cell trait now being involved in research. So I think gradually just a little bit of research that includes people with sickle cell trait. Sometimes just let them tell what they learn about themselves, what they know, what they don't know, and maybe over time we can collect more data to see some trends that we can learn from. That's what I would hope for.
No, thank you. Fair enough. And I think something we've always kind of talked about is research surrounding sickle cell trait in parallel to research with sickle cell disease is always something we want to make sure that we're not catching up for both and that both are being progressed. All right, I that was my last question. We have our next person, Dr. Ward Hager. Thank you so much, Stephen. This was fun. We have to do it more often.
Did it? This is my community, not for you.
I don't think the community grilled you enough. That's me personally, but
You hit me off the bat with the hottest data. I'm going. I love it though. This is
well,
good.
I had to throw something in.
All right. Is there anything else you guys have for me, or if not, am I good to go?
You're good to go. Thank you and happy World Sickle Cell Day.
Thank you. Thank you, Dr. Q. Thanks, everyone. We'll talk soon. Okay, later. Bye-bye.
Bye. All right. So our next expert we have is a Dr. Ward Hager. And this is actually a special occasion because I have my pediatrician and my adult doctor on live. So that's pretty special for me. Um, Dr. Hager is a adult sickle cell specialist and internist at UCSF. And so I'll go ahead and add him in and we'll get started. Um, any questions about adult care? Any questions about, any treatment options? Anything that comes to mind, feel free to go ahead and put them into the chat and we will get them answered with Dr. Hager.
Hey man,
Hi. Hi, Dr. Hager.
hey Keith, I'm so excited to see Keith. I don't know if you can hear me. Okay.
Yes, we can hear you. I was just telling the audience this is a special occasion for me because I have my um, pediatric sickle cell specialist and my adult sickle cell
Boy,
specialist on
true
the same
lifespan.
live.
It's like,
I know, I'm a lucky girl, right?
well, this will be fun.
Yeah, thank you so much for being here today, Dr. Hager. I want to read a bio about you, and you let me know if it sounds okay or if there's anything incorrect. But just to let the audience know who we have here on live, we
Okay.
have a Dr. Robert Hager directs the Adult Sickle Cell Center at UCSF Hoff Children's Hospital, Oakland, where he helps create, design, and implement clinical studies and transitional research to improve quality of life and care for people living with sickle cell disease like me. The center has cared for over 500 patients. Is that correct, Dr. Hager?
Probably
Over
closer to 600 at this point, but
600? Okay,
yeah.
wow. And provides liaison services across Northern California, as well as nationally and internationally. His clinical specialties span sickle cell disease, thalassemia, apheresis, gene therapy, and pain management. So um, I'm so happy to have
Yep.
you.
Can I give a shout out while I'm here? I
Absolutely.
want to give a shout out to Dr. Carrillo, who started the pheresis program. It's actually been going strong since. He had such a great foundation for it. It was been one of our boons going on. So every time people talk about pheresis, I always bring up his name. So I mean, I know how hard it is to get something brand new like that and complicated started. So that's been huge. It's been a legacy for him.
Yeah. No, it's an important one. My sister is part of the
Yep.
program, and yeah, it's great.
Yeah.
So, we have a global audience here,
It's
Dr.
11
Hager, and you've done this before. These are questions that are coming in real time.
Sure.
But I want to start us off with what is something that most people don't know about, or I guess what's something that's under. Um, what's the word? Doesn't receive enough a credit for adult care within sickle cell.
When you mean by enough credit, things that should be done or things that are being overlooked or
Yes, things that are being overlooked
for adults,
for adults with sickle cell.
I'll
Yes.
have to again give a shout out to Dr. Carrillo because when he was with our program, the kids coming to the adult programs were in pretty good shape compared to what we're getting now for a lot of different reasons. But the most important thing is by the time you're an adult, sickle cell has become a chronic disease of end organ damage. And even though pain is really loud, what really shortens the quality and quantity of life is the end organ damage. Because even without pain, the cells are still sickling every few minutes and unsickling. And when they change shape and bump up against the very living blood vessel linings, they release a bunch of chemicals. And it's kind of like a slow burn that goes on. And we've had people show up in their 30s and 40s that really have never had pain, but their organs have already failed. So one of the main things that we do as the adult centers, and actually most centers that do show a marked improvement in survival for our friends is that we actually have a grid out about the organs we're screening. We track them to see if they're going, I'm old, so my organs are already on the way down. So it's a matter of making
Same.
sure it's not faster than it should be. And if it is, we know we need to intensify the disease modifying therapy because the organs can get beat up without really noticing it unless you're tracking it. So that's one probably the thing the most centers should do, but for our friends with sickle cell, believe it, just good old lifestyle. Make sure you're eating well and sleeping and exercising goes a long way to both mitigating pain and also just keeping you healthy because it just amplifies everything else. So
Yeah.
and then one more thing I can throw in there too. One of the things that we really kind of insist on is make sure everyone has a primary doctor too, even though we do what we can do for that, but you don't get a pass when you have sickle cell. Wish you did. You can just say I have sickle cell, I can't get anything else. But as you get older, all the adult stuff starts coming in too. And we've diagnosed so many adult problems that have nothing to do with sickle cell because they're not having regular follow-ups with primary docs. So that's why we try to work in partnership with a primary. We do all the sickle cell stuff. We want to make sure all their other adult needs are being taken care of. Otherwise, it's all these things that go into what eventually makes people healthy in the long term.
So you mean we can't only have you as a doctor?
You don't want only me as a doctor. And the reason is, so many of these new changes, even for cholesterol and everything else, the, the way they screen and the numbers, they keep changing. And, we're really focused on hopefully the latest research and everything and trying to really improve sickle cell care, which is in itself a full-time job. And so and it's hard to keep track of other things too. And we do find patients that haven't, like older ladies that haven't had mammograms. We've picked up a few breast cancers, we finally get them to go. So these are the things that will sneak in if you're not just taking care of your usual health. Unfortunately, it's great you're an adult, but so it means you have to make sure that's going on and then make sure the sickle cell, in addition to the adult stuff, is being really looked at. So if that makes sense. And
It
so,
does.
yeah.
And sorry, we went offline for a second, but I have a question that came in, and it's about how you partner with people. Let me.
Yeah.
I would love to learn how Dr. Hager partners with palliative care, those who provide palliative care.
Well, that's actually a really timely question because there's been a movement over the last couple of years to increase palliative care for sickle cell patients. And the biggest hurdle we've had to deal with is that whole term palliative care sounds like you have a terminal disease. And that's usually when people get plugged into. But the point that they're trying to do is find all the other modalities for care, quality of life, and pain relief that has to do with food, sleep, alternate ways to handle pain, exercise, stretching. And this is what palliative care in many places, but not all, can focus on. And so there's actually been several meetings. There's going to be another one at the end of July at the National Association of Sickle Cell Centers talking about this because there've been more studies coming out of, that they're not quite sure how best to do it. I think that's an excellent question, but it really is going to depend on the group you're working with. We
Yeah.
at UCSF, there's one really good, she's affiliated with UCSF that does palliative care, but also did a lot of sickle cell pain. So she's been excellent to help with our friends. So it's just a matter of who you're working with. Some really focus more just really on end of life. And that's not quite what we're, trying to say to our patients with sickle cell that, that's why we're sending you over there. So we really look to see what options are there and see what resources that they can bring to the table for our friends. And usually it's a growing partnership only with seeing more with what's available. And unfortunately, some of it's still kind of limited for most of the hospitals around where I am, with the exception of, as I said, over at UCSF. And have another group over there. It's not quite palliative care, but they do a lot of the same thing. And so, it's who we were trying to work with.
Yeah. So, Dr. Hager, what do you think some of the biggest challenges are with treating adults with sickle cell? And how does that differ, do you think, from pediatric care?
Um, how much time do you have? Um,
We have an hour.
I don't want to feel like I'm talking the whole time. I'm actually asked you to repeat that question because I'm trying to put it into different pieces to make sure I give a
Yeah.
concise answer.
Yeah, the biggest, I guess, to simplify it even more, what are some of the biggest challenges that you find within adult care with sickle cell? And
I
I
can
guess
easily,
when I initially asked it, it was kind of contrasting that between pediatrics,
yeah.
but I guess what are some of the biggest challenges you find in adult care?
That it actually is very regional specific, as Dr. Carrillo knows.
Mm.
Again, another shout out. He spent a lot of time trying to get the state legislature to allow people with rare diseases pick their own silo so they can actually come see us. That this didn't quite happen, through no fault of his. It's just a whole other issue. But the biggest challenges we have is um, adult specialty care. And when people come to see us, and even UCSF is getting less and less friendly to adults over at Children's, and it's becoming a big issue. We're actually looking to move the whole clinic to maybe the spot in Emeryville or something. Where we actually have more adult services nearby, because back in the day, we had such a small hospital, and we had early community mentality. We get to send everyone to radiology, cardiology, and they still see our adults. And now with all the people rotating in from the West Bay, it's just a different culture. They just, if you're over 18 or 21 for sure, they just won't see you. And so now having to have something, we have to have a lot more process to get people places to get these things going. The
Yeah.
um the So that's probably the main thing that's happening that we have going on. The cardiology. And then why the primary for us is so important is that we can't refer. One of the things we lost with the revamping of healthcare in California, which actually probably was an improvement, but still needs some help, is that we are considered specialists. You used to be able to refer, and we can't do that anymore. And one of the other reasons why it's so important for people in the Bay Area, at least, to have a primary. So if the primary doctors, they know their network, if they need a dermatologist, an OB, a orthopedist, and we often call these doctors that when they're seeing our patients to talk to them about what we're looking for, because it is a bit of a specialty, but we've kind of lost that close contact with a lot of specialists. I'm happy to say we're building it out a little bit again, and but still most of it's across the bay. Our saving grace is many of the subspecialties come to Emeryville. So that's what we're really kind of leaning on for specialty adult care right now. And the way the insurance is just divvied up, it's just really kind of crazy. But so that's kind of the main challenge I find patients have is that when they become adults, if they don't have a primary or they're really plugged in, they go from a system where they used to whatever they needed, we could just get it, to now it takes 2 or 3 steps to get anything done. And everyone's just so busy just trying to get through their day and then, wrestling with their, and most people with any sort of, God bless them with chronic disease, they just so down on their list of taking care of themselves, just trying to get through everything else that we go over and over trying to get people in just for basic screening and sometimes important care. It's just very hard. And then a lot of times the appointments are just months down the road. So we're calling, trying to see if we can get them in early and everything else. So that's why, again, one of the things we now have to insist on for patients coming from the PEDS program, and they're pretty good about doing it, is making sure they've seen their primary twice. They actually, interestingly, the National Association of Sickle Cell Centers now defines successful transition. One of the hallmarks is you've seen a primary twice, because apparently this is also a national issue. Because it's hard to find someone when you need them right away. If you've established a visit or two, even though you may not see them regularly and mainly see us, which is fine. If we need like a referral or something, we know who to pick up the phone and call and make sure that gets done for you. Otherwise, it can be months on end. And even sometimes it's really critical stuff too, that often isn't taken care of in the hospital. So we can't just send you to the hospital for some of these treatments.
Yeah. So a question we often get asked is what medications or what treatments are out there that are currently available for people living with sickle cell disease? And I realize that can also be specific to the region as well, but
Yeah.
what's out there, generally speaking, for sickle cell right now?
It's actually the biggest indicator of how well people do with any type of sickle cell and any severity is their social support. And I don't want to minimize that at all. It's easy to talk about medicines and things, but it's so
Yeah.
important that if you have a close family, friend, extended friend, anything group, people do just so much better. And for a lot of reasons. And so
Have they
that's
studied that?
what?
Have they studied that?
Oh yeah.
Is there data
Yeah, yeah.
surrounding that?
Yeah, yeah. And you can imagine why. If you have people that are really around you that are part of your care group, they kind of make sure you get to places. They kind of make sure you take your medicine. They kind of make sure if you're having trouble, they're there early. So that's probably all the different bits and pieces that go into it. But that's one huge thing. So the things that you do needed treatment for start to get done. And that's one huge thing. The second thing is, again, as I said before, just basic taking care of yourself. Good foods, light exercise, and sleep actually go a long way. Even with a lot of pains, a lot of our friends have back pain from all sorts of little changes in the back. But, muscles protect joints. If you got toned up abs, you have a whole lot less back pain, no matter what's the cause of the back pain. So, we'd love to get a lot more physical therapy and stuff in, and we keep trying to work on this, but just the cost structures are so challenging. It's an ongoing battle, but that's where we're, again, going back to the question about palliative care, we're hoping they can kind of help because they have a little more access to that as part of their bundle. And that's kind of what we're kind of looking to kind of tap into. And then now going back to more specific treatment, I think one of the critical things is looking at what the sickle cell activity is and what's it doing. And that's why we screen so many organs. We kind of have this little, heart, lung, brain, kidney kind of the main things, but you can anywhere the blood flow can cause trouble with different things. For many people, the kidneys are kind of the bellwether thing that we're always watching because the kidney is like one of the most inhospitable places for a sickle cell in the body. There's too much acid, it's too concentrated, there's not enough oxygen. And so over time, it's pretty quickly, even with the little newborns, by the time they're 1 or so, you can actually show changes in the kidney. That's actually gotten better. It's now been studied, not extensively, but they don't want to do biopsies on kids. It's one of the reasons. But there's definitely been lab improvements when they're starting little babies with SS hemoglobin on hydroxyurea early. They're actually seeing a whole lot less of this progression early on. So there's some hope that there's going to be some early changes that will translate into better adulthood. The other challenging issues are just making sure nothing's sneaking in. People that get transfused a lot, making sure they're watching their iron, because that really, we probably lose 2 people a year to iron. And it's just not, no matter how hard we try to chelate them and get them on chelation, and unless it is something like a stroke, where the only thing we know that really, really helps is transfusions, we've had to take people off transfusions because they won't chelate. And unfortunately, their pain goes up. It really does help, but we really, one of our challenges is trying to get people on good chelation. And even though we're constantly doing it, it's a very human thing. And it's not picking on any particular people. I mean, it's hard to be on regular medicine when everything else is going on, but especially it's kind of like blood pressure. You don't know it's hurting you, so you kind of forget about your medicine until it's almost too late. And so we really have to watch that, kind of for them. I don't want to feel like I'm their dad, but I just can't keep giving them blood if I know I see it building up and I know what's going to happen. So that's one thing. And then in terms of specific treatments, there are a couple things. One, we have, I keep stressing it over and over, especially for SS, and there's a little data in SC. What am I going to say, Cassandra? Hydroxyurea.
Hydroxyurea.
Hydroxyurea. With all the other medicines out there, it's still as good, if not better, than any of the medicines that have come out. And even there's some interesting early studies. I have to stress this early, when they first started doing bone marrow transplants, that this was done in Europe, that people that had stayed on hydroxyurea and were really on it overall did better than people that had been transplanted after a certain amount of time. Now, I need to quickly follow that up by saying what almost drove the difference was the toxicity of the transplant. And they're getting better with using less chemo and less troubles with that. So hopefully that'll be changing too. But, it's a good medicine because it works. Everyone talks about fetal hemoglobin, but it has so many properties to it. One of the main things that a lot of folks probably do or don't realize about sickle cell, and I'm sure Keith knows, is that it really is an inflammatory condition. And one of the reasons it affects so many organs is that your body has low-grade inflammation all the time from just this constant sickling and all the changes that causes. And when that happens, what goes on is that that's where a lot of the damage to different organs happen. And hydroxyurea actually reduces that. And one of the early studies, the multi-center study with hydroxyurea, if you actually look at it, the biggest predictor of how well people would do clinically was how much their white count came down. And even the people whose fetal hemoglobins barely budged and their white count came down actually had a lot of improvement in pain and organ. So it has not only a twofer, but there's a fourfer effect that we know about. The threefer is that if you actually look at the molecule, if you ever look it up on Wikipedia, you'll see a little nitrogen sticking on the side, and that can turn into nitric oxide, which really gets chewed up in sickle cell. And so it does seem to be able to donate nitric oxide. There's been some studies with that done at the NIH, and they think they can show that. These are really hard things to study. And we also know that it, just like crizolizumab, it actually blocks some adhesion too, for different cells sticking together. It doesn't do the endothelium, but it blocks white cells and platelets and red cells sticking together through certain things they know. So it actually has this multifactorial thing. And often when we're talking to pharmaceutical companies who come out with yet another blocker or something, and it says, this will replace hydroxyurea, and it says, well, probably not, because it does, it can hopefully add to it, but it can't do all these other things. And again, to stress to anyone listening, the only 2 things we know that actually preserve and protect organs, end organs, the heart, lung, brain, kidney, which is the name of the game for adults, are blood transfusions and hydroxyurea. They've been looking for these others, and hopefully they'll find them, but right now there's really just not convincing data. You can help symptoms, and hopefully they'll be able to show that later, but it hasn't been demonstrated.
Yeah, it's good to think about it in that way, where we're thinking about, organ preservation, because I don't think a lot of people have that lens. It's always very symptom-based
Right.
thinking and more reactive thinking, But yeah, thinking about your body as a whole and its organs and what actually helps preserve those organs is it sounds like blood transfusions and hydroxy are those two things.
Yeah, and especially if, if you're not having them checked, sometimes they're getting worse more quickly than we want them to be. And at that
Yeah.
point, we know to increase therapy with some of the other meds we could talk about. Because we do use things like crizolizumab, which is a fancy name for it. It's a chemical name for Dexvio. And it seems to work by blocking the red cells and sticking to the endothelium to cause the
Mhm.
trouble. It's probably how it's working. Again, these things, it's really, if you think how complicated the body is, you're asking to look at tiny little pieces and trying to even figure out how to measure that is really hard. But it is plausible, it's the way it's working. We have a lot of our patients on it. It seems to be about, say, 20, 30% of people really do have a response to it. And the response I often hear is that I still get pain, but it's less intense.
Okay.
So that they can just get on with their day. Because even with pain, we haven't really talked about pain, but this sickle cell pain is almost unique to being what we call a which nerve inflammatory and inflamed pain, because that always makes
Yeah.
it so hard to treat and it's different from other pains. I still remember when I started many, many years ago, actually many decades ago, on one of the first monographs that came out from the American Pain Society was basically that, sickle cell pain is a unique pain syndrome. Don't get involved with it because they had no data on it. And they just realized it was different and they needed to kind of, you know, focus on what they need to focus on. Unfortunately, I've heard that from early on from different groups that we just don't understand sickle cell enough to take care of it. So having said that, luckily that's changed a lot. But the pain is, obviously really intense and really in your face uh, when that's going on. And then, so, helping the pain, we do find that helps. Um, we we have used some L-glutamine, which is the amino acid. We've only had a couple of patients really stay on it, and I think part of the reason was you have to mix it up as a slurry and get a lot in. We had a really good researcher here who still works with us, but she's over at Emory now doing a whole bunch of different stuff, actually around arginine and L-glutamine.
Okay.
And she basically says you need tons of it to be able to really get it to work. And so we're working on that. So the only other medicine that we've had out there have been obviously voxelotor or Oxbryta, um, which has been um,
Withdrawn?
sorry,
Withdrawn?
withdrawn and now maybe coming back. We're not sure. It's like this is really this interesting idea. And the idea, if you take the idea as you're trying to keep the cells themselves from sickling, that makes some sense. We've done some other studies. I think Keith was involved with some of these, where we actually had ways to keep the cells from sickling, which actually increased the hemoglobin, but it didn't help the pain at all. And it's a very challenging thing to figure out. It's not, obviously sickling seems to be the hallmark, but just slowing that down may not be quite enough to really make something that effective. So that's
Yeah.
why studies have to be done. They're actually working on, there's one actually product now that's actually up for FDA approval that's actually in that process, not just actually see if they can make the red cells healthier, not just keep them from sickling, but increases the cell's ability, the red cell's ability to repair itself. And that looks really good in thal, but unfortunately, almost everything we do looks great in thalassemia. And again, it's that inflammatory component's probably the difference between the two. And so we have to see how well that works. But we've actually been trying to get that off label for a few patients when nothing else we have works and
Is
they
that the
can't.
mid pivot?
Yep.
Okay.
Yeah. And there's another couple of studies that are going on right now that are really fascinating. Um, there's uh, there's something called a Whiz protein, which is a protein that actually allows the blockage of fetal hemoglobin. And if you knock that out, then you start making fetal hemoglobin like gangbusters. And they've actually have two different companies are working on it now, and we're actually have one of them in study, and we're getting ready to do the other one. Because interestingly, they have different age groups. So we're going to put the one to take the lower age group on one and one on the other, and kind of see how they work. But the
Yeah.
people, both the data report and our one patient we have on it, their fetal hemoglobin shot up to like 60% without side effect. They feel like they have a new life. So there's some other things out there short of, gene or transplant that may really be really helpful. And then one of our junior faculty is now starting a study for acute pain, which is actually had nothing new for acute pain forever. One of the things that happens with acute pain is what drives a lot of it is the inflammation we keep talking about. And when the cells lyse, it's not just the cells in your anemia dropping. If that was just that, we'd just give you blood and it should fix it. But what really happens, not only is your counts dropping, but all the stuff that comes out of the red cell, now just flooding the blood vessels, is really irritating and toxic to the blood vessel lining. And one of the main things is something called with the breakdown product of the hemoglobin molecule, you can just call heme. And the body has some mechanisms to stop that up, but it's already obviously low in folks with sickle cell because of the chronic anemia, chronic cells falling apart. And then at the same time, what they have is when you have a crisis, it even almost goes to zero. And so what one company decided to do, which is actually been floating around for a decade or so, is they're actually taking that product to figure out how to make it in the labs. It's basically what the body makes. And they're just making a whole bunch of it. And so when you have an acute pain crisis, they're bringing you in and they're just going to give you a whole bunch of that. So it's nothing new. It's not like a new drug for your body or anything else. It's just replacing something that's just gotten sopped up. And so that's actually exciting to see if it'll help acute pain. Again, in mice models, it looks great, but if we were mice, we'd have cured sickle cells about 12 different ways, but we'll have to see how this plays out. But yeah, so that's one thing. And there are some other interesting one other two things before we talk about gene therapy. One is it's long been known, and in fact, the doctor that founded our Sickle Cell Center, Elliot Vuchinsky, had published on this, decades and decades ago. They even did this in France because it was always been observed that the lower your hemoglobin, the less pain you had. And what seems to happen with that is the lower hemoglobin you have basically means you have less hemoglobin molecules per red cell. And so the concentration is less in there. So it's less easy to completely sickle.
Interesting. Yeah.
Yeah. And so what they would do, and they did this in France. Actually, I tried it on a couple of patients with SC, but they didn't come in often enough to see if it would work. They'd actually take patients and phlebotomize them, have them come in and take out. I have to look at the paper, remember how much, but say 200 to 250 milliliters of blood, and just kept them a little bit lower than they usually ran. And across the board, their pain got better. However, you're taking someone that's already anemic and making them a little more anemic. So it was really hard to get a good therapeutic index on where to put that. So the idea is Novartis has decided, but since it seems to be the mechanism of action for that, is that you're basically having less hemoglobin per cell, hemoglobin molecules per cell. Why don't we iron restrict just the red cells and see if we can't decrease it that way and see if we decrease the amount of hemoglobin molecules per cell, that will be able to decrease pain. And so they actually came up with an antibody that just really targets that area. And they did, again, in mice models, it looks really good. They've done human volunteers and very little, really no side effects. So we're actually in negotiation with them now to maybe just do some what are called phase 1, phase 2 trials. Just take some people that to want to try it and they're willing to try it and just give it to them for a couple of doses and see how it goes. This has always been done already in humans that don't have sickle cell, and so it looks safe enough. We're not just taking people randomly and just seeing what happens. And they get monitored pretty closely. But that's another approach. So I think what's encouraging about that is people are looking at a lot more different ways to go after this. And it probably at some point there's going to be a combination therapy that's really going to help with this, that we can put things together that may be helpful short of full-on gene therapy or transplant. Now, having said that, shifting back into transplant, One of the few times we actually really, really, really encourage kids to get a transplant is if they have SS type sickle cell and they have a full match sibling, because the success rate for that without any real trouble is about 97%. And if you can do that early without any, you do that early before they get a lot of end organ damage, that's probably the closest we've gotten to a cure with what goes on. But what's really challenging for us is that, especially with the improvement in childhood care, and even now, even childhood mortality with sickle cell is still slightly going. It's so low, it's hard to show it's going down even lower, but it probably is still getting a little bit better. We really almost never expect to lose a kid now, for a lot of various reasons. So mostly between hydroxyurea early and everything else, the kids are doing great. So it's kind of a hard sell to parents. Their kids really young, you say, why don't we transplant them? Because there's still fertility issues and some other things. But it's basically it would take sickle cell off the table with our present knowledge. By the time most people get really interested in transplant, they're almost too beyond the age where most centers can do them. Even though like the commercial products are done for genetics over basically over 18 up, there's no upper limit. Most places don't feel comfortable doing it over about 30 to, the only place I know that is 45, City of Hope in Los Angeles, and Chris Lacamani, who's now at Emory, will do about anybody. And so, so we can actually get some help with that. But in most places, by the time people realize that, boy, I just really probably it would be great to get rid of this at this point, they're almost kind of out of the current window that we have. Having said that, I can tell you that UCSF, through one of the faculty that we're going to hire, she's finishing her fellowship this month, and then she'll be starting after a well-deserved vacation for a month or so, coming back as an assistant professor, really is trying to help us push their transplant group to really look into doing adults with sickle cell. The challenges with that, though, is
When you
just,
say adults, is that 35, over 35?
yeah, just any adult, doesn't matter the age.
Okay.
Yeah, that's what we're trying to get to. Because most people by the time they're really interested are about 40. And that's, where everything they realize it just,
That's
yeah,
interesting.
it's just
People
starting
should,
to. So, we talk to
wow.
people. There are a smattering of people, like even like the current study that Mark Walters, who's our transplanter, is doing.
Yeah.
The one study, it's a really interesting, good study. And the only two people he could even get to do it had to come from the East Coast. Because even when you talk to patients, they're doing well enough. And to be fair, you're still trying to balance. I'm feeling good. Why should I get through it? It's still quite a process. So until they can make it less challenging and arduous, so, you're going for a gene therapy or even a transplant, you're basically talking a year or so out of your life. And then with the problem, the challenges of maybe even becoming infertile at the same time, it's a really harder sell for a lot of people still. And
Yeah.
it's a balance. And if you're still feeling pretty good, then it's kind of hard to kind of go there. So we'll have to see how these new therapies, if they work, come out, how that may change the story.
Yeah.
With the transplant, there's kind of an advance that was just published, I think, a couple weeks ago. We've been watching this for a while, but the first interim report came out. It has a funny name called base editing for transplant. And that word base means, if you think about DNA, you have the four nucleotides, adenosine, threonine, guanine, and cytosine, and they're called bases. So what you're doing is you're using basically CRISPR. The current genetic therapies are cutting something or adding something in. So they're cutting into your actual DNA. And all base editing is done is it's editing the bases without breaking up the DNA. So there's no crack to the DNA. They're just kind of changing. It looks like they can do it pretty specifically just on the hemoglobin gene with the way they do this CRISPR stuff. So they're not breaking any DNA, they're just kind of modifying the bases on it. And that actually looked really, in small numbers, they only did like 31 that they reported. They'll have to use chemo, and everyone had pretty bad side effects actually. So it's still not quite sure how that's going to play out. But the idea is that if we can do something without really having to break up DNA, that would be very helpful. And
Are
then,
Earlier you talked about the scenario where it's a SS and a true match sibling.
Mhm.
Somebody wants to know what's the best age to do that.
Uh, I'll turn it over to Keith because he was our ace pediatrician for so many years. We definitely miss his expertise. But I'm guessing, before damage really starts and before they're much more plastic. So I would be thinking, again, I'm not the pediatrician, that's why I'm looking on my screen at Keith to see what he
Or
says on this. I'm trying to think the last time we did it, we don't see it done much anymore. For one, it's hard to get a fully matched sib. And I mean, we
yeah.
really talk fully matched. It's not just like partial match or anything. But if you have it, then you almost have no chance of graft versus host reaction. And
Mm.
the chemo is a whole lot. It doesn't have to be as, it's intense. So I'm guessing about 5 or 6. But again, I'm not the pediatrician. So I keep bug marking that because I don't want to
Dr.
write that one down.
Carollo, do you have any insight on that?
Well, if you have an HLA matched sibling, nowadays they've really improved the bone marrow transplant procedures. The graft versus host disease has been uh, they have new treatments for that. So I would say under 5, and before you want to do it before there's any organ damage if you have an HLA matched sibling.
And organ
So,
damage starts after 5 or starts at
No,
about
well,
before.
5?
it's accumulating. So, like
Mm.
Ward was saying, even in children, you can see that their kidneys aren't normal when they get to be a little older, less than 10 for sure. So, the earlier the better. Part of it is really small, it's a size thing. So, really small kids are hard you have to have intravenous access and that. So, probably around 4 or 5 would be the optimal time to do that
Got it. Got it.
if you have an HLA matched sibling, which is very unusual. I think it's less than 1 out of 10 kids have a HLA matched sibling. So
Less than 1 out of 10 kids have
yeah,
okay.
yeah,
Okay. Which is why there's, I guess, opportunity for gene therapy.
right.
Um, Dr. Hager, a lot of times, you see within these clinical trials that, to your point earlier, that the cutoff is at 35 years old, and you were talking a little bit about this. Is that because um, of the damage that sickle cell
You have to.
has done?
Oh, I didn't mean to cut you off. But yeah, this is a really, when you're making criteria for a study, your
Yeah.
main idea is you want groups close enough together that you can actually see if you've done anything that helps. And so you have to kind of come up with what we call inclusion criteria and
Mhm.
exclusion criteria so that at least the people that get into your study, for that study, you can say, yes, we can either show it did or didn't work. And that actually, at some point, you have to draw somewhat arbitrary lines around things. Because if
Okay.
you had too many open-ended things, then you could easily see where some centers would be entering all kids and others would be all adults, and it'd be hard to compare apples and oranges, so to speak, because it's just a different stage of their lifespan and their journey with sickle cell they're in. The other thing that happens is they want to be able to isolate bad effects and things to just if the treatment is causing it or not. So at some point, they just kind of look at the numbers and worry that that are older than 35 may have more underlying problems, like we were talking about, that just slowly accumulated, that could skew the results away from just showing what their product is or isn't doing. And it's not like they're trying to exclude people; they're just trying to figure out if their product works. And so a lot of times when they do the studies, there's a lot of inclusions. Interestingly, for the 2 gene therapies that were approved, the studies had limitations, but the FDA basically just said from like 18 or 12 and up for each, and up. They didn't have a top end. They said anybody would qualify. And the other challenge for most of, especially the gene therapy studies, they exclude people with known vascular disease because they're just worried about something happening just because of the vascular disease that would be hard to follow. And what's really challenging for us, because one of our main reasons we really watch, we're actually probably the only place in the country that does regular MRIs on our patients. We actually track that too to see if we see any progression of blood vessel changes in the brain, because to us the brain's a big organ. If it's the kidney's usually kind of the first thing that shows trouble, but we want to make sure the brain's okay, because if we start seeing more changes that go on in that, then we want to increase treatment for the underlying disease to try to protect those vessels as best we can. So it was like, from a study perspective, I understand why they excluded patients, but then they're often the patients we want to send to gene therapy. It's like, let's stabilize this person before their brain gets any worse. And, because a lot of times your brain's pretty plastic for a long time. You can take a lot of little changes without a whole lot of stuff, but at some point, you can subtly start to interfere with quality of life. And, we really focus on quality of life. I guess I forgot to stress that up front too. Everything I was talking about with lifestyle and everything, we kind of bring it back to how are you doing with your life? What's your sickle cell keeping you from doing what you want to do? What's your pain keeping you from doing what you want to do? And then trying to improve things, from that, because, you know, if you don't have, really improving your quality of life, if you're just taking medicine and still feeling really crappy, then that's just not really good. So we kind of work with that too.
Yeah. I got a question here that says, and I'm not sure if I know what this acronym is do you believe that BUP truly helps with pain?
Say it again, the
BUP? Is
BUP. Oh, buprenorphine. BUP. Yeah. We've
that
had,
what that is?
yeah,
Okay.
buprenorphine is an interesting opioid. It actually is a full-on opioid agonist, and which basically means it really binds to the same mu receptors as Dilaudid, as OxyContin. It binds incredibly tightly too. In fact, it's actually one of the problems with it. It binds so tightly. But it also, when it reaches a certain level, will block other things from reacting to it. So people kind of call it a partial agonist, which means it kind of works like that, but at some level, it'll quit working as more. If you have a certain level of use of opioids, and especially if you find yourself taking them over and over again, there have been a lot of interesting studies and even without sickle cell, pain clinics are starting to use buprenorphine as their go-to drug when people are starting to use almost daily meds, because it's been so effective. We've gotten 3 to 5 patients off pretty high dose opioids and gotten them on buprenorphine, which can be a challenge, because what happens when you're on high dose opioids through no fault of yours, it's just the way the drugs work, they're not great drugs, your blood level goes up and down, and your nerves physically and chemically change. So they get used to that. And so if you're on high dose and come down, your nerves hurt for a long time before they settle out. And it's just miserable. And so sometimes it's really a challenge and people trying to figure out how to get down on it. Because if you just take someone on fairly high doses of opioids and put them on buprenorphine, you'll just throw them into permanent withdrawal and they'll probably never come see you again. So it's a matter of trying to hit the right dosing. But we've had several people feel like they've had a new life after getting on buprenorphine. It does have it's pretty potent and it's not for everybody. But the advantages we've seen in a few patients that we've worked with, and now we're starting to work with a local hospital that does a lot of it. And we just got one person who's just been in and out all the time and just starting it. And we've got our fingers crossed this will hopefully help. Is that what they notice is their pain stabilizes a lot more. It doesn't necessarily take all the pain away, but suddenly they don't feel like they need to break through all the time. And they actually start thinking clearer because they're on less total and they're sleeping better. And there's this unholy alliance between pain, depression, and sleep. And when I say depression, it doesn't mean that everyone just can't handle things. I mean, it's horrible having pain all the time, it's accompanying things, and so it's not like true major depression like you see in psychiatric syndrome, but it's just again one of those whacks on quality of life. And if you can kind of help any of those 3, then the overall picture gets better with pain, with quality of life. So the short answer is to that question: if you have a person who's experienced in doing that, and what they really should be telling you to do, they're laying out the plan on how they're going to do it and how they're going to monitor it. Because you think if said here, take Bupe and go home, that's not a plan. That's like, it's just almost a setup to fail. But here's how you're going to do it. We're going to try this dose. I'm going to move this up. The only knock I have on buprenorphine is how it's given. They don't have a pill. Either it's a shot, it's a patch, or some sort of mouth pill, either a film or a tablet you put under your tongue. So so it's not an easy thing to completely work with. And I'm not quite sure why they haven't figured out a pill for it yet, but
Yeah.
but it actually been pretty successful in a small subset of patients who have had almost no success with anything else. It gets to the point, we've actually started it on patients when they look like they're escalating their pain needs, and it's been helpful because it does seem to smooth things out quite a bit. But again, you have to know something, we're not experts at it yet at all. We've been actually talking to a lot of people and trying to train ourselves up too. But it's like anything else that's potent. If you use it, if you don't know what you're doing, you're probably going to make somebody miserable with it. And so you have to really make sure they have some experience. And you can totally tell that when you're talking to them, because they pretty much tell you what to expect, how they're going to monitor it, what the plan's going to be, and if that's going. If they can't, it's already, put this on, call me in a month. That's probably not who you want to be seeing, because it's probably not going to be there.
So I wanted, you're an adult specialist, and I feel like you guys are like unicorns because, there's already so little amount of sickle cell specialists, and then there's even a smaller amount of adult sickle cell specialists. Wanted to ask you, how old is your oldest patient, and how have you seen, like, just within clinic, uh people living longer lives in practice, and how, I guess, what is the last decade with adult care look like? Sorry, that
Uh,
was a lot of questions in one, but how
yeah,
old
that
is
was all. I
your
think I can
oldest
walk you through that.
patient?
I get it. Something we think about all the time. Before COVID, I call it BC. BC, um, that we actually had an over 50 clinic with about 40 some patients in it. My oldest patient was 83 and she died probably of an unrelated stroke, just all the other adult
Wow.
things.
Yeah.
I was just asked for how many patients we had over 70, and we have 6 um, in our system, and a ton in their 60s. But it's also
Okay.
interesting that if you actually look at their major troubles that we track their, obviously their health things. Most of the things that they're wrestling with are the adult diseases we talked about before. Now, one of the interesting facts, both in California, Georgia, and I talked to the director in Alabama, and she sees the same thing, is that life expectancy, unfortunately for adults in general, even in California and probably across the nation, but we have the closer data in California, Georgia, and Alabama, is actually flat or decreasing. And most of it seems to be because no one's paying attention to all the other adult and organ things. If you go to a center like ours, the life expectancy is far better, decades better. But it's not like we're doing anything magical. We're just looking at, your kidneys getting beat up, or, and getting you to the right specialist to help take care of the adult stuff
Wow.
that's going on. So I think what happens to the poor friends with sickle cell, they've just wrestled all their life with a chronic disease, and they just don't want to even have to think of, it's like so hard to think about something else. And so that was part of, what's going on with that. So if you go to a center, and there's good data, we have the data from like King's College in London and from Duke and others. People do really well. It's well over the 70s and kind of the average. It's still probably a little bit shy of the background population, but it's definitely, it's not so outside the norm. We always say we can do better. But it's not the 40 some that, across the
Yeah,
board.
I thought the life expectancy for a while was 42, and now I've seen new numbers where it's like 52 now, or something
Depends on
within
whether
the
it's SC
50.
and lady. Women with SC do the best. Everyone else does the worst.
Women with
So
SC,
do the best.
type SC.
Yeah. But
Okay.
yeah, so across the board there, depending on the study and how big it is, but it really isn't going up much, and that's in contrast to the kids who, again, their um, life expectancy is so close to 100% to make it to adulthood. It's even hard to show any improvement. In fact, if you try to do a study, you couldn't show it because you can't move it any closer.
Yeah.
just not enough room to move to be able to statistically show something. But yeah, so that's one of the things that we really stress, and we actually have a, what we call our sickle cell boot camp that you participated in. That we actually train a lot of either nurses or doctors or hospitalists, looking not only just the key things to do when you see sickle cell, not just lectures. We want people to, they see someone with sickle cell, to know A, B, and C what to do right then, and who to call if they have questions. And one of the things we always stress is you're checking the organs. For the hospitalists, so they come in, heart, lung, brain, kidney. Are they okay? Is there anything going on? We need to know. And because so often it is, the pain is so loud and so bad, it kind of overwhelms everything else. And that needs to be addressed, but you have to, that's eventually not what's going to be the main factor in how well and how long people live. It's going to be those organs.
Okay. Yeah, I feel like it's only joining, or I guess joining the conversation is organ protection. And that's just been within the last decade for me, from what I've, heard. It's always been pain uh has taken front and center stage within a lot of these conversations. So I'm glad to see that organs are getting that spotlight, because it's the sneakier thing, it's the silent thing at the
Yeah.
end of the day.
It's kind of like blood pressure or cholesterol. It's kind of, they used to call blood pressure the silent killer. You just don't feel it until something bad happens. And I think in a good way, it wasn't talked about much because people, as life expectancy wasn't, before it really improved, it really wasn't much of a chance. Because I remember being told when I was just started that, oh, folks with sickle cell don't get heart disease, don't get this, don't get that. They just didn't live
Really?
now. Now they're living longer. We're seeing everything, and so I
Yeah.
think it really was just, what we call case finding.
Oh, they don't get heart disease because they don't make it to.
Yes, yeah,
Wow.
yeah.
Oh,
So
okay.
that's, and since they hadn't seen people before, as people getting older, they just assumed it was the same setup. And the last thing just to mention, and I hope this is not too graphic, but we really don't do many autopsy studies anymore. But when they used to, actually these were done in the 70s, late 70s. Keith probably remembers these studies. There was a pathologist in Alabama, Elizabeth Manshey, who used to do a lot of autopsies, not just to do them, but actually see what was going on with our poor friends with sickle cell who didn't make it. And 70%, 75% of the organs are damaged, but only 25% were ever picked up during the lifetime. So that's why we're really focusing
What do you
on
mean we're ever picked up?
clinically. If you go back in the chart and
Okay.
they say, oh yeah,
Okay.
they had this, you can look and go, oh, look at that. And then they go back and see if anyone ever either mentioned it or did anything about it.
Wow.
And again, because it's silent, a lot of it didn't get to the point. The body's pretty darn resilient till it isn't. The old saying, nothing happens fast, but when it happens fast. Because there's a lot of redundancy, a lot of backup, but you still can get nipped at. At some point it catches up, and so that's part of why we try to really screen early and often. Some to our patients like going, really again? I just did, I did that last year. I said, no, no, we want you to do it again, because we just want to make sure we understand what's happening with all our friends, because otherwise you don't know. You don't look, you never know. I'm happy to say most people, probably 87%, are screening fine. We pick up stuff all the time and things to watch, that comes up that at least we know they're there, and we can let the person know and how we're going to deal with it and what we're going to watch for. And, not trying to increase their stress, but to make sure they understand that that's why we're treating what we're treating. That, we'd love for them not to have sickle cell. They didn't ask for it, but, if we really pay close attention, that we can, it should be the least interference in their life we can possibly make it.
So I know we're running out of time, but I did want to ask this question. Any tips, medications for birth control and perimenopause? Would that be better handled with HEMOC or with OBGYN? And how does sickle cell impact that? And what I'll add to this is, oftentimes when I ask those types of questions, I'm kind of ping-ponged. Like, oh, you have sickle cell, so ask your sickle cell doc. And then, when I have conversations with you, oh, this is like, reproductive health.
Yeah.
Ask your OB/GYN. So who really has, like, who owns that space?
the short answer, whoever takes an interest will understand the data. And
Mm, yeah.
we, Neha Basin in our place has actually worked pretty hard to get a couple of perinatologists and OBs interested
Yeah.
in this to kind of understand it. There's a working group at the National Association of Sickle Cell Centers that's been pulling this together. Lydia Pecker is the doctor's name, Pecker. If you want to look up something online, she's probably has the most authoritative publications
Yeah,
about
she's
birth
great.
control and stuff. And so, I mean, so what we know about birth control, one, birth control is really important. So we'll start with that because pregnancy is I'll say two things. It's high risk if you're not being followed by someone who knows sickle cell pregnancy. So if you are pregnant, you need to make sure your perinatologist, your OB is a high risk person that knows, and if they don't, come call us. We not that we're doing anything magical, mainly it's because we have such good um, um, perinatologists, but okay, I'm not going to, I almost don't want to say it. Mortality, maternal mortality is
Oh
like
yeah, it's well known.
almost so different from what they show from the state. And it's not
Yeah.
nothing. I don't think it's necessarily us. I think it's really they're just watching people really, really closely. And I think that's what they just need to do. But we know that anyone with sickle cell is always slightly hypercoagulable. So we tend to, if you're going to use a birth control pill, we tend to use progesterone-only pills. Probably the best birth control is a IUD, a progesterone-eluting IUD of some sort, because it seems to be the best combination of effectiveness and convenience. Pills, we tend to go with progesterone only. And the implants with the progesterone, we've had a few patients with those. The only thing about implants you have to be careful of, if you start getting side effects, then you got to take them out. You just put them in. So that's kind of a not a fun procedure, but it's not that bad, if you have to, but just something that makes sure it works. And then, so that's kind of the quick answer to that, progesterone only pills, because anything with estrogen, even though the increase is not everyone that's on a combination pill will have a clot or something from it. You can actually show they do, the percentage goes up to, enough that it makes you worry about it. The only slight knock on progesterone pills, they're slightly less effective than the combination pills in terms of birth control. Still pretty small numbers, if you look at the whole numbers. So that's one. And what was the other question? Oh, perimenopausal? Oh, that's huge. We're kind of wrestling with that one because we really don't want to put people on estrogen. And so there's been some other medicines that have come out that have been not well studied. So I don't have a clear answer on that yet, but
Yeah.
it is again something people have wrestled with. We have several of our ladies that have been going through this. One of them called it her private summer that that's going on. And so we just kind of treat it more symptomatically right now because we're a little bit worried about putting people on estrogen that are already a little likely to clot. But there is some data, and I've seen a couple of OBs do this, that if you put people on the patch, the estrogen patch, you're less likely to clot. It's a whole lot less,
In the oral.
yeah, than the oral. And so
Yeah.
that maybe even for birth control, they could try that. But that's been about the only other thing that I've seen people do, except for just symptom control. Because even though menopause is for some quite challenging, it will go, it eventually goes away. So the question is, how much risk do you want to take trying to help the symptoms until nature takes its course, so to speak, and things just settle out on their own. So for birth control, progesterone-only pills, maybe an estrogen patch. For perimenopausal, mainly symptom control. If you really need to go to something, maybe an estrogen patch.
And what about pregnancy? This is the last question I'll squeeze in. We have actually Dr. Marcia Treadwell next talking about mental health and sickle cell.
Oh,
But
good. Oh, that's huge.
I
Yeah,
know, right?
this is great.
Um,
I'm quite honored to be here on this particular day too. So thank you for inviting
I
me.
know, no better day to be here, right? On World Sickle Cell Day. Pregnancy as a 39-year-old with sickle cell. Your
Mhm.
thoughts?
If they have one, you have to look at the other health or the health of the other organs. This is the first thing we do with our people thinking about getting pregnant. Make sure everything's okay. The only time I really stress that most, having a kid is such an important thing for so many people. We never, I almost said never advise not getting pregnant. Probably the only time we would, which we haven't had to deal with, if someone had documented severe pulmonary hypertension, because pregnancy
Mm.
at that point is really high risk death. But short of that, we screen, heart, lung, brain, kidney. If everything looks good, then we make sure you have a good high risk OB, and then you're, pretty much back to the background population risk of having a baby at 39. If it's your first child, and the same thing with that. We'd be quite happy to help someone try to get through that. What we often do with the first hint of any issues, if this person, did you say had SS or SC, or did they say?
They didn't say.
Okay, well, especially with SS and low hemoglobin, at the first hint of anything, we just start transfusing once a month. And that really pushes down, even though the data is, one study was a little conflicting, but mostly from the experience from the centers when we talk to each other and what we've seen, it's not a cure, but it really knocks down a lot of the complications. And, having a transfusion, from about the third or fourth month, until you deliver is not particularly arduous, and especially for the benefit people seem to get out of it. And the moms feel a whole lot better, and the babies grow a little bit better. And so that looks really, really good. And so, so we just look, for any excuse to start transfusions, and then kind of watch it from there. But no, I would definitely not say no. If again, with that one exception, if they really had documented clear pulmonary hypertension, because we've actually had, think it's not, it's just a high risk. You'd really have to sit down and think about it.
Yeah.
You know.
Well, thank you so much, Dr. Hager, for being here today on World Sickle Cell Day.
Thank
And
you.
you guys can imagine I have really, really great conversations with my doctor. And this is why. And like I said, I'm a lucky girl. Thank you so much for being here today.
Oh, sure. My pleasure. Thank you. I'm quite honored to be here. So thank you. And great seeing you, Keith. Take care. All right, I'm signing off.
Thank you. Take care. All right, so we have our mental health specialist, Dr. Marcia Treadwell. She is a clinical psychologist. I'm going to go ahead and let her in. So if you have any questions about mental health or any executive function, anything, you know what? She's great. We could throw anything at her, and I know she'll roll with it. So I will go ahead and add her in here.
Hello.
Hi, Dr. Treadwell.
Hi.
How are you? Good to see you.
Good. I'm good. And happy birthday to you.
Oh, thank you. She gets it. We call this our second birthday, World Sickle Cell Day. Thank you.
Yes.
Thank you. Happy World Sickle Cell Day to you too, and
Thank you.
happy
Thank you.
Juneteenth. And
Yes.
we're just so happy to have you.
Yes. Glad to
Wonderful.
be here.
So I am going to share a little bit about your background in a bio, and please feel free to fill in any gaps that I have. And like I said, we have Dr. Marcia Treadwell here. She is just top notch. I've known her for, I think, half of my life. This is another one. I know how to keep my doctors, guys. Like I know how to. Um, but just a little bit about her background. Dr. Marcia Treadwell is a clinical psychologist and clinical and health services researcher at UCSF Benioff Children's Hospital, Oakland. Um, and co-director of the UCSF Sickle Cell Center of Excellence. She has devoted her career to clinical care, research, and community advocacy for individuals with sickle cell disease and their families, leading multi-institutional international research teams studying how social, psychological, and behavioral factors impact health and well-being of people living with complex chronic disorders and conditions. So we have an all-star here. I think my first question will be to kind of break down what those things mean to it, I guess, in the context of sickle cell, social, psychological, and behavioral factors.
Oh, that is an excellent question. So I think what we've come since I started my career in sickle cell disease and in psychology almost 40 years ago, the focus on the body in sickle cell disease has really shifted to be a holistic focus. Now, people living with sickle cell disease totally understood, have always understood that stress and depression and anxiety can really exacerbate the pain experience, can exacerbate complications related to sickle cell disease. And healthcare providers finally are at the point of understanding there really is, it's just, you have to look at people holistically. And, so the social environment is so important. How much support does the person have or not have? How safe is their environment? How clean is their air? All of those things are going to affect sickle cell disease. And then behaviorally, the challenges that may come again with anxiety or stress or so on can really be addressed. So behaviors where people just take control and have better adherence to the what the healthcare providers recommend, that can really improve what happens with sickle cell disease. And then on the flip side, behaviors where people feel stigmatized and feel that they're facing a lot of injustices in seeking health care, and so they delay seeking treatment. So that kind of behavior can actually, again, cause more problems. So everything is really linked. There's a cycle, and we really have to look at sickle cell disease in a holistic way.
I like that. And is there, I guess, I think this is part of the work that you do where you're collecting data on how much those things impact sickle cell. Is there anything you can share surrounding that data?
Oh, yeah, really excellent question. One of the studies that we did with the Sickle Cell Disease Implementation Consortium looked at what are called social drivers of health and how they impact, again, people with sickle cell disease. So the lead author was Gustav Mendez in Chicago. And we put all together reports that people had. They completed surveys about their experiences, about barriers to healthcare, and what we found was not unexpectedly, but it's important to confirm these things in research that we all know, and that is that these social drivers of health really accounted for more of how what's called the variance or how people's condition with sickle cell disease was manifested than their quote diagnosis. So again, this is something we've learned over the years. When I started, it was thought, oh, hemoglobin SS is the worst, and the worst of all of the diagnoses. But people who don't have that diagnosis, like SC or S beta plus, it turns out with the more challenges in their environment or other factors that we just don't know about because it may be some other genetic thing, but the bottom line is that you can't say that there's always one diagnosis of sickle cell disease that's worse than the other, because if people have these social drivers of health, that's going to have an interplay with the diagnosis.
That just makes me think about, I guess, what is the perfect scenario in factoring in, and this might be an impossible question to answer, but in factoring in all of these, determinants, what should good look like for a sickle cell patient in order for them to, have the best quality of life?
Um, okay,
Is
that's
that
a
tough? Is that
yeah,
too
that's a tough question.
much?
So I'm going, since this is a conversation, I'm going to diverge slightly.
Sure.
But I will answer your question. So again, I started in my career really learning a lot from people with sickle cell disease about resilience. And so early on, I focused on what are things that can increase resilience. So what is resilience? Resilience is the ability to withstand all that comes at you, pain, medical traumas, psychological traumas, difficult living situation. Um, and in partnership with people living with sickle cell disease, I did learn, and they learned and taught me ways to improve resilience. But in more recent years, people with sickle cell disease have really reminded us as healthcare providers that resilience among the warriors and families isn't enough. The healthcare system has to change, and we have to create an environment that's better. So you see the difference where you say to a person, have the resilience to deal with that uh, person in the emergency room who doesn't have any compassion or knowledge.
Mhm.
But no, that's not the answer, totally. The real answer is we as healthcare providers have to take responsibility along with people with sickle cell disease to to change the system. Now, so that's kind of the harder answer on the one hand, but it sort of highlights that we all are responsible for this. So, more directly to your question, how can people improve their quality of life? Well, what people can look at about in terms of the factors that affect their quality of life are um, social support is an important thing. And so you want to look at your support system. You don't have to have a ton of friends, but you have to have at least one person who you really trust, who really has your back, and who will be there for you. So that's the first thing, social support. The second thing is in terms of quality of life, is what I touched on a little bit. Adherence with your treatment regimen. So, go out and understand why your healthcare provider is making a particular recommendation. Talk to them if you don't agree with it. But then, if you do agree with it, then do your best to make sure it happens. So, if there's a medication you need to be taking every day, or if there's a way that you need to be, getting enough rest or sleep, then you need to do that. And really check your goals and know that all of this, in terms of your owning your healthcare, is going to lend to you being able to meet your goals. Another thing in terms of quality of life is paying attention to your mental health. So the reality is that people with sickle cell disease do have a much higher prevalence of depression compared with the general population or the Black and African American population. And it's higher by a magnitude of at least twice as much, and it could be a little bit more. And so it on the where we now really work with people to say it's a part of living with sickle cell disease. That doesn't mean that you have to suffer with it. It means you need to get help if you do have serious depression that's interfering with your life. Let's see what else in terms of quality of life. I would say another important thing is having a purpose in life. Um, uh, uh, Focusing on achieving what you can achieve. And so, what can lend to depression is if you feel, I just can't, always, I can't do this, I can't do that. And that is depressing. But if you look at what you can do and really focus in on that and take the steps that you need to achieve it, then it's an important part of quality of life. So some of these things probably sound like, oh, that this works for everybody, and that's true. So what's something unique to sickle cell disease that we should think about? Well, we should think about pain, of course. So the issues with pain and quality of life are that's again a very long kind of answer and a full lecture, but I'll kind of distill it to understanding the factors that are going to increase your pain, like stress or triggers, um, or depression or anxiety. factors that you can again own to manage your pain up front, um, such as addressing triggers before they happen or trying to avoid triggers. Another thing is tackling the pain early. So people do know their bodies, and you can tell that this is going to turn out badly if I don't do something about it. So rather than waiting and waiting and waiting or trying to avoid it, tackle it as early as you can in the process of the pain developing. But at the same time, don't blame yourself if you can't have total control. um, Sickle cell is has some capriciousness about it, and there are things that people aren't able to control. So when that happens, control what you can control.
Yeah.
Rest if you need to, drink your fluids, reach out for support. And yeah, so pain is unique to sickle cell. So there are a lot of things you can do to improve your quality of life that are just the same as anyone else, but pain is a particular issue for people with sickle cell disease, obviously, and so you really have to tackle it in a particular kind of way.
And what about fatigue? I think fatigue is also, would you say, particular to sickle cell?
It really is. And another, when we created the Adult Sickle Cell Quality of Life Measurement Information System, we asked people with sickle cell disease to outline what their main issues were or priorities in terms of their health. And this is where you have to have a partnership between researchers and people with sickle cell disease, because we didn't identify fatigue as prominent as it turned out to be. So everyone does think about pain and thinks about that as a prominent factor in sickle cell disease, but fatigue is huge. And so once again, you want to take steps to manage it when you can and adjust where you can, so that your life is still productive and fulfilling despite having the fatigue. But really people should talk to their healthcare providers about what some of the options might be.
Yeah. And is there anything else besides, anything else that's sickle cell specific to call
Yes,
out?
there definitely is.
Oh, okay.
Um, what is being appreciated a lot more than it used to is that sickle cell can affect the brain. And so people knew about stroke, and I'm sure that, when Dr. Keith was working with kids and their parents, that would be the thing that you'd bring up to a parent, look out for the signs of stroke. Um, but we've really learned a lot about what are called neurocognitive challenges that people can have. So, brain health is also a key feature of sickle cell that's recognized a lot more than it used to be. And the issue can be that there can be like mini strokes, or there can be challenges with oxygen delivery to the brain, sickling in the brain, and so that people can have more learning problems and problems with planning, and that's called executive function, problems with processing speed, so that they may or may not do as well as other people in terms of doing things quickly in the classroom or on the job or thinking fast. So the planning and the processing speed can really be affected in sickle cell disease, and really need to be recognized. And people have to consider what they need to do to adjust if that is an issue that they find in themselves.
So how do we find out, what these things could look like? Are there particular tests that we can take? And if somebody isn't necessarily associated with a sickle cell center, how can somebody find out about, whether they have these issues?
Um, we don't have as many neuropsychologists as we really need in sickle cell centers. But in some centers, there's the availability of neuropsychological testing. And what neuropsychological testing does is give you a profile of what your strengths and weaknesses are. So our thinking and learning is complex, and it does have, again, these aspects of like planning, aspects of memory, aspects of how fast you can think or solve a problem. Are you more verbal, or are you more a person who learns by hearing or working with your hands, that kind of thing? So the neuropsychologists, in the best world in sickle cell disease, where you have all the resources you need, can give a test to people that takes actually about 6 hours. I mean, it takes a while
Oh,
to
wow.
really get a full profile of a person's strengths and challenges in terms of their brain health. In the absence of a neuropsychologist as a part of a sickle cell center, one thing that we have worked on, and we had a great neuropsychologist working with us, Judy Cavazos, who worked with neuropsychologists around the country to come up with shorter screening tools. So if your provider says, I want to ask you some questions and I'm going to like name 3 animals, and then 5 minutes later they ask you what were the 3 animals, that kind of thing. So they can do screening tests, and then they might have you do more neuropsych evaluation if they find something on the screening test. Um, then the third thing I'll say about evaluation is, particularly if you're still in school, um, it's the school's responsibility to provide these tests. So neuropsychology is expensive. There aren't as many neuropsychologists as we need. So where can you get it when you aren't able to access it easily? You can get it through the schools. And then a fourth potential is through the Department of Vocational Rehabilitation. So I think that's under used by people with sickle cell disease. They're there to help you. And you can ask them again about tests that look at how well your brain is functioning.
Yeah. So I have a question here. Actually, two questions came in about workplace and stress.
Okay.
Um, what advice would you give to those with workplace stress? And then the second one is similar. If you work at a job that is stressful, but you're not in the position to leave, how could you manage that?
That is tough. Because as you were reading the first question, I was thinking, well, hopefully they can leave. But
Yeah.
we're in in a context now where jobs aren't necessarily easy to find, and so yeah, if you really can't leave, then that's an excellent question. How do you manage it? I would say that one thing to do would be to go back to the concept related to support. So do you have someone that you can talk with, who can talk you through some of these stressful days and hours with your coworkers or employer who are causing you stress, or the job itself is stressful? So social support could be one thing. Um, Another thing in dealing with stress is um, meditation or relaxation. So, a meditation practice is really important for people with sickle cell disease, no matter what. What a meditation practice does for you is helps you learn about really getting your body into a state of calm. And ultimately, you focus in on your breath. And if you practice every day, more than once a day if you can, when you're in a stressful situation, then you can turn to what you've learned. So a meditation practice can be anything from 5 minutes to an hour, let's say, of meditation. But when I keep saying practice because you do that, when you're, in the morning or in the evening or whatever time you can devote to it. And breath is is foundational to a meditation practice. So then when you're in a stressful situation, because you've practiced it, you can turn to your breathing and that can calm you pretty quickly. But you really do have to practice it outside of, where the stressful situation that you're in. The other thing I'll bring up is a psychotherapy, a form of psychotherapy that there's evidence, and I know you have been a part of studies with Dr. Jonathan Saint, where he has looked at cognitive behavioral therapy for people with sickle cell disease. This is a very well established intervention that works really well. So what is cognitive behavioral therapy? Well, what it does is it ties together behaviors, thinking, and emotions, and allows people to think about that how I think affects how I feel and how I behave, and those things affect how I behave. And then again, it's another cycle. Then my behavior affects my thinking and my feeling. So, cognitive behavioral therapy does help you to feel more control over a situation that may inherently not be in your control. And what you can do is you start to change what you say about your experience. So think about if you are, with that stressful employer, and you say to yourself, "This is hopeless. I can't leave this job. I hate this job. Um, and I'm a failure." So you say those negative things. In cognitive behavior therapy, you can interrupt that train of thought and say to yourself, um, you can go different paths. This is going to be over in 4 hours. I'll be off soon, and then I can join my family and
Yeah.
and just be away from this. Or you can say to yourself, I am confident. I know what my capabilities are. It's not being recognized by this employer. I am going to take some steps to find an employer that is going to appreciate me more. So you can have a positive thought about yourself in that situation, or you can think about, okay, it's going to be over soon. So those kinds of ways of thinking help you feel calmer. They help you feel less anxious and depressed, less stressed, and then you're going to, feel better. Then the third thing, though, is that you could take some behaviors. What's a behavior that I can take in this situation? So again, cognitive behavioral therapy has that element too, the behavior. Um, is a behavior I can take to talk to the boss? Is a behavior I can take is to simply, again, get through these next few hours and get home and just relax and chill there because I don't have other options? Or is the behavior to go see a therapist to learn about this a little bit more in depth and help me figure this out? Or establish a meditation practice so I can help myself when I'm under stress?
Yeah. Do I guess meditation and, CBT, and do they work for everybody? Like can is there, I guess, data out there that shows that these do work for everybody and this is something that every it's a tool that everybody can use? And I guess I kind of ask for myself in a way, like for example, for meditation. And maybe it's because I don't practice enough, and maybe it's because I don't stick with it well enough. But um, you're supposed to ignore thoughts, and you're supposed to but for some reason, I don't feel it works for me, and maybe I'm doing it incorrectly. So I guess my question is this something that's actually supposed to help everybody, and I'm doing it incorrectly, or is it kind of on person basis?
Um, that's a really great question. And another component that's been brought into cognitive behavioral therapy is what's called mindfulness.
Mhm.
And so, what you do with mindfulness is actually you don't ignore the thought, but you let it pass. So, you think about it as a cloud, that's floating on the wind. And by in that way, you don't judge it, as positive or negative even, and you just notice it. And what mindfulness does is really allow you to sort of accept what's happening now, but again, without the judgment. So again, think about it. In cognitive behavioral therapy, it is always about you are trying to shift a negative thinking, and mindfulness is another piece of that, where you can just it's a different, it's not ignoring it, but it's just letting it pass. And because if you hold things in there, it's definitely shown that when you don't do something about it, that it's going to cause something negative like pain or low oxygen uptake because you're tense, and so on. So I think that what you can do, besides think about the mindfulness aspect, is also know that there are different things that different people can do. So some people will get what we're talking about by jogging or walking in nature.
I see.
So you don't have to, meditate an hour a day. You really don't. It's good and it works for a lot of people. But some people do more of a moving meditation or exercise where they're able to get out of that experience that they're having that's negative. Music, a spiritual practice. So if it doesn't work for you, what I would advise is first to think about, maybe do a little research. What are some practices that maybe could work for me?
Mm,
Should I add mindfulness, or should I think about, rather than trying to do this for an hour, just doing it for 5 minutes, or should I just focus in on my breathing? Um, so that would be one thing to figure out if you can make meditation work for you. But then the second is, what gives me joy? What makes me feel relaxed? And let me add more of that to my life. And then third, of course, the physical activity is prescription for every person with sickle cell disease too, at whatever level you can do it, whether it's gentle yoga or running a marathon. Physical activity is a way to not be in your head and really reliving the negative thoughts, because that's what we found with cognitive behavioral therapy, is that it's just really dwelling in the negative thoughts that causes the problem.
got it. Oh, got it. No, I think you just kind of opened my mind because I'm thinking, oh, if I'm supposed to meditate and I'm not very good at meditating, then that means I don't have an out. But then as soon as you brought up music, I was like, oh, yeah, I could listen to my favorite song and that can get me out of some sort of a funk or
Mhm.
so it really is having people understand what puts them in a good mood and kind of just knowing yourself and your body in that
Mhm.
way and what your body might react to in a positive way and
Yeah.
knowing that about yourself and utilizing that
Hmm.
essentially.
Yeah.
Okay, okay. That's good to know. You talked a bit about resilience
Hmm.
and I've never heard it uh, I guess, described the way you described it. It almost sounded like it could be a medical term in a way,
Hmm.
where it's just, how my takeaway is how long somebody can deal with, I guess, adversity for.
Yes,
Um,
exactly.
is that measurable in any way? And how I guess what role does resilience play in being able to coping with sickle cell and
Mhm.
how can it be built?
Yeah, um, you want to think about resilience as like um, a tree that is going to a young tree maybe that when the wind blows, it's very flexible. And in fact, uh, there's a symbol in the Akan symbol for resilience really is a fern. So it's a plant that no matter what happens, the wind can blow, a flood can come, but it always comes back. It always comes back. So so life is going to throw adversities at us, and that is the fact. We're going to meet adversities. The question is, how do we meet the adversity? Because they're going to come. So, an important thing is that, in fact, people can um, have what's called stress related growth so that the adversity doesn't beat you down and flatten you. But in fact, you can grow stronger from the adversity. So that tree that survived the hurricane, it actually maybe it's a palm tree in the Akan symbol, I think, because it survives the hurricane, let's say, but and it's stronger because it's still there. So that's really what resilience is that life is going to throw challenges at us, and we can become and will become stronger. It does take some tools sometimes for that to happen.
Yeah. Um, that's really great to know. I never thought of any of this in in this way, and I feel like my brain chemistry is changing right now in how to because a lot of times within sickle cell, very, very easy to get buried under heavy thoughts, buried under
Hmm.
negativity, and um, very, I think, easy to feel sorry for yourself. And
Hmm.
it's justifiable too.
Hmm.
It is a beast. Um, so being able to climb out of that is
Hmm.
something that sounds like can be taught and
Hmm.
something that sounds like we can actively practice.
Yeah. Yeah, absolutely. And that's what I really love about cognitive behavioral therapy because it,
Okay.
it does work, and people, yes, you can learn strategies to become more resilient. But you said something that's really important in terms of the negativity can be hard to kind of climb out of sometimes, or many, many times. And I really don't want anyone to feel like badly if they're like, oh, I'm just so negative, or I, I can't get over this. And again,
Yeah.
what you said is really important, that um, you're dealing with something that is it's an incredible level of adversity. So, so people who don't live with sickle cell disease, they may have other adversities, in their lives, or different medical conditions, and so on. But sickle cell disease it's a powerful um, force that can be very traumatizing. And so no one should feel like, oh, there's something wrong with me because I feel hopeless. That's not what I'm saying. So I want to be really clear that if you
Yeah.
feel hopeless or you want to give up, that comes because you're dealing with something that's tremendously challenging. But what you again can do is try to use tools to turn that around a little bit. And it's not saying, oh, everything has to be perfect either. You aren't, and that's another aspect of this, that you aren't trying to turn it around to say, oh, my life's perfect. This is wonderful. I love this because it's causing me so
It's
much
like
stress and I'm getting stronger.
gaslighting yourself in a way.
Yes, you don't want
That's
to
even the correct.
gaslight yourself.
Yeah.
So again, good point. Don't gaslight yourself. Just take it as the reality. But sometimes it
Yeah.
can also help to say, oh, actually other people do deal with other stuff too, and I don't even know what other people are dealing with. So that's isolation is a huge issue in mental health for people with sickle cell disease. And so when you feel like I'm the only one, that's a problem that causes a lot of problems. But when you can reach out to other sickle cell warriors, and when you can think about, oh, my situation is similar to that person, with hemophilia in this way. So then you feel less isolated, and that can allow you to cope. So sort of looking outside of yourself, or again, being sure that you've built a support system, because isolation is a really negative thing that people may be dealing with, and they really need to figure out ways to not have that happen, because it's very, very unhelpful.
Yeah. How much of your work covers the caregiver experience in sickle cell?
A lot. So, um, at the top of our time together, we were talking about what creates an environment of good or bad quality of life. And the parent of that child with sickle cell disease, and Dr. Keith may remember this, we really worked hard to understand what level of stress that person was when they brought their baby in who was newly diagnosed. And we worked hard to try to create all of these things I'm talking about for the caregiver, because that person's experience is going to impact that child, and both positively and negatively, in the sense that, the best thing for a child, a baby with sickle cell disease, is the love that their parent gives them. And that's that's a key right there. But we want to help the caregiver deal with levels of stress, like using, again, the relaxation or the stress management, or make sure that they aren't socially isolated, or make sure they're addressing their health challenges themselves. Make sure that they feel that they have control over something. So you don't have control if your child has a splenic sequestration, but you have control by recognizing and getting them to the doctor right away. So, you don't have control of their pain necessarily. When you see your baby with, swollen hands and feet, that can be devastating to the parent. What can help them is to, um, get the child the help they need right away. Know that they're there as an important comforter to their child. Know that they can use strategies themselves to teach the child how to manage pain and manage fatigue. So, and that continues throughout the life the course of the life of the individual with sickle cell disease. And that's one thing that we also, when we have had transition workshops, we work with from transition from pediatric to adult care. We don't just say to the adolescent, "Oh, let's talk to you and educate you about how you're going to move into the adult world." What you also have to do is talk to the caregiver or parent who's devoted their life to this child. How are you going to transition to being their partner in their healthcare? So you
Yeah.
move from being responsible for their healthcare to being a partner with them in their healthcare. And a person with sickle cell disease should never be in this alone. They shouldn't, just because you have independence, just because you're an adult, doesn't mean that you have to take this on all by yourself. If it's not your parent, it could be a friend or a life partner or a spouse, whoever can be a partner in your care. That's incredibly important. And then that person can experience the same kinds of stress because of how sickle cell disease, can have these life-threatening complications, and things can come up no matter what you do to do your best to try to avoid, again, triggers or these episodes. So the caregiver needs support as well. And these techniques, cognitive behavioral therapy, meditation, can help the caregiver as well.
Yeah.
Do you think
Yeah,
that do you think that education empowers people to be able to cope? Like, I'm just thinking about Sickle Cell 101 and what we're doing
Mhm.
right this minute. Does that help empower people to be able to cope better with like sickle cell disease?
It really does, because that element of where can you control things, because I think where people stress starts to overcome them is when they feel like, I totally don't have any control over this. But when you take control where you can, you educate yourself so that you recognize what's unfolding in front of you, or so that you learn different tools, you expose yourself to different tools. You do what Cassandra just did. You say, well, I'm not good at meditating, but then you open your mind to, oh, there may be something else I can do that's similar or serves the same purpose. The more you educate yourself, yes, the more power you're going to have in your life. And so I commend SC 101 for this series and for your whole, purpose. It's incredible. It makes a huge difference in people's lives to learn and know and hear your research, but then move on and maybe do their own. And I think that's important too.
A question I have from the audience is, as someone with sickle cell, it gets exhausting explaining my diagnosis to
Mm.
everyone and everyone new in my circle. What advice can you give for that?
Mhm. That is tough. I think there could be an element of, yeah, I mean that's a tough one because I'm thinking on the one hand that there's a discernment where some people just aren't worth you explaining your situation to them. On the one hand, but on the other hand, then you don't want to increase isolation, or you don't want them to know how to support you if something were to come up. So I do think you can have different levels of how you explain things. That there are people who are going to be really close to you that you want them to know the details, and you want them to know exactly how to support you when needed, and how to advocate for the sickle cell community. And then there are others who, you just want to explain enough so that you are able to have an equal relationship with them, and they don't feel sorry for you, or they don't feel afraid of you, those kinds of things. So I think that's the exhaustion that the person is kind of alluding to, that if you have to constantly explain, and maybe you could just turn them over to SC 101 website.
That's what I actually wanted to say. A lot of people will take a video and send it to their mom or their friend, and they're like, this is what I'm trying to say to you, and just
Mhm,
have other people, you could even have a friend that, can just speak on your behalf and, kind of take on some of that because it is burden to explain.
mhm,
It's burden, like this is so now it's not sickle cell, right? But like I got a DoorDash and I got the order wrong, and I explained the order to one person. And then like the next day I had to explain it to another person. And I had to explain it to like five different people. And I was getting so annoyed
mhm,
because like how many times do I have to tell this story? How
mhm.
many times do I have to
Yeah,
articulate my issue?
yeah.
And that's just a DoorDash order. And we're talking about something you're living with, and
Yeah.
sickle cell, and it's very hard to convey, and it also sometimes traumatic to convey too. And
Yeah.
sometimes you don't want to be in that space, right? And
Yeah.
so you can have other people speak up on your behalf, or if there's a video that resonates
Mhm.
with you, then you save and you send it to somebody or save it
Mhm.
and just say, here, watch this.
Yeah.
But I really love what you said, where there's levels to this, right? And how much
Mhm.
using discernment, and how much you want to open up to a person, and in that way. So
Mhm.
I really like that too. Um, I think I read a study once that talked about PTSD and sickle cell. Is
Mhm.
there any research or anything that you can speak to about PTSD and sickle cell from both a patient and a caregiver perspective?
Mhm. Definitely. And it does really tie in with the caregiver and the person living with sickle cell disease. Um, think about it that, the pain that people describe um, in sickle cell disease it's a trauma on the body, so that intensity of pain causes the nervous system to, sometimes become overactive or become unregulated. So the experience of living with sickle cell disease, excuse me, the complications, that's a trauma. And I think if people think about it that way, then I think that's important. That I've been through a trauma when I had acute chest syndrome, or I've been through a trauma when I, had to go under anesthesia for surgery. And then you think about, what's the trauma that comes with that as well. And that is, I had to sleep in the hospital, by myself. I was just a little kid, and my parent wasn't able to stay with me because they had to go home and be with the other kids, kind of thing. So that's a trauma, to have that separation from your caregiver. It's a trauma in terms of uh, getting an IV start or blood work. But the, so post-traumatic stress disorder is real. And that's where people might see that they drive by the hospital and they are hyperventilating. So that's a stress response. And you're like, well, what's going on? Why did I do that? And it's because you were in that place where you were traumatized. Or the parent sees their child do that when they get near the hospital. Or the child, wakes up, or the person wakes up in the middle of the night with a nightmare because of what they've been through. So again, trauma is real, and that is where, for people living with sickle cell disease and their caregivers, you want to work on these tools. You want to use cognitive behavioral therapy to help you talk your way through dealing with the stress and trauma. You want to use whatever relaxation or physical activity or art or music to help you through, that trauma feeling. But then on our part as healthcare providers, we have to create environments that are better for people with sickle cell disease. And that includes the compassion of the provider who isn't one of the people who's asking you to explain yourself. The provider needs to take the time to learn themselves what the person with sickle cell disease is living with. And there's something called trauma-informed care. And so a really good healthcare institution is going to be instituting trauma-informed care. And what does that mean? Well, it means that every person is sort of approached as if they've experienced a trauma, and you're going to be more compassionate and more. You're going to do certain things a certain way. When you use this approach, which is called trauma-informed care. And the key is that you don't re-traumatize, that you don't make it worse by trying to start the IV 5 times instead of giving the person a break in between, or really using strategies where you don't traumatize them with that needle stick or IV start. You don't traumatize them with providers, who are biased and stigmatizing. You make every effort to make sure that family can be there, to be a support of that kind of thing. So that's trauma-informed care. And that's the responsibility of the healthcare provider to institutions and systems to really create these spaces for people with sickle cell disease.
Wow, I've never heard of that before. So it kind of sounds, if I'm hearing right, like method acting in a way where you kind of try and put yourself in the patient's
Yeah.
shoes to.
Yeah, definitely. There are a lot of tools that I do teach, and that are other people teach healthcare providers to help them um, not to re-traumatize people. So, we're humans, healthcare providers are humans. And bias is a part of how we manage our environment, in the sense that I have to, people automatically look at someone and make some kind of judgment. And that's not necessarily bad. It's just a way to manage the environment. But when you have a negative assumption about a person, or you aren't open to them being something different than what you thought they were going to be when you made that snap judgment, that's when bias is a problem. So bias in healthcare is a huge problem. Um, Again, I like the way you put it, method acting. We have to step outside of ourselves as healthcare providers, um, know that bias happens, but take a pause and not let that bias affect the way we end up interacting with the person. So yeah, and how we teach about this, we give vignettes of, let's say a young person with sickle cell disease, and the healthcare provider does again immediately have some thought about, a 20-something-year-old with sickle cell disease, and we say to them, step back. What first identify what was your assumption, in the and when you practice it in a workshop, for example. And then you say, well, did you stop and think that this person actually is a college student? You made assumption about their educational level, but you didn't stop and think that they have these other things that they're, that's happening for them. Or you make an assumption about, the whole idea of that people are in a certain amount of pain because of how they look. And so again, as providers, you really have to step out of that and be open to that people express pain in different ways, and you are there to treat the person and not re-traumatize them. So it is an important concept in healthcare that I am happy is there, because um, people have enough trauma and challenge, and we don't, as healthcare providers, we shouldn't be adding on to that.
Yeah, agreed, agreed. I know we are almost at time, but I wanted to um, ask you what is exciting and what you're currently researching right now, and if there's anything you can share to kind of give the community insight as to what research looks like
Mhm.
in your field right now.
Yeah, for myself, I'm a part of networks of care, and so that's exciting to me. So I mentioned the Sickle Cell Disease Implementation Consortium a couple of times. And so what implementation science is taking, the brilliant discoveries that are made. So it's actually easy to discover a new drug in a way or a new treatment, but it's hard to get it into practice. And
Yeah.
so the research shows that when discoveries happen, well, let's just take hydroxyurea. There are so many barriers to hydroxyurea, and yet it's very effective. And so implementation science looks at, well, how do you get people to overcome misconceptions about it? Or how do you get providers to be well educated so they prescribe it correctly, that kind of thing. So what I'm doing right now is I'm working with different networks using implementation science to get the best evidence informed practices actually into practice. So I'm part of the Pacific Sickle Cell Regional Collaborative, and we're going to be using linkage coordination, which is finding people who have fallen out of sickle cell care or have never been in sickle cell care, so usually adults, and really encouraging them to understand that um, prevention is key to your long life and your quality of life.
Yeah.
The healthcare system may have been negative for you, but we can work on either building resilience where you can't change things, or we can advocate for you so that you have a better experience in the healthcare system. So that's one network of care on the regional level. And then we want to, my colleagues at the Sickle Cell Center of Excellence, we're really working around the Bay Area, but we could spread this around the whole country, and other teams are working on this. And that is to have a network where you don't go to one emergency room today and you get a certain experience that is terrible or poor care. And then you go to a different one and you get a whole different set of ways that they approach you. What we want is for people to see that we have guidelines and implement it every time, everywhere. So we
Yeah.
just want people to get the best care every time, everywhere. And so that's implementation science. And again, I'm involved in networks that are figuring out ways, barriers from every angle, the provider angle, the system or institution angle, the person's angle where they may avoid care because of these fears and so on. So yeah, that's what we're working on.
Fascinating. And I 100% support the work that you're doing because implementation, you're right, is half the battle. And
Mhm. Mhm.
it's often an afterthought.
Yes.
You build something so great, but then where does it end up going at the end of the
Right.
day? So,
Exactly.
very interesting work. Well, thank you so much, Dr. Treadwell, for being here today. It's always a very interesting conversation. I always learn so much from you, and I feel like gain another perspective that, is something, or, there's some sort of hidden thing within my life that you kind of add a term to, and help me acknowledge. And so
Mhm.
that's always really helpful because I'm one of those people who I love everything to have the name and to be able to acknowledge what I have and kind of know what I'm dealing with from my end. So I appreciate you taking the time to talk on World Sickle Cell Day and
Yeah.
sharing your expertise with us.
All right. Well, thank you again so much for having me, and thank you for all the work that you do.
Thank you. Thank you so much, and happy Friday. Have a wonderful weekend ahead.
Thank you.
Thanks.
Bye
Take care.
bye.
All right.
It's 13
Bye.
hours.
All right, we have our next guest here. This is our second to last guest. We have Jimmy Hair, and I am so excited to talk to him because he is a gene therapy recipient. So a lot of you all ask questions about gene therapy, what it's like. Um, how does one decide to undergo gene therapy? So now is your chance to ask those questions. We have somebody here who's been through it, who can really give us the 411 on this, really share what maybe doctors can't share. So please feel free to put your questions in the chat. Any questions you have around undergoing gene therapy, we have Jimmy, and I'll go ahead and let him in here. Hello. Let's see if you can. Hi, Jimmy. Can you hear
Hey,
me?
Cass. Good. Can you hear me? How's my
Hello.
audio?
Yes, happy World Sickle Cell Day.
Happy World Sickle Cell Day. How you holding up?
Oh, I'm good. I've been at this
Good.
since 7
Yeah.
a.m. and it's 1 o'clock where I am. So if I'm like, if my words are being slurred or whatever, bear with me, please. But you know what? We always have really invigorating conversations, so I know this is going to be a good one. So I want to share with those who are online who Jimmy is. Jimmy is a sickle cell global advocate and recipient of a transformative therapy, Casgevy gene therapy. After living with sickle cell disease for 35 years, and Jimmy, I pulled this offline, so please let me know if it's anything is incorrect or needs correcting. So after living with sickle cell disease for 35 years, his participation in a groundbreaking gene therapy clinical trial resulted in a functional cure, propelling him into the forefront of the conversation around gene therapy's potential to revolutionize care. He's now a passionate champion for equitable access for sickle cell disease treatments, including curative intent therapies, and was the first person with sickle cell disease. Hold on, you guys. Hold on. We need like a drum roll right here. The first person with sickle cell disease to summit Mount Kilimanjaro in 2024. And I have excellent conversations about that. And, I still have so many questions about that. But y'all, Jimmy has been to Mount Kilimanjaro. What a feat. What an accomplishment. So Jimmy, welcome to our Ask the Experts Live. This is a special segment we're calling Flip the Script because within this particular program, we're usually asking sickle cell specialist questions, but we also recognize that we have lived experience experts within the community, and who are just as qualified to answer these questions, and maybe even more qualified because you've lived it. So. Um,
Agreed.
Thank you for being here. Thank you. Sorry, that was a long intro, but thank you.
No, all good. Thank you for having me.
So, to start you off with the question, how are you today? You are what, 5 years out now? Around 5 years out from being transformed. I don't know if we use that
Right?
terminology, being
I
transformed
know.
from sickle cell. They used to say cured, but we don't say cured anymore because it's a transformative therapy. But what is life like for you right now?
Life's great. I'm
And you
still
can
have daily
you don't
living.
have to paint like a perfect picture either.
Oh
And I know
no,
you won't. I know you'll be honest with me.
I
You don't
will
have to be
be
like,
correct.
everything is
Yeah.
great. Come on over.
No, at this very moment, life's good.
Good.
2026 has been fantastic. Obviously, as you mentioned, I'm really fortunate to go through that CRISPR-based gene therapy that I qualified for. Not many people know this. I was about a few months from aging out. So really, really lucky to get it in the last 2 months before I aged out, and completely changed my life. As you alluded to, post-transplant life has really been peaks and valleys. One moment you're on top of the world, quite literally in Kilimanjaro, and the next you're living in the hotel. So it can be ups and downs, but generally speaking, it's been fantastic.
Oh, I'm so happy to hear that. What are you working on currently?
Working on right
Yeah,
now,
yeah. What's exciting? What does your work look like right now? Uh-oh, I think I'm losing you. Uh-oh.
um,
Dr. Q, do you hear him or is that just me?
No, it's he's breaking up.
Oh, okay.
me kids on this.
Jimmy, we don't hear you.
Oh,
I think you're breaking out.
I'm back. Am I good?
Yes, yes, you are.
Okay. Sorry about that. Yeah, I'm not sure what happened. I had a little bit of connectivity issue. But you asked me what I've been working on, and I'm saying, these days what I've been working on is spending more time with the kids. So that's one thing gene therapy has afforded me the ability to keep up with three kids under the age of 6. So yeah, that's what I'm spending my time doing these days.
Okay, and I know that's already a full-time job right there, so
Yeah, it is. It's a hands-on all day activity, and right now it's summer too. So when they're not in summer camp, we're
yes.
we're extremely busy.
Oh, I know, I know. So Jimmy, tell me a little bit about, I think one of the top questions that we get from the sickle cell community is what is the process actually like? And people hear, either bone marrow or stem cell transplant or gene therapy, and they think about going under the knife, and it's just this very huge production. Can you kind of help paint the picture of what the process is actually like?
Yeah, I would tend to agree. It is kind of a huge production. It's very cumbersome in the format that it is right now. And it has multiple steps. So first of all, if you're doing gene therapy, it's most likely autologous, which means you're using your own stem cells. So the first part is collecting those stem cells to actually edit. So that would be probably the first part is going through a month or two, depending on the medication they use to mold again.
You're back.
Oh my God, I'm just going on with the connection. It could take a couple of months, hopefully days, weeks to get collected. Like I said, it really depends on the mobile age. Everyone's different. I'm not quite sure why some folks need to get collected. Others get collected twice, sometimes three times. In my case, four times. So
Oh, wow.
that was a huge issue. Uh, after the collection, yeah, after the collection, there is the conditioning. As you know, it's still a stem cell, not a stem cell transplant. You're still going to have a transplant, so they need to kind of make room for your new stem cells. So you go through that conditioning process, which is also quite difficult. And then eventually, after your stem cells have been wiped out, the ones that you have in there with chemotherapy, the final stage is getting infused with your new stem cells, which have been transported from another lab where the genetic engineering has happened and brought back to you in the hospital and infused directly into you.
Hi, Jimmy. My name's Keith. I'm a pediatrician. I work with Sickle Cell 101. What do you think was the hardest part? Waiting to make sure that, that they were doing the right things with your stem cells or the chemo or just getting the infusion and then being in the hospital for weeks? What do you think was the hardest part?
Uh, for me, actually, the hardest part was actually post-transplant. Believe it or not, the collection definitely was hard. In my case, I wouldn't call it painful. I would call it very, very uncomfortable. I've heard that some patients do feel pain during this process and can potentially trigger sickle cell crises, but thankfully that did not happen to me. The conditioning was also quite difficult. A week of busulfan and not feeling that symptom. For me, I'd had this pop culture reference of what chemotherapy was like. Once you get infused, you feel it instantly. Unbeknownst to me, you don't feel the symptoms of chemotherapy for until probably 7 to 14 days after. So that was a little weird and difficult as well. But I faced most of my challenges after I actually got infused when I was dealing with who this new version of Jimmy is going to
Oh,
be
mhm.
after living with sickle cell disease for 35 years. And one day it kind of left, and everything I had known and become was built off of the foundation of sickle cell disease. So I had a identity crisis and really massive bout of identity crisis. I mean, I'm sorry, survivor's guilt. And yeah, that was the most difficult part for me.
Yeah, and you spoke a little bit about this in the video that you had with the Dr. Natasha Archer. Um, how do you identify? What is it? What have you come? And I realize it is a process, right? And it's not kind of like you have an answer the day after you undergo this. But where are you at right now with how you identify with sickle cell?
Yeah. I think it's still a work in progress. Definitely do not feel like a sickle cell warrior because I don't, I'm not in the trenches anymore, thankfully. Um, so I definitely don't identify as a warrior, but I know I still have certain remnants that once in a while would rear its ugly head. So as you know, the gene therapy I should say, um,
Oh, you're breaking out again.
does not go directly for the sickle cell expresses hemophilia disease. Um, I think let me see if I can change locations. Is that okay?
Yeah, sure. Do what
Let
you
me
need to
let me
do.
let me see. I'm not happy that I keep going in and going out. Let me quickly change locations and get to somewhere where I think somewhere in the house where I can have better service.
No problem. I'll chat with Dr. Q in the meantime.
All right, give me 5 minutes.
Hey, Dr. Q.
That's pretty amazing. You'd think that he would have said that part of the procedure was the hardest part, but really it was, and we've heard that from other people that not having sickle cell, I mean, to me, I don't know, it's like you still kind of have sickle cell. I mean, you have that life, especially him, he's had this life experience. So it's interesting that you feel like not only have you physically changed, but your personality somehow has changed, or you as a person have changed. That's really an interesting and very common thing that happens to people after transplants, gene therapy.
Yeah, and I never even thought about what that's like across the board, even outside of sickle cell. But one of the first conversations I had with Jimmy was he found out that he is not an introvert, and it was sickle cell that made him introverted,
Oh,
and
wow.
yes, my mind was blown. I was like, wow, so I might be an extrovert, but sickle cell is holding me back and I'm introverted because of it. And so identity is such a huge piece to
Oh,
all of
yeah.
this. And hopefully when we get him back online, we can ask him to expand on that a little bit more because it's just so interesting where you see yourself in the context of where you are with sickle cell, and then after post transplant. It's really interesting.
Yeah, there should be some kind of identifier for people who have I don't know. It's got to be difficult.
What's up? Okay, can you talk to Papa about that? Jimmy talked about kids on summer break, and then here comes mine.
Oh.
She's she's doing her chores to get an allowance, and she's
Oh,
just very adamant about sharing what she's done so that she can get paid.
right.
And so that she can buy Little Caesars pizza as many as she wants. And yeah, yeah. Um, so what's the most interesting part of the conversation today so far, Dr. Q, would
You
you
mean
say?
among everybody?
Among everybody.
I really, really liked the first speaker.
Vivian Sheehan.
Viv,
Yeah.
she's very, very good at explaining things, and she's very knowledgeable. I mean, she's and very personable, actually.
Yeah.
Yeah.
All right.
Everybody was good, but maybe because she was the first one, it was the most, but she was great. Yeah.
Yeah. Hello.
I am back. I
I
think I suspect my connection will be better. Sorry for interrupting.
No, no, not at
Oh,
all.
that's okay.
I was sharing with Dr. Q how you really opened my mind to like how much identity is tied in with sickle cell. And I will never forget the conversation we had where you talked about uh, after being post-transplant, you found out or you discovered about yourself that you're not as introverted as you thought you were. And that like blew my mind because I consider myself an introvert, and I wonder how much of that is actually me and how much of that is sickle cell. So, would you mind expanding on that a little bit more? Because it's just so interesting. And I'm so happy that you came to that because it makes me think how much of who I am is actually
Yeah,
sickle cell and how much of it is, sickle cell holding me back.
absolutely. We are completely wrapped up in the disease, who we become as an adult. And I didn't realize it until I managed to survive the disease, so to speak. I grew up with a father who is or was a socialite, but very, very popular, outgoing. And I just always envied him. Like, why can't I be like he was like the life of the party? As soon as he walked into a room, everyone just stopped. And it was just, I'm like, man, I would love to be like that one day. But I was the complete opposite. I found solace in video games, staying at home on the computer, learning how to code, which I do enjoy, but I've come to realize those were the only things I could do to make sure I don't exacerbate my disease and get into crisis even more. So instead of going out and having fun like my friends used to, I would stay home and play video games. And that became who I was, because that's all I did. And post-transplant, as I started to kind of explore life a little bit more because I had the ability to, I'm like, oh, I'm not as a shy individual as much as I thought I would, that I can actually have a conversation and not be ashamed or worried that what I'm going to say or how I'm going to look. And I didn't come to this realization until after I had had the transplant and I had the ability to do all these things, and I come to realize, oh, I actually also, similar to like my father, I like being outside. I like socializing. I can now do both. I now consider myself an ambivert, because I grew up being an introvert because of the disease. And now that I don't have the disease like I used to, I can go out and be more of an extrovert. So I find the perfect balance in the middle.
Do you think the unpredictability of sickle cell disease, where you could go out and be talking to somebody and then all of a sudden be sick, what do you think that really fed into that whole?
I think that definitely played a role. Um, that happened in my experience multiple times. Literally one day in a dog park with your dog, the weather is nice out. You're having friends with you're having fun with other friends who have dogs, and all of a sudden you start like riling in pain. Yeah, it's actually quite embarrassing. So that's, to your point, why you don't want to engage in social activities, because there is an element of embarrassment attached to it. When everyone all of a sudden having to need your friends to just care for you randomly out of nowhere. Um, and just that unpredictability, like I don't know what's going to happen today if I go out. It's very, very anxiety ridden life living with sickle cell disease like that.
Yeah, I just know I feel like I'm already wild now. If I got gene therapy, you guys might not see me anymore. Like I might I might have a mugshot somewhere. No, I'm playing. But it's so interesting. How I guess what other realizations did you have post-transplant that, like and you're I'm so glad that you underwent it just for the sheer fact that you're very self-aware and and not something everybody has, right? But you're able to compare and contrast that. And, I think some people may not go that deep with this, but I feel like you're the perfect person to ask, like, what else can you compare and contrast, between your
Yeah.
life before and your life after?
With sickle cell disease, I was very, very ashamed of myself. I had like zero confidence. My confidence was in the gutter, absolutely in the gutter. There's this famous line by Matthew McConaughey, where someone comes and asks him and goes to Matthew, "You're so full of yourself." And he responds like, "Who else am I supposed to be full of?" You know, and what I've come to realize post-transplant is I wish more warriors had the opportunity to be full of themselves. It's such a liberating experience for living 35 years with like absolutely zero confidence. And you obviously you know why. For me, not just looks, just everything. I was very inconsistent because of the disease. I had yellow eyes, I was skinny. I just had zero confidence. And post-transplant, the confidence I have now, because I'm able to follow through and I look healthy, and it's not that alone, the realization that how little confidence and how it literally affected my life aside from the disease was stark.
Wow. So when you said that, I was like, oh, instead of being full of yourself, you're full of sickle cell, right?
That's true,
The
yeah.
sickle cell is what you're full of and to your point, it can be very, very liberating. And we have a conversation, I think it was last December, and I asked you, do you think I would be a good candidate, for gene therapy? And I liked asking, people who I feel seen by, right? And, that I feel understand me as a person. And you said yes, but additionally, you've said gene therapy isn't for everybody. So can you kind of explain in your own way of thinking about this, who gene therapy is for and who it might not be for?
Yeah. Before I say anything, I should say living with sickle cell disease, regardless of how severe, is, in my opinion, still terrible. You know, no matter if you get
I know why
crises.
you're saying that too. Sorry, because a lot of us say we're fine. We're fine.
Yes.
We're fine. Like that pain, oh, it's fine.
Yeah.
The tiredness, oh, we're fine. So sorry, I
Yeah.
I, I just
No,
want to
no,
say I know where
exactly.
that's coming from.
Exactly. But what all of you that say that is you haven't experienced what it's like not to have that. You're so comfortable with that. It's become the status quo in your life that you think getting a crisis once a month is okay. How mad is that? That's not okay, in my opinion. Within the context of your life, you might have gotten used to it. And now it's normal, and like I said, it's the status quo, but people shouldn't have to live like that. You shouldn't have to live with your organs in jeopardy any time you go out to get acute chest syndrome, no matter how staggered they may be. It's still a terrible way to live. That being said, like you said, I don't think gene therapy is right for everyone. I think there are individuals who still, despite everything I've said, do not have it severely enough where they need an intervention as invasive as gene therapy the way it is right now. Um, Also, just age. I think there are so many people that if they go through gene therapy at this stage, in my opinion, the patient experience is not where it should be, which, they say pioneers get slaughtered. We're still at that stage where we're figuring out how to make it a lot more compatible. So I would not recommend gene therapy for anyone over 45 or 50. I just think there's so much, particularly with the conditioning regimen. Busulfan itself alone, I don't know if you've seen in every clinical trial that we've had for gene therapy for sickle cell disease, there's been a fatality that you can link to the conditioning regimen. So that's why I think a lot of people, in my opinion, should not depending on your other comorbidities, that I don't think gene therapy is the answer for you. Also, you know, being of African heritage, family is huge. Um, People put so much value in that. And right now we haven't done a great job as to making sure that the gene therapy that we're going to administer to patients or warriors, that we're not we're not properly figured out to make sure that they're not going to be infertile forever. Fertility preservation is not standard of care yet. We're still fighting tooth and nail to make sure that women in particular, we can give them that option when the time is right for them. And yeah, there are unfortunately, I'm sure we all know what happened with Fulcrum Therapeutics, but there are other, and hopefully there'll be more ways to induce fetal hemoglobin for patients who are not critically ill or are not I lived in the hospital. My sickle cell disease was horrible, and I was very, very close to giving up. At this point I was desperate, as I was on the cusp of becoming a father. So I felt it was perfect for me, and I didn't have a match, you know. And I think that's the ideal candidate. Individuals that are severely ill, really, really close to death or at death's door, life hanging in the balance, don't have a match, and need an intervention as quickly as possible. I think that's about 20,000, maybe even less, Americans living with sickle cell disease.
Did you have many like chronic complications like lung disease, heart disease, or anything like that?
I had it all. Cardiac arrest, pulmonary embolisms,
Oh,
acute chest
wow.
syndrome. My gallbladder has been taken out. Managed to keep my spleen by 7 hours. Is the whole 9 yards.
And I'm just thinking from the doctor perspective. So I mean, the chemotherapy, like you say, is not a piece of cake, sort of. And how do you think doctors should go about, it's a limited, only everybody is not going to get stem cell therapy or gene therapy. So what do you think doctors should do because we decide, right? What do you
Yeah.
think we should do to make sure that the person who's going to get this really advanced therapy, their life is going to be transformed? How should we go about finding those people who will do the best, who will really, I mean, I don't know you, but it seems like you are a person who really benefited and um, pretty exceptional. How should we go about finding the few people that we're able to do? I mean, we can only maybe do 100 people a year in this country with all the medicine that we have.
Yeah. I think that we haven't done a great job disseminating the patient, also provider educational information about gene therapy. I know we're creating a lot of them, but we're not disseminating as effectively as we should. Um, in major cities, I'm sure most people would have heard of gene therapy in the LAs and the New York cities of the world. But in remote areas where patients have to like travel an hour for a hematologist, those patients still don't know gene therapy. Even here, I met someone in March who literally cried to me. She has two children with sickle cell disease here in Atlanta, and it was a public event. It was this event I was speaking at, and she was just shocked that her providers never told her that her sons could be eligible for gene therapy in the hospital system that she's in. And she just
Yeah.
started bawling, like, how can they not? So I don't think it's anyone's fault. I think it's the system that we have. It's just the system is not built for gene therapy, at least not yet. We're working towards building that system where we're educating enough people um, to, in fact, know about this. I suspect that patients would be the ones to come to you and how to identify the right one. It's a really, really tough question because that's I think first of all, if you cannot, if the individual is in a really severe place or has a really severe case of the disease and does not have any options in terms of a bone marrow transplant or a haplo, that would probably be where I start. Like, listen, we can use your own stem cells. So that and you don't have access to any other type of stem cells, I would probably put you in front of the line.
Right.
So, Jimmy, what do you think is something nobody's talking about when it comes to gene therapy that you have insight on?
How long do we have? Um,
Well, we got 30 minutes.
there's so many. There's so many. I mean, let's start with the fact that we're using a weapon of war to kill stem cells. 75 years ago, we dropped a bomb in Japan, and in towns outside of where the bomb dropped, they found out that we were killing people's stem cells inside instead of killing them directly. That's how chemotherapy was invented. And there is actually
I did not
technology.
know that at all.
Yeah.
Wow.
And that's 75 years ago. The science has come so far now where we know we can actually just target stem cells. We can just target CD34 cells and not have to destroy everything for gene therapy. But no one wants to do that research because we're not sure if it's a technology we can monetize or not. So that's one problem. Number two, let's start with the gene therapy for sickle cell disease in particular, that the data that we have on gene therapy is based off of white and Asian men. That's why we can't figure out many things about why this patient gets collected because we don't have data on the African population. I might be wrong on this number. I think it's been 20 years since the Human Genome Project, yet only 20% of the African genome has been sequenced till this day. And we're doing gene therapy on a disease that massively affects people of color. And their sequence and their DNA is not the dominant one in the data set that we have. So there's so many problems with it, despite the fact that we're still able to imagine, look how efficacious it is right now with the problems that I've just mentioned. Imagine if we start to fix that, even how much better it can get. Also, the healthcare system, the fact that, a lot of people say, well, let's try and figure out how to decrease the cost of gene therapies. And, they start picking away at the cost of goods. The cost of goods of a gene therapy is never going to go down because we live in a system. We have a system here in the US that's value based. So the price is set off of the value it provides to the individual. So no matter how you try and decrease the cost through the line items, your reagents, the nucleus, it's still going to be $2.3 million. So that one, it's just a system in its own. So there's so many things that people don't realize in regards to gene therapy um, that we could fix. And to be fair, we are fixing, but it's going to take a while.
Very interesting. I haven't heard any of this stuff, so I definitely need to have more conversations surrounding a lot of this stuff. Um, is there a moment where you were like, yeah, I am going to undergo this, and you felt sure of yourself, and were you ever 100% sure of your decision, or was it always something where it felt like, shoot, I don't know what I'm gonna do, or I don't know how sure I feel about this.
Yeah. For me, I was 100% sure. I'd gotten to a point where I was like quite desperate at this point. And like I said, it was right where I was about to become a father. And for me, sickle cell disease had like won every battle in life. Like school, couldn't go to school, my career path that I wanted, that was flushed down the toilet as well, just everything. And this particular battle with fatherhood was one that I desperately wanted to win. And it was quite serendipitous that a gene therapy was available. Right. I was about to become a father in a month time, and this gene therapy was available. So yes, I was 100% sure, 100% sure, and I was just like, this is time for me to, this is going to be my feather in the cap, you know. I don't know if you have, I have always had this feeling where every day I'll just look in the mirror and you ever just wonder that you could be more. I lived like that for like 35 years, waking up, I'm like, man, you could be so much more. And, when I had the opportunity, thanks to the fact that I was about to become a father, I'm like, I am not letting this slip.
Yeah, that's definitely an experience I have. And I have it as like it's not even in regards to gene therapy. Like I know I hadn't I know I feel really good on a blood transfusion, and I've seen that I can
Oh,
do more on a blood transfusion.
yeah.
So, so when I'm not on a blood transfusion, like now I'm like you can do more. You can do more. Do you think people have to be at 100% to make this decision?
You mean like, what do you mean 100%?
100% sure, like within
Oh,
themselves, or do you think there is room
nah,
for that
I think there's
uncertainty?
room. Yeah, and I think that's healthy too. I think it's fair to think about it and not be 100% sure. I think you can give yourself that flexibility and question if this might be the right decision for me. The important thing is making a decision. At some point, you're going to have to make a decision depending on how bad or where you're at with this disease. I'm guessing if you're contemplating having a gene therapy, you're not in great shape. So just, yeah, absolutely. I think there's room. Just don't take too much time deciding.
Yeah. And I guess before starting the process with the gene therapy, what's something you wish you heard or you wish you knew before starting it?
Yeah, that's a great question. Before starting it, I wish I had taken my time. I wish I was a bit more patient. But then again, I was 2 months from aging out. Uh, I didn't know as much as I know now about gene therapy. I didn't even know there was an industry called cell and gene therapy. I didn't know they were already doing this in cancer. It was completely new to me, and I wish I gave myself more time and maybe even age out of that specific clinical trial and get something that's commercial. If my hemoglobin is quite high, and I've said this publicly, and I don't mind sharing. I grew up on my hemoglobin count being like a 6, and I'll get transfused at like a 5. And now my average hemoglobin is like 16, sometimes 17.7. They actually have to phlebotomize me. And then I wonder, imagine if I got the base edit, which the data shows it even gives you higher levels of hemoglobin. What would life be like if I had a 21 hemoglobin? How, while that is actually not great to have that high of hemoglobin, but I am like you, crazy in many ways where I want to
I
know
was
what it
gonna say,
feels
I don't
like.
think you're supposed to have that high of a hemoglobin.
Yeah, I want to know what it feels like, how high,
Right.
after living
It
at a
reminds me of like
6.
Limitless, or that movie.
Yeah, yeah. I want to know what that feels like. I'm like, I get upset when they want to phlebotomize me. I'm like, man, no, I want it. I like it. Keep it. I want to keep it. So yeah, that would be it. I wish I was a bit more patient.
Yeah, yeah. No, that makes sense. Um, how else have you changed? We talk about you climbing Mount Kilimanjaro. I think you've even done marathons. So, you feel the change physically, and then you feel a change through your identity. What other ways are you experiencing change post-transplant?
Man, that's a loaded question, Cass. Um, I will say this, and this has been my experience. So I'm not going to um, expect this might happen to other people, but I will say that your new life is going to cost you your old one. And it's actually going to be better. You're not going to know that for like the first couple of years. You're going to actually wish you had your old life back. And after going through it and this new life, having it for 2, 3, 4 years, you're going to come to realize that this new life is actually better. It's going to be a painful transition. It was for me. But you're going to realize that this is better. Like everything, every single thing has changed. So that's why I said, like, I don't think there is, I think maybe just my name. That's probably the only remnants
Wow.
of the old Jimmy.
Your name is crazy. That's it?
That's it. Everything else has changed, like everything.
Wow.
That sounds scary to me. I'm sorry.
To be fair, I moved pretty quickly. I
Yeah.
was making up for lost time. That's another thing that I've found, that, and I would call it a problem, maybe for me, is, for living with sickle cell disease for 35 years and not being able to do what you want once you have the opportunity to do it. I constantly have this feeling of like I'm still trying to make up for lost time. And sometimes I take on too much because of it. And it can be quite exhausting because everything I didn't do in 35 years, I've fit into 5 years. I've made so many mistakes, which has been fantastic. I think that's one of the biggest mistakes people make is trying to avoid mistakes. So just making mistakes, failing, really failing a lot. But with the way the mathematic works out, the
Because you
more
can
you
afford to
fail.
fail.
Yeah, exactly. So it's been good.
Yeah. Oh, I think I lost you or your audio.
Can you hear me now?
Can hear you
Yeah.
now.
Yeah.
All right.
I didn't hear the last part of that.
I don't know. I can't remember what I said.
Okay. You
Sorry.
you mentioned you mentioned I can talk to Jimmy all like y'all this for the rest of the day. I'm gonna be
We
talking
do
to
this all the
Jimmy.
time.
You mentioned that at the very beginning of this process, there's a part of you that missed your old life. What did you miss about it?
Oh, I miss the comfort. It's crazy to say. I miss Netflix and chilling. I was the king of Netflix and chilling before Netflix and chilling became a thing because that's the only thing I could do. All I did was just sit on the couch and watch TV. And like I said, I'm the type of person who tends to go, and I have the energy to, thanks to my high levels of hemoglobin. So I'm just go all the time now. And sometimes I'm like, man, I miss the days where I could just sit on the couch and watch TV and someone caters to me, asking me, how do you feel? I miss the, are you okay? As much as I used to hate it, people asking me, are you okay 100 times a day? Now no one asks me if I'm okay anymore. I miss that, you know? But I obviously realize that it's a good thing that no one asks if I'm okay. But it's those little subtle things about gene
Mhm.
therapy and living with sickle cell disease that can be kind of complex that you don't even realize. That was, for me, actually how I felt people loved me when they asked, am I okay?
Hmm.
And there was a time where, and there's been a time when no one's asking me, am I okay anymore? And I kind of took it as no one loves me anymore. Obviously, that's not the case.
Yeah.
Um, but that's how I felt.
Yeah. And I guess did sickle cell ever provide you with a comfort where, you're Netflix and chilling and you're like, it's okay to Netflix and chill because
Exactly.
I have a hemoglobin of 6 right now,
Yeah,
right? And I'm
yeah,
doing great,
yeah, yeah,
Yeah.
exactly.
So it's there's I guess a comfort to sickle cell that you had that you no longer have. A lot of times people can fall back on sickle cell as an excuse, rightfully so, because it is a major disability in life.
Yeah,
So when you remove that disability, what do you fall back on? Is
yeah.
that, did I get that right, or is that kind of how you were feeling?
No, that's absolutely it. You know, um, just it was seeking comfort in the disability, like you said, something that I think you hit the nail on the head. Like when I'll have a hard day, when I was in the throes of the disease, I'm just like, I'm just gonna go lay in bed, man. Like I have sickle cell disease. This shit's hard, bro. You know?
Yeah.
And now I can't do that. I can't use that as an excuse anymore.
You can find another one though, right? I underwent gene therapy. Let me rest.
Let me rest, man. My hemoglobin's too high. I've been running around all day. Let me rest.
Yeah, me as a person, I will find a justification.
Uh,
Um, so I kind of want to bring in our next person a little bit earlier, Jimmy, if you don't mind. And you,
right.
I don't know if you know our next person. Her name is Amy Cohen, but she was in the news and she made headlines for running a 5K marathon with sickle cell disease. And so you're doing this after sickle cell disease. She's doing this like with sickle
Yeah,
cell disease.
that's massive.
And so I kind of want to see the crossover. And I know you ran a marathon and um, yeah, I kind of just want to see, just have a conversation between all of us, if you don't mind.
That'd be awesome.
All right, so I'm gonna go ahead and add her.
Okay. Actually, I have to take off, so
Okay.
I'm being called out.
Thanks. Thanks for being here,
Really,
Dr. Q.
Jimmy, you are great. You should
Oh,
write
it's
a
good to meet
book.
you.
No, I'm
Thank
serious.
you.
He does.
It's like a person who turned into a different person.
Yeah.
Yeah.
It's really fascinating.
Thank
Nice
you. It's good
seeing
to
you.
meet you. Likewise.
Hope we can meet in person one of these days.
That'll be
Always
awesome.
great.
Yeah. Okay. Bye-bye.
Bye.
Bye. All right. So let me go ahead and add Amy here. Give a bio. Hi, Amy. We cannot hear you and we cannot see you in case you are wondering. Oh, oh,
Hello. Hi. I'm so sorry.
hello.
about-
Hi, how are you? Happy World Sickle Cell Day.
Happy World Sickle Cell Day.
Hi, Jimmy.
Hi. Good to exchanged emails, but good to see. I don't want to say in person because obviously we're not in person, but good to meet you kind of in person.
Yeah, definitely, definitely. And congratulations on your marathon.
Thank you.
I was gonna say, so I,
Likewise.
I pulled you in a little bit early because I wanted us to, and then there's somebody in the comments that said I have run a 5K with sickle cell disease as well. What are you guys doing? Like, what am I missing here? I can barely take on a flight of stairs. Like, anyways, before we get into that, I want to introduce our audience to Amy Cohen. And Amy, so wonderful to see you face to face as well. And hopefully we get to meet in person.
Oh,
Um,
definitely.
and I'm going to read a bio about you. Amy Cohen is a public health professional, patient engagement strategist, and the founder of The Patient Room. In November of 2025, she became the first person with sickle cell anemia to complete a marathon, finishing the New York Marathon as part of the NYPR or NYRR's Team Inspire. She has also used her platform to challenge old assumptions that people with sickle cell disease can't engage in strenuous physical activity, showing other sickle cell warriors what's possible with proper guidance and care. So you guys are phenomenal. And then whoever's on in the comments saying you ran a 5K, we need to get you on here somehow too. How are you guys doing it? What is the secret?
You gotta start from somewhere.
You gotta start from somewhere. And I wanted to ask you, do you have SS or do you have sickle beta? Because I
I
think I've seen two different things, but I didn't know.
I have S beta plus.
Okay, you have S beta plus. Okay. A lot of times within the media, people, and I think this is just a technical thing. Sickle cell anemia, I think, is technically SS and S beta 0. And
Mhm.
so, do you say you have sickle cell anemia, or is that just misquoted, or is that
I just have sickle cell anemia, but like engaging
okay?
more in the space, I realize like I need to be more specific in terms of which genotype I do have. But like, I mean, to me, it's like, yes, different genotypes, but like still all the same, still have a sickle cell diagnosis. But like for some people, they just really want to know for whatever
Yeah.
reason.
Yeah, no, no, that's it's really good to know, just to level set people. So, what does your sickle cell look like, on a day to day? And I don't want us to like limit to genotype because sickle cell presents differently in every person, regardless of genotype. You could have two people, like for example, me and my sister were both SS on paper, and
Mhm.
then we have this weird thing that's where it's like single gene deletion alpha thalassemia trait, but present completely differently. Like I haven't been hospitalized since my trip to Indonesia in 2017.
Look at
Um, so
you.
I'm coming up on 10 years without being hospitalized. But then my sister, she is, on chronic transfusion and she gets hospitalized often. And so even within on paper with the same exact genotype, you see such a difference. So what is your sickle cell like?
Yeah, definitely. Very similar to you. I have like long stretches of like crises. Like this April was like 3 years since my last crisis. So even with that,
Wow.
like I just know that I have to pace myself one, but also really pay attention to like my health and wellness. Like I can't just like eat anything because like there's some things that will like trigger a crisis. I live in the Northeast now, so I have to be careful and mindful of like the cold weather, wearing a jacket and all the layers in the winter time. And this winter was like horrible, but I made it. So
Yes.
just being mindful of just like again my environment, and just mindful in general of just things that could potentially like trigger a crisis. But how sickle cell presents for me, it's mainly just pain crises. Like the only time like I experience like any type of like thing from sickle cell is like when I have a pain crisis and like if it progresses to the point where I can't handle it at home, I'll definitely go to the hospital. But it is pretty manageable from home. And another thing with the health and wellness thing is just like staying hydrated because with the marathon training, like that was the biggest thing, like staying hydrated and making sure I'm getting enough rest in between runs.
Wow. Okay. So I want to hear from both of you how you prepared for a marathon because I think this is just even a crazy thing, um, just for the average person. But undergoing gene therapy and having sickle cell, what does prep look like, and how do you guys work your way up to being able to do that?
I should say that Amy and the individual in the comments, their achievement is, I think, well, I know, should be celebrated way more than mine because I was actually cheating. Um, with, yeah, they don't have hemoglobin F, at least to my knowledge. So if you research, hemoglobin F has a higher affinity to hold oxygen. because that's what we use to breathe while we're in utero. So it has to be actually stronger than A, which it is. So for me, that's why climbing mountains, running marathons it was obviously extremely difficult, but I'm able to handle it because I have like 40%, if not 45% hemoglobin F running through me. And I used to make this joke that I wish I was, or I wish the gene editing, there was some type of Batman or Spider-Man-esque accident where they accidentally edit something and get some type of superpower. But I do feel like the fact that I have hemoglobin F, 50%, almost 50% hemoglobin F is a superpower. And that's why I'm able to do this. And to your question, to your specific question as to the marathon, it was just first of all, I'd been quite physically active from training from Kilimanjaro. So it was just adding to that to continue to train. And, I was quite steadfast with my training. I made sure I trained as much as possible before I actually went to London. I tried to do 20 miles here in the US, I think, which I accomplished. And the rest of it was just kind of following the process.
Amazing. What about you, Amy? First of all, what put the idea in your head to want to pursue this?
Yeah, it's so funny. We used to watch Oprah a lot growing up, and I remember like on one show, Oprah was talking about her experience like running a marathon in DC. And I thought that was so cool, like a Black woman running a marathon. I grew up in Houston, Texas, which is like super hot, so we didn't have like a running culture. I still thought it was cool, like, wow, look at Oprah running a marathon. And I said, like, I want to do it too, but like no marathon activity in Houston. And then I moved to New York for grad school. And I thought a little bit about running the marathon, but like school obviously came first. And then the pandemic happened. So nobody was doing, well, people were running. um, it wasn't the space where I could run from scratch. But then I eventually like moved to Massachusetts and I got in touch with like Dr. Czar and his wonderful team. And they pretty much had a system set up to where I could go in and pursue that because we have a wonderful exercise specialist named Jen who the marathon we ran together was her 82nd marathon. So she was the perfect person to run with. But in terms of that whole process, like from the initial like intake process to running the marathon, it was about a 3-year process. So initially I wanted to run the New York City Marathon in like 2023, but unfortunately we didn't get in. So what we did instead was we ran the Boston half. And I think that was the best starting point. And I was getting ahead of myself if I were to run the marathon because that was like really hard in of itself. And I didn't really have a running background. I was starting from scratch. Like I was getting winded. I still get winded walking up the stairs, but it was just like a continuous like building that muscle to getting to, running that like 1 mile, 2 mile, 5 mile, 10 mile, 20 miles, 26 miles. So it was a gradual process for sure, but it definitely took time. And like for anyone who wants to run a marathon or strength train or anything, like it does take time. And I think that's one of the things that people should keep in mind and also give themselves some grace about because like I hate saying like we're not normal, like we're alien or something, but like it takes us a bit longer and that's okay.
Yeah, I don't think people really envision the years it actually takes to prepare for something like that. And so thank you for saying that because that kind of helps level set
Yeah.
from my end because yeah, it's not an overnight thing. You gotta train for that. Of course you do, right?
Definitely. And I think like in this process, like comparisons the thief of joy, because on Theme Inspired, there are people that, started their marathon prep like 3 months beforehand, a couple months beforehand, but like it took me years. But I mean, we're all there. So to me, it doesn't really matter how long it takes as long as I get there. Most importantly, finishing and not having to go to the hospital.
Amen. Amen to that. And I know, Jimmy, we have you slated for an hour, so feel free to hop off whenever you need to hop off.
Right.
But
This was
yeah,
awesome. I will hop off now. I'm on daddy duty.
Ooh.
absolutely. Thank you so much for being here, and I'm glad the three of us got to talk and talk about the crossover. You're amazing, Jimmy. You know that, and I we'll be in touch soon.
All right. Take care, everyone. Bye.
Have
All
a good
right.
one, Jimmy.
Bye, Amy.
Bye.
So I'm so excited to be talking to you today, Amy, because like I said, I followed your story and you are just an inspiration. You founded an organization. Tell me a little bit about the organization that you founded, the Patient Room.
Yeah, so the patient room was birthed from my experience working in clinical trials when I was working at Mass General, and it was a new domain for me, honestly, because like growing up, having crises, like of course I was like given the option to take hydroxyurea, and thankfully that worked for me, but I didn't really think much about the entire process of the pharmaceutical process and getting drugs on the shelves. And it's so funny because at one point I was a farm tech and I knew the process because that was a part of the certification, but I didn't really think in depth on that whole process. So working in that space and realizing that there's not that much information that's distributed to the average like person, and even like in the sickle cell space, like talking to my different friends and colleagues and peers about like what's going on, and they don't know what's going on, and we all live in Massachusetts, which is like the biotech pharmaceutical hub of the world. I felt like I needed to do something as someone like in that space to help bridge that gap, and most importantly build trust, because I feel like in the sickle cell space, like we're always looked at as like this primary like data set, in a sense. Like we're always like looked into, like people always ask some questions and then they like disappear. So I feel like there's not really much real investment in times, just because like I understand like there are timelines people need to get things like through for approval, but at the same time the humanization of the process is what I felt was missing. So I created the patient room just to help bridge that gap and just give patients as well as like industry like the space to meet and understand each other.
And how long have you been running your program or for your organization for?
It is coming up on a year in September.
Oh, congratulations. Congratulations. What is your favorite part of the work that you do?
Meeting all the different people, because I feel on both sides, like you can never learn everything. Like I learned so much about sickle cell, but even on the industry side, just learning about the ins and the outs of how things work, the drug process, the drug making process, and how like even how AI is being factored into this process.
Yeah, yeah. I have our other marathon person that they said they're from Texas too as well, and sounds like they got they did it as a group activity with somebody else. Um, who helped you train, or who did you train with? It's not a solo endeavor, or is it?
It was not a solo endeavor.
Okay.
Cool that I had Jen. So she's the exercise specialist with my hematologist, Dr. Zara at MGH. So she's very seasoned, very knowledgeable. So we started off with a plan. So she created a whole spreadsheet of how much I should run every week, how many days I should run.
Really?
So I did not have to think much about anything. I just went ahead and did my runs and then would check in on her. And we both had Strava. So she would just see my runs and we would check in from there. But to me, it was like very straightforward in terms of the running process and just being consistent with like my water intake and like nutrition and things like that.
Yeah. And do you know what your baseline hemoglobin is?
At the moment, no. Oh,
Okay, okay. I wondered, you didn't have to get transfused or anything to
no.
be able to do this?
No. Fortunately, I've never gotten a transfusion.
Okay.
Ever had to take like hydroxyurea,
That's
thankfully.
that's amazing. That's awesome. So it sounds like it was not just a long process, but it was a meticulous one. You went in with a plan and you had um I guess, an expert walking you through or guiding you through every step. Is that kind of representative of your experience with this?
Definitely.
Okay. And it sounds like you're just a fitness girl too.
I don't know
Is it safe
why.
to say you're a fitness girl or
Yeah, I was
not
literally last night. So
really?
always been a part of like my life. And I think it's part of the messaging that I got growing up because my hematologist growing up was always like very adamant on not trying to other myself in a sense, like not using sickle cell as like a reason not to participate because I didn't have a reason to because I didn't have my first crisis till I was 14. But I played volleyball, soccer, tennis, uh,
Wow.
strength training. So I'm very active and it just like to me, I feel like that attributes like why I can go on these long stretches without a crisis.
Yeah, I always felt for me that if I didn't have sickle cell, I'd be athletic, but you're kind of proving that you can still be athletic and have sickle cell. So now I need to be to take a closer look, and not that I'm gonna run a 5K, right? But it's definitely something that um providers do say we need to integrate within our lifestyle is some sort of exercise and you know getting your blood flowing and just having a healthy lifestyle when it comes to that. Does I guess your athleticism, does that go hand in hand with anything else? Like, are you kind of like a nutrition nut, if you will, or does that kind of play out in other parts of your life?
These days, no. I'm more like a balance, like I'll eat whatever I want type of
Oh,
gal.
okay.
It's so funny because my baseline is like I eat really healthy, but like I mean I'm gonna have my ice cream, I'm gonna have my dessert or whatever. I'm from the South, which they deep fry everything. So I'm gonna have what I want to eat, but like in moderation as well, because I can't go too hard, especially with, like oily foods, because it just like gives me like a wave of like fatigue, and I might as well like just go to bed for the night.
Yeah, no, that makes sense. That makes sense. So, what advice, if somebody wants to become a little bit more athletic and try something out like a sport. You said you played soccer, which is insane to me as well. But you're just that person where you're just going to break every barrier. Um, how do you start off? How do you start off with something like that?
I mean, you just start and start slow. And again, don't compare yourself to other people. Like, I am not the fastest. I'm not the strongest. I get winded really easily, but like, I mean, I know I need to take a break. And I have those boundaries like within myself and other people. Because at one point I was in CrossFit, and in CrossFit, like they try to like push you to do more weights, do more weights, do more weights. Now I tell the coaches like, no.
Yeah.
So definitely have to honestly just know your limits as a person, but definitely get started.
And what does getting started look like? Like, is it researching maybe to figure out what you can first do, and then I guess how do you know when you're reaching your limit or you're testing your limits, and how do you stay safe in this process?
Yeah. I mean, intuition. I think that's the biggest and strongest marker.
I love
Like when
that.
you feel like you're just winded or like you're really thirsty or you just need to take a break, just do it. Like don't feel the need to like push yourself to look a certain way or to present a certain way. And I mean, getting started, like it doesn't have to be like at the gym. It could just be walking around your neighborhood and seeing how you feel about that. And you run like a block or two blocks and then you add another block and then you get to maybe a half a mile, then a full mile, then you go from there. And maybe you want to jog one day, then you start jogging those couple of blocks and go from there. But it should be a gradual build. I
Yeah.
think like especially now that there's this like huge marathon culture and people are like comparing times and all this different stuff, like it's easy to get wrapped up in that, but that's just like not the most important thing. It's finishing, especially like if you have sickle cell, because my whole thing was running the marathon is like, I don't want to get sick during the marathon. So I had to like pace myself. Like I walked some. I did not run the whole marathon. I feel like that's like a misconception. Some people think like I blazed through the whole thing. It took me 6 hours. And I'm very proud of those 6 hours too. But I paced myself.
Thanks for saying that because I think I can walk, maybe. Like I'm good for walking.
And even when I started like the gym, I was just walking on the treadmill. Like it took me a while to like pick up a weight mainly because I didn't know what to do. But you got to start somewhere. Walk on a treadmill, walk on the Stairmaster, walk around your neighborhood because it can be intimidating. I'm not gonna lie, but you just have to know and feel comfortable with where you're at before you move on to that next level.
Yeah. And has any part of the process ever been like a trigger for pain crisis for you?
Oh yeah, definitely.
Really?
When I ran my first 20 miler, I thought I was gonna have a crisis right then
What
and
is it?
there.
That means you walked 20 or you ran 20 miles?
Uh,
Is that what a 20 miler is?
hmm It was an issue with my hydration because I was like just drinking water. I was drinking a gallon of water during that time. That wasn't sufficient enough, so I had to like switch over like straight
Okay.
Pedialyte.
Oh,
So it was
wow.
like 3 weeks of running, 4 weeks of just drinking like a whole thing of Pedialyte after I ran 20 miles. And even after the marathon, I remember the night before, I drank a thing of Pedialyte, not before bed, but like during the afternoon. And then right after the marathon, I had like another bottle like in the hotel, and I drank that afterward and just prayed for the best, and
Yeah.
it worked out.
Yeah. Yeah, I love how you're sharing how you've taken this huge um feat, if you will, and you've modified it to something that's attainable for you. And I don't know, so we a few years back we had our very first NBA player, Billy Garrett. I don't know if you I've heard of him, but he's out of Chicago and he played for the NBA and has sickle cell. I think he had type SC. And it's just so amazing what our bodies can still do. But, oftentimes growing up, we are told, hey, you cannot do this. But it's not, hey, you cannot do this. It's, hey, let's modify this so that it works for you. So what other ways have you, modified um, these types of feats so that you can still do it with sickle cell?
Yeah, I'm I'm just like a natural like blocker. Like I don't like to look at like the entire thing because even during the marathon process, I never thought about the 26.1. Like when I get there, I'm gonna get there. I was more so focused on like, okay, today's like Friday the 19th. I have to run 8 miles. That's what I'm focused on.
Mm.
So just blocking it and not don't look at the end because you'll get there if you do everything necessary on the steps toward getting there.
It sounds like a mental thing too. It's like you you have to be very strong mentally to do a lot of this stuff. So is there it sounds like you have like this mental fortitude where you just don't allow yourself to go there. Is that correct or does that sound right?
It is correct, but I think it's also just like something that a lot of us living with sickle cell have, like that mental toughness and resilience. Because a lot of us are doing amazing things. Like there's business owners, doctors, nurses, like so many people doing wonderful things, and it's not easy. So I feel like for us, like, yes, we're gonna go through what we go through, but as soon as we're done and we get better, we're gonna get back to it.
Yeah, yeah. Yeah, no, it's so amazing, just everything that you've achieved. And I guess you've done the 5K, what's next? Like, what is your next challenge? Because you seem like the person who likes a challenge and you're gonna keep challenging yourself. So what's next?
Okay, I don't know. A lot of people want me to run Boston, but like
Okay, you have to tell me
it's
what are like this is so outside of my world. You have to walk me through what is boss and what is like
no
explain
Boston.
the differences.
Okay, the Boston Marathon, it's in April.
Okay.
So it's like right at the alleged tail end of winter. It was really cold. So my whole thing is like I would have to train during the winter time, and this winter was like horrible. So I don't want to risk it, and I also don't want to run in snow. So that's like the hard part. And then someone was saying like, why don't you like go to Miami or something for 6 months? But that doesn't make sense because when I come back, I'm gonna be shocked by the cold. So
Yeah.
that's a giant question mark. There's a lot of people that are like, when you run it, let us know. So I will be letting the world know if that ever does happen. I don't know in terms of fitness goals or right now. I've just been taking it easy, getting back into the gym and just going from there. Yeah, I don't have any really big goals on right now for
Well,
fitness.
what about outside of fitness?
Hmm. Hmm. I mean, I do have a couple of like things that are like more private, but like when I'm ready to announce it, I will. But I mean, I'm just living life, and I feel like I'm still like reveling on the fact that I have so much free time now because I spent like the better part of last year training for a marathon. So we shall see, honestly.
Oh, I'm so excited to follow what's next. And I can tell you work in silence, and then when it's done, we can, celebrate and yeah, and that's the way I like to work as well. Yeah.
Oh, definitely.
Yeah. So I guess any kind of general advice that you have for the community, just as somebody who's just accomplished so much, and any, I guess, words of encouragement for the sickle cell community.
The biggest piece of advice I can give to any warrior
Mhm.
is give yourself grace. Like this is a tough disease, and I feel like, especially since it's an invisible illness, we tried to like say like it's not as serious or not as like complicated as it is. I've been there. And then like I go to like my hematologist, who's like, no, this is like a really serious like condition, even if you're not like in the hospital and things like that. Like it's very serious. So give yourself grace and honestly, take your time with things, like even outside of like fitness, just in life, like it takes people time, like even people who don't have sickle cell, it takes people time to get to, their goals. So I think that's what I would give to the community.
Give yourself grace. And are you good at giving yourself grace?
I really am, especially
Oh,
these
good.
days. Honestly, like it's just like I'm doing my best. And I feel like once you get into that whole thing of like, I did my best, I laid it all out, like it's just easier and easier. And plus, like, we deal with a really tough chronic illness. We really do. And we don't have like the support or infrastructure that we need. And in spite of that, a lot of us are still overcoming, excelling, and doing just amazing things. And I think that's something that we should all hold on to, just the amazing things warriors are able to achieve and accomplish in spite of whatever's going on in the world.
Yeah. No, I love that. Give yourself grace. I think a lot of us within the community, this is not you. Um, well, there we're kind of like say as I do, not as I say. Do as I say, not as I
Mhm.
do. That's why I asked you, are you good at giving yourself grace? Because a lot of us, we know what we're supposed to do, but when it comes to executing it, that's the hard part, especially when it comes to self-care and
Yeah.
just a lot of that stuff. So, um, Is there any particular ways
No,
that you celebrate when you have these types of achievements?
it's so interesting because I went back to work on Monday. So,
Okay,
um,
wow. That's amazing.
stop.
On to the next.
Like I did something like during the holiday season, but like I'm just like exactly on to the next. So there was a celebration. It just like it's so interesting that I was like, okay, I did this on because I am that person anyway.
Yeah,
But yeah.
yeah. Well, thank you so much for being here today. You are such an inspiration to us, and you've really widened my mind on what I really can. And you can use sickle cell to blame on some things. Are like, oh, I can't do that because of sickle cell. You're like, no, there's no excuse. It can be done, right? And obviously, I say this to with you or with people in mind and doing this with their provider, right? Because all sickle cell is not the same, and we talked about that, right? And integrating, whatever health issues you have and checking in with your provider. But, just seeing what you've accomplished is so amazing. And, it really is very inspirational to us. Hearing stories like yours really does provide hope for us, and it expands our what we think are limitations, and these limitations could be put on us from doctors or it could be put on us from family members or wherever, but to see stories like yours really really does break down those barriers of how we think about ourselves, and we really are resilient and we really are strong and can achieve a lot of these huge feats. So I appreciate you coming on and sharing your experience. Any parting words at all?
I want to touch on that point that you said about involving your doctor and your medical team because I've been getting some DMs like, oh, like, can you pass the exercise plan? I don't feel comfortable. I'm not
Yeah.
a doctor. I'm not a nutritionist. Not any. I'm not a clinician. So definitely engage with your doctor. And I feel like as this conversation of like exercise and sickle cell is starting to like gain traction, like they will eventually have to get on board. Because like I like share the same sentiment as you. Like when being younger, my mom was very opposed to me exercising because she grew up like in West Africa.
Are
And
you West African?
I'm African, I'm Ivorian and Malian.
You're what?
Ivorian and Malian, Cote d'Ivoire and
Oh,
Mali.
wow. Oh, that is awesome. I was rooting for your team. Yeah, are you following football?
Oh my gosh, I love that. Okay.
Oh, that's so awesome. I don't know if you know, I'm Nigerian, so hey, West Africans.
Okay. Are you
Oh,
Igbo or Euro?
I'm both. Yeah,
Best of
yeah.
both worlds.
Yes,
Oh, that's
yes.
amazing.
Oh,
Yeah, I grew up
well,
with Nigerians, in Texas, so I'm like very immersed into the culture.
oh yeah, you can't escape us over in Texas.
Yeah. Love-
Oh.
Oh my
Well,
God, I
thank
love
you so
Nigeria.
much for sharing your story, and I hope I get to meet you in person. Do you ever attend any of the sickle cell congresses or anything?
I need to start. Last year was just hectic. I know that there's one coming
Oh,
up in July, so
yeah.
we'll see. See.
Okay.
But where are you?
I'm in California, so I'm not too far. Are you in Dallas or Houston or Austin?
Girl, I live in Boston.
Oh, you're in Boston.
So we're not.
Okay, you grew up in Texas. Okay. Oh, so you're on the other side of the, okay. Well, I'm over there too,
We'll
so
figure. I'll
yeah. Oh, well,
have to
wonderful to
connect.
meet you. Thank you so much for
Oh,
having and
you as
taking the
well. Thank you.
time on World Sickle Cell Day, our second birthday. I call this our second birthday because, we deserve all the birthdays. Thank you so much for taking the time to share your experience and congratulations on everything that you achieved. Like I said, you really are an inspiration to the sickle cell community. So thank you.
Fine. Thank you. And thank you for providing a platform to just speak and just share our narratives. Because I love that, we're having the space like in a continuous space to share different stories and different facets of the experience. So thank you so much, Cass, for organizing this because this is amazing.
Oh, this was fun. I get more out of it than any of you guys possibly can. Like I'm just like taking it all in. So thank you. And hopefully we can collaborate in the future too. I'd love to do more with, your organization and your work. And yeah, this won't be our last conversation.
Definitely not.
All right. Well, take good care and have a wonderful Friday and happy World Sickle Cell Day.
Happy World Sickle Cell Day. You have a good one.
Thanks. You too.
All right. Bye.
Bye.
Yeah.
And then there was one. Thank you all so much for joining us today for World Sickle Cell Day for our Ask the Experts World Sickle Cell Day event. This was very, very informative for me. And I feel like I know a lot when it comes to sickle cell, but there's just so much you don't know about sickle cell, and it's you are a forever student when it comes to sickle cell, especially talking with all of these experts. And so I hope you all learned something new today or considered something in a different way or something might have clicked differently. That's the goal here, is really to provide you that information, and then you take that information and run with it and do what you want to do to better your life with sickle cell. So I appreciate you all taking the time today. Thank you. I see Nature for Children. Thank you. Thank you, Sian. Thank you on TikTok. This is our first time. How we do on TikTok? How did we do? This is our first time on TikTok today. Uh, if you are still online and if you'd like to do one more act of advocacy today. We do have a global survey that we put out. It's called the Our Voice Survey. We're hoping to gain global data from the sickle cell community. We have 50 countries, people from 50 different countries participating in this survey. And the goal of the survey is for us to be able to answer our own questions. There's a lot of times, as you heard on this live today, a lot of the experts said, I don't know. We simply don't know. And so, how do we get those answers? We take surveys, we take questionnaires, and I know they can be annoying. I know that they can be long. I can barely string my words together, guys. I'm like at capacity, I'm tapped out. But the last thing I'll say about this survey is please, please, if you can participate in it, it closes this Sunday, but the goal really is to be able to answer questions within the sickle cell community that we don't have answers to. That, if everybody kind of comes together and gives their input for this, we can finally have concrete answers and can finally deliver that data to the sickle cell community. So, we have the time. The link is in our bio. It's on our stories as well. And with that, I am going to sign off for World Sickle Cell Day. Thank you all so much for being here. Please enjoy your World Sickle Cell Day. Please celebrate. You deserve it. And it's Friday too on top of it. So enjoy your weekend ahead. And we will see you on the next Ask the Experts Live in 2 weeks. Thank you all.